صباح الخير دكتور أسد.
صباح الخير. Good morning دكتور.
دكتور أسد, your mic is muted. Can you open your mic?
Good morning, ladies and gentlemen.
Morning.
It is my pleasure today to start the third day of the IMDO conference. Today we will have very interesting topics, and we will start in time, hopefully. This session will be chaired by Dr. Said Rida, and also with Dr. Shaima. So basically, the first session, it will be followed by, again, multiple sessions and different topics. I will introduce Dr. Sayed. Dr. Sayed Rida is the consultant cardiologist, head of Department of Medicine, Wali Hospital, Kingdom of Bahrain, regional coordinator for medical education, Royal College of Physicians of Edinburgh, external examiner, Arabian Gulf Medical University, peer review author for various international medical journals, has published research and scientific work in various reputed journals. Dr. Sayed, the session for you. Please, you can start now to introduce the speakers and the time floor for you.
A very good morning to all. First of all, good morning, Dr. Asad, and thank you for the very kind introduction. The only thing I see now is the time is 9:51, where the session was supposed to start at 10 o'clock. Do you want to wait a few minutes or we want to start?
I think because of the time we will
Yes,
start
doctor,
exactly.
please.
But just to introduce Dr. Shaima,
Okay, no problem.
and then hopefully we will start in time.
Okay, so in the meantime, let me introduce, and maybe Dr. Shaima can make a small or slow start, I would say. So I would like to welcome my co-chair or moderator, and who is also the first speaker for this morning, Dr. Shaima Abdul Mahmood. She is a senior cardiac specialist, heart imager, and she's currently working at Shifa Al Jazeera Medical Hospital in Bahrain. She has MSc in cardiology from Ain Shams University in Egypt. She has worked and has got extensive experience as a specialist cardiologist. She has worked in adult cath lab units. She has worked in EP studies cath lab, and has also worked with patients with congenital and structural heart disease, and CCU, urgent ER, and non-invasive labs of, as well as invasive labs of echocardiography and stress cardiac unit. So the screen is yours whenever, Dr. Shaima, you're ready.
Good morning all, so much, and I hope inshallah successful conference as usual, and inshallah meet all next year, inshallah in gathering meetings, inshallah not virtually again. We will share our slides from the side there, please.
Yes, Dr. Shaima, we will start sharing.
Hello everyone, I'm Dr. Shaima Abdul Mahmoud El Sayed, MD Cardiology, Shifa Al Jazeera Medical Center in Manama, Bahrain. I am appreciating this elegant and this successful conference every year, IMDO. I'm happy to be a part in a scientific member and a speaker in the 5th IMDO. Today we will discuss about the cardiac events with diabetic patient.
Sorry to interrupt, Dr. Shaima, if I may request you to
the size of the problem of cardiovascular diseases. Then we will discuss about pathophysiology, type 2 diabetes mellitus as a major risk factor. Additional risk factors are common in diabetes mellitus. Cardiovascular disease is a significant global burden. It's account about 31 due to cardiovascular diseases, 7.4 million due to chronic heart disease, and 6.7 million due to stroke. So total global deaths in 2012 is around 56 million. Type 2 diabetes is increasingly prevalent, and the cardiovascular disease is a leading cause of death in this population. So we see here the global population, 387 million people are living with diabetics, and there is a risk factor for going to be more than rising 592 million by the 2035. So diabetic patient approximately doubles the risk of the cardiovascular deaths. As we see here from this figure, it's account relative risk for cardiovascular mortality in cardiovascular disease only 1.76. If it is combined with diabetes mellitus, is a relative risk will increase. All-cause mortality is 1.85. We will discuss now about the pathophysiology for the cardiovascular diseases. As we see here, there is in the organ damage like a stroke caused by disruption of the blood supply to the brain. Heart failure due to pump of the heart will be failed, and sometimes ejection fraction decrease or to be mild range, and may cause congestive heart failure. Coronary artery disease, disease of the blood vessels supplying the heart muscle, peripheral arterial disease, blood vessels supplying arms and legs. Endothelial dysfunction is a common to microvascular and macrovascular events, causing remodeling, hypertrophy, and causing myocardial infarction to the heart failure. And the remodeling of the plaque may cause peripheral arterial disease, TIA, stroke, aortic aneurysm, and microalbuminuria, mild or moderate insufficiency of the renal impairment, or overt proteinuria, and end-stage renal failure. Endothelial dysfunction drive atherosclerotic progression. So atherosclerosis is accelerated in type 2 diabetes mellitus by hyperglycemia and insulin resistance, inflammation, and diabetic dyslipidemia. This is visceral adiposity is related to inflammation, insulin resistance, dyslipidemia, and atherosclerosis interaction are complexes, interrelated, and not necessarily caused by. And obesity can cause decreased adiponectin, increased inflammatory cytokines, increasing with type 2 diabetes mellitus in insulin resistance, causing dyslipidemia, endothelial dysfunction, hypertension, age, and increased oxidative stress, increasing the atherosclerotic changes. So burden and pathophysiology of cardiovascular disease and type 2 diabetes mellitus is significant cause of morbidity, mortality globally, and in the leading cause of the death in people with type 2 diabetes mellitus. Type 2 diabetes mellitus is a major independent risk factor for cardiovascular diseases, and endothelial dysfunction affect microvascular and macrovascular risk, drive the atherosclerotic changes, and atherosclerosis is accelerated in diabetes mellitus with type 2 diabetes mellitus, visceral obesity, and is associated with increase in insulin resistance, inflammation, atherosclerosis, and dyslipidemia. Then we will discuss now about type 2 diabetes mellitus as a major risk factor. For it is doubles the risk of vascular events. As we see here, outcome of coronary heart disease will increase to the double, and causing coronary deaths and non-fatal MI. Also cerebrovascular diseases like ischemic stroke, hemorrhagic stroke, unclassified stroke, and other vascular deaths events like peripheral vascular diseases. Diabetes is associated with significant loss of life years. We will here compare a study between men and women and in non-cardiovascular deaths and vascular deaths. As we see on average of age of 50 years old with diabetic but no history of vascular disease is around 6 years younger at a time of death than a counterpart without diabetes. Life expectancy is reduced by multiple morbidities of diabetes, stroke, and MI as age and sex adjusted heart rate.
Yes, Dr. Asad.
Yeah, sorry, Dr. Sayed, for interruption. As the delegates requested to repeat the lecture, we will start from again because they request the lecture to be, most of them, they are requesting to attend at 10 o'clock.
Yeah, so, I think that's what I said. So we should wait. That's fine.
So if we can repeat the lecture.
Okay.
Ahmed.
So.
Okay, Dr. Sayed.
Oh, no problem. No problem. In that case, I'll start the introduction once again and
start from
the very beginning.
Thank you.
Hello, everyone. I'm Dr. Shaima Abdelmaboud El Sayed, MD Cardiology, Shifa Al Jazeera Medical Center in Manama, Bahrain. I am appreciating this elegant and this successful conference every year. IMDO. I'm happy to be a part in a scientific member and a speaker in the 5th IMDO. Today we will discuss about the cardiac events with diabetic patient. I'll share the slides. The size of the problem of cardiovascular diseases, then we will discuss about pathophysiology, type 2 diabetes mellitus as a major risk factor. Additional risk factors are common in diabetes mellitus. Cardiovascular disease is a significant global burden. It's account about 31 due to cardiovascular diseases, 7.4 million due to chronic heart disease, and 6.7 million due to stroke. So total global deaths in 2020 12 to is around 56 million. Type 2 diabetes is increasingly prevalent, and the cardiovascular disease is a leading cause of death in this population. So we see here the global population, 387 million people are living with diabetes, and there is a risk factor for going to be more than rising 592 million by the 2035. So diabetic patient approximately doubles the risk of the cardiovascular deaths. As we see here from this figure, it's account relative risk for cardiovascular mortality in cardiovascular diseases only 1.76. If it is combined with diabetes mellitus, is a relative risk will increase. All-cause mortality is 1.85. We will discuss now about the pathophysiology for the cardiovascular diseases. As we see here, there is in the organ damage like a stroke caused by disruption of the blood supply to the brain, heart failure due to pump of the heart will be failed, and sometimes ejection fraction decrease or to be mild range, and may cause congestive heart failure. Coronary artery disease, disease of the blood vessels supplying the heart muscle, peripheral arterial disease, blood vessels supplying arms and legs. Endothelial dysfunction is a common to microvascular and macrovascular events, causing remodeling, hypertrophy, and causing myocardial infarction to the heart failure, and the remodeling of the plaque may cause peripheral arterial disease, TIA, stroke, aortic aneurysm, and microalbuminuria, mild or moderate insufficiency of the renal impairment, or overt proteinuria, and end-stage renal failure. Endothelial dysfunction drive atherosclerotic progression. So atherosclerosis is accelerated in type 2 diabetes mellitus by hyperglycemia and insulin resistance, inflammation, and diabetic dyslipidemia. This is visceral adiposity is related to inflammation, insulin resistance, dyslipidemia, and atherosclerosis interaction are complexes, interrelated, and not necessarily caused by. And obesity can cause decreased adiponectin, increased inflammatory cytokines, increasing with type 2 diabetes mellitus in insulin resistance, causing dyslipidemia, endothelial dysfunction, hypertension, age, and increased oxidative stress, increasing the atherosclerotic changes. So burden and pathophysiology of cardiovascular disease and type 2 diabetes mellitus is significant cause of morbidity, mortality globally, and in the leading cause of the death in people with type 2 diabetes mellitus. Type 2 diabetes mellitus is a major independent risk factor for cardiovascular diseases, and endothelial dysfunction affect microvascular and macrovascular risk, drive the atherosclerotic changes, and atherosclerosis is accelerated in diabetes mellitus with type 2 diabetes mellitus, visceral obesity, and is associated with increased in insulin resistance, inflammation, atherosclerosis, and dyslipidemia. Then we will discuss now about type 2 diabetes mellitus as a major risk factor. For it is doubles the risk of vascular events. As we see here, outcome of coronary heart disease will increase to the double, and causing coronary deaths and non-fatal MI. Also cerebrovascular diseases like ischemic stroke, hemorrhagic stroke, unclassified stroke, and other vascular deaths events like peripheral vascular diseases. Diabetes is associated with significant loss of life years. We will here compare a study between men and women and in non-cardiovascular deaths and vascular deaths. As we see on average of age of 50 years old with diabetic but no history of vascular disease is around 6 years younger at a time of death than a counterpart without diabetes. Life expectancy is reduced by multiple morbidities of diabetes, stroke, and MI as age and sex adjusted heart rates for mortality by baseline disease status. As we see here, comparison between diabetes mellitus, stroke, and MI, diabetes and stroke, and diabetes and MI alone, stroke, diabetes, and none. Diabetes confirms the significant cardiovascular risk. Combination of diabetes and history of MI further increase the risk alone. And here also a chart is explaining how diabetes-related cardiovascular complications have declined with improved care, but substantial burden remain. So controlling cardiovascular diabetes patient is mandatory to can decrease the burden of the disease. Renal diseases is associated with increased all-cause mortality. If the patient is diabetic, hypertensive, hyperlipidemic, and cardiovascular disease, renal disease increase all-cause mortality. See, we here have the chart, previous MI, patient is around 35, diabetic and CKD, increasing the risk to 75. CKD with EGFR less than 60, it will be less than that. Remain again. I'll decrease again. This is as we see here again to this one is alone diabetes, this risk of all-cause mortality, and no other diabetic or CKD decrease risk. Type 2 diabetes needs to increase the cardiovascular risk. Diabetes doubles the risk of cardiovascular events and reduce life expectancy. Risk is further increased in patients with type 2 diabetes mellitus and cardiovascular disease. Incidence of type 2 diabetes mellitus related cardiovascular complications have declined with improved standard of care. So it is very important to go to the target. And however, rates remain higher than in adults with no diabetics, and rising incidence of type 2 diabetes mellitus will increase overall cause burden. And the combination of type 2 diabetes mellitus and the renal disease further increase the cardiovascular risk deaths. Additional risk factors are common in type 2 diabetes mellitus. So modifiable cardiovascular risk factors are common in patients with type 2 diabetes mellitus, like hyperglycemia, hypertension, dyslipidemia, obesity. Cardiovascular death is increased in patients with diabetes and multiple risk factors. As we see figure, diabetic alone and the non-diabetics, and there's a number risk of the age-adjusted cardiovascular deaths per 10,000 persons per year. Dysglycemia is an independent risk factor for adverse cardiovascular outcome. As we see here, a coronary heart disease and vascular disease. We see the dysglycemia and the uncontrollable patient will increase the risk for coronary heart disease and vascular disease. Hypertension also each 20 over 10 millimeter mercury pp increase doubles the risk of cardiovascular mortality. This is 8-fold. As we see here, though the target control for your patient, hypertension, hyperglycemia, obesity, everything of these comorbidities with diabetes will decrease to the cardiovascular mortality if we control the patient. Dyslipidemia increase LDL cholesterol, increase the risk of coronary heart disease. As we see here, it is a straight line. And dyslipidemia increase the LDL cholesterol and decrease the HDL are associated with raised risk of coronary heart disease. And abdominal obesity also is associated with increased risk for both diabetes and cardiovascular deaths. Additional risk factors in type 2 diabetes mellitus. Modifiable cardiovascular risk factors are common in patients with type 2 diabetes mellitus. Cardiovascular mortality is higher in patients with type 2 diabetes mellitus and multiple risk factors. So hyperglycemia is associated with non-linear increase in risk cardiovascular events and mortality. Hypertension lead to a non-linear increase in mortality. Increased LDL lead to a non-linear increase of the risk. And visceral obesity is associated for increased risk of diabetes and cardiovascular deaths both. And the summary is type 2 diabetes mellitus is a major independent risk factor for cardiovascular disease. Endothelial dysfunction and progression of the atherosclerosis is accelerated in patients with type 2 diabetes, and patients with diabetes mellitus are at significant increase in cardiovascular risk and additional risk factors associated with type 2 diabetes mellitus. So hypertension, dyslipidemia, visceral obesity, hyperglycemia, and renal dysfunction are all associated with further increased cardiovascular risk. Diabetes confers significance of cardiovascular death risk, and combination of diabetes and history of MI further increase risk. This study is comparing MI alone or stroke or cardiovascular risk with non-diabetic or no prior MI, diabetes prior MI alone, and diabetes plus prior MI alone. As we see here, in a prior MI, and diabetic patient and uncontrollable patient will increase the cardiovascular deaths. And thank you for all for this significant attention, and be happy for any question from the attendees. Thank you.
Thank you very much, Dr. Shaima, for this wonderful presentation and giving us an overview as to how diabetes can increase the cardiovascular morbidity and mortality. Now, since there is no question in the chat box, I'll just make a couple of comments. Now, as you know, that there has been a paradigm shift as to how we see diabetes and how it leads to cardiovascular complications. And that has also let us understand more as to how the pathophysiology is in how diabetes causes these cardiovascular complications. And that has led to development of new medications like GLP-1 agonists and SGLT2 inhibitors. Now, obviously, we recognize now it is not only the HbA1c or the tight glycemic control that is important, but there are some mechanisms we do not understand very well, unfortunately. But that is how these SGLT2 inhibitors, particularly, they have seen to improve the cardiovascular outcome in these patients. So any comments on that?
I have a question, Dr. Sayed.
Yeah, please, Dr. Sayed.
Yeah.
You want to
Thank
answer
you,
that
Dr.
question?
Shaima, for your nice presentation. It comes in my mind for our patients with diabetes. What is the best way to pick up these patients with ischemic heart disease earlier and get these patients, modifying their risk factors to at least announce them and refer them to the cardiologist?
Thank you, Doctor. Question. It's important question, really. My lecture today not about the recent guidelines or recent treatments for the diabetics, but it's only for figures, numbers, how it is important to the patient with diabetes mellitus to protect the endothelium of his organ, because there is 4 organ targets for him to protect. Patient with diabetes should be go to the target level. Don't hesitate to delay his numbers to be optimum for protection these 4 organs. So the main lecture for how to protect this endothelization for the target organ and protect them from that damage. The patient with cardiovascular diseases and diabetes, we should refer him to cardiology to go to the point. What is the disease of the heart? Is it chronic only like coronary heart disease or structural heart disease? And we can do like a team. And after that, to go for optimum HbA1c for him. If the patient is only cardiovascular, not diabetic, this patient, I should remain him as cardiovascular disease only. And if become diabetic, I should treat him aggressively to protect him from more vascular events, not only from the heart or coronary heart disease. He can develop also atherosclerotic for stroke or renal disease, or. So for your question specifically for the Dr. Asad, if the patient diabetic from the start and develop coronary heart disease or like heart failure disease, we should make a team how to deal with this patient earlier to protect this endothelization and protect the patient as taking the HbA1c to the optimum for this patient protection. Team is better than doctor alone. يعني not diabetology only. لا, better team like diabetology plus cardiology. Make the patient, your patient every 6 months, make echocardiogram, make ECG, check his heart. Beside your side treatment for optimization HbA1c.
Thank you, Dr. Sharma. And since I don't see any other question in the chat box, I'll perhaps make another comment since there's a little bit of time. The other factor we should not forget is that in diabetic patients particularly, yes, we look at the LDL, but we should not forget the non-HDL cholesterols,
Yes.
which also includes the ApoB and lipoprotein A. So these are independent risk markers for atherosclerotic disease in diabetic patients particularly. So any questions from the floor since we have time? If not, then perhaps we will move. And then I think it's my presentation next.
Thank you, doctor.
Thank you, Dr. Sharma. Thank you very much for your presentation.
Dr. Shaima, you want to present Dr. Said Raza today morning?
Sure.
Yalla.
Sure, doctor.
Yalla, thank you.
I'll introduce Dr. Said Raza is a consultant cardiologist. He is the consultant at Awali Hospital, Kingdom of Bahrain, regional coordinator for medical education, Royal College of Physicians, Edinburgh. Dr. Said will give us today an important lecture, sleep apnea and its impact on cardiovascular system. I love this topic and I have many patients for this. Usually I'm preferring to discuss this topic every year in IMDO. So I'm happy to hear this from Dr. Said Raza today. Welcome, doctor. The floor is yours.
Thank you very much, Dr. Sharma, for the very kind introduction. And I just want to confirm if you can still hear me.
Sure, we are hearing you, doctor.
Okay.
Yes,
great.
Dr. Raza, loud and clear.
Okay, thank you. So this morning I'm going to speak not only on sleep apnea, but mainly I'll focus on its impact on cardiovascular system. So sleep apnea is a common medical problem, but at the same time, it is not very often recognized. But once you recognize sleep apnea, and if you manage it well, then it can not only be a life-changing experience for the patients, but it can also be a life-saving experience. So in the next 20 minutes or so, I'll discuss and give you an overview as to what sleep apnea is. I will mainly focus on the cardiovascular complication burden in sleep apnea. I'll briefly discuss its pathophysiology, and I'll finish by discussing some of the management strategies in sleep apnea as to how you can elevate the complications, the cardiovascular complications related to sleep apnea. So sleep apnea is a condition in which a person will stop to breathe. There is cessation of breathing that happens several times during his or her sleep. And this is very frequent. It can be thousands of times that the patient will stop, either will stop to breathe completely or halfway through, which is called hypoapnea. And they will have extended pauses in breathing when they sleep. And once they stop to breathe, then the brain gets stimulated and they will start to hyperventilate. So this cycle will continue. They stop to breathe, then they hyperventilate, they stop to breathe, then they hyperventilate. And what happens is that when they stop to breathe, there is obviously a decrease in the oxygen supply to the brain and to the rest of the circulatory system and to the rest of the organs of the body. And obviously the person, if he or she does not sleep and wakes up several times subconsciously, then this is going to affect the sleep quality. and the person will wake up with a morning headache, feeling fatigued, very tired, and is very likely to sleep during the daytime. So what is the prevalence? So worldwide prevalence is there's more than 1 billion people who are affected by sleep apnea. And in United States, there are 18 million people suffering from sleep apnea. But the worst than that is at least 10 million, they go undiagnosed. And the incidence in men is 1 in 10. So it is more common, sorry, in 1 in 4. So it is more common in men compared to women, where the incidence is 1 in 10. And it is also more common in patients who are obese or carrying some extra weight, or if they are smokers. So mainly there are 3 types of sleep apnea. The first type, which is the commonest type and constitutes at least 80% of all sleep apneas, is obstructive sleep apnea. And then there's a central sleep apnea, and then a mixed type, which is called the complex sleep apnea. So in the obstructive sleep apnea, what happens, these are the patients who are overweight or obese. And here they have got muscles which are quite big. The muscle tissue is quite big, particularly in the throat, back of the tongue, and in the pharynx area. And when they sleep, obviously these muscles, they relax and they become a bit loose, and the tongue falls back, and all the loose muscles, they fall back and obstruct the airway. And it does not allow the oxygen or the air to pass through very well. And in the course of this, there's decrease in the oxygen that reaches the lungs, and obviously it reaches the less oxygen reaches the brain and to the rest of the organs of the body. In central sleep apnea, there's no obstruction. The airway is clear, and the oxygen can get through. But the problem is here in the central nervous system, which is the center for breathing. Now, if I ask you where is the center for breathing, center of breathing is in the brainstem and mainly in the medulla. So if this center of breathing is not stimulated enough, it does not provide a drive for breathing. And here again, the person or the patient will stop to breathe several times during the course of his or her sleep. Now, once you get a combination of this is called complex sleep apnea. Sleep apnea can affect every system of the body, but I'm mainly going to concentrate as to what impact it can have on the cardiovascular system. So first, let us understand what the pathophysiology is. Pathophysiology as to how sleep apnea causes cardiovascular complications is multifold, as well as it is complex. But it is down mainly to 3. Number 1 is hypoxia. Number 2, negative intrathoracic pressure. And number 4, arousal that increases the sympathetic activity. So let's understand this a little bit in more detail as to what the pathophysiology is. So once the person has got sleep apnea, he or she is not getting enough oxygen. So there is hypoxia with or without increase in the carbon dioxide. And once there is decreased oxygen that is going to the system of the body, it leads to endothelial dysfunction in majority of the arteries, and that can lead to vasoconstriction and thrombosis and inflammation. And hypoxia can also lead to oxidative stress, and that can in turn lead to slow damage to the heart as well as the blood vessels. Hypoxia can lead to pulmonary vessel constriction, and that can lead to pulmonary artery hypertension, and that can be a cause for right ventricular overload and right heart failure. Because the patient wakes up several times during the sleep, this leads to what we call arousal, and that will lead to increase in sympathetic activity and parasympathetic withdrawal. And this would also lead to increase in the nervous hormones such as catecholamines, adrenaline and noradrenaline, they go up. And in addition, what goes up is the stress hormone cortisol. So these will bring about the changes that there will be increase in the blood pressure, there will be tachycardia, and they have adverse effect on the cardiac function. And in addition to that, when the person is obstructed, there's increase in the intrathoracic pressure that will cause increase in the preload and afterload to the heart. And in a way, it increases the left ventricular end diastolic pressure and can cause heart failure in these patients. So there's a wide range of cardiovascular complications that can happen in sleep apnea. It can start from simple as hypertension, and on the other end of the spectrum is something catastrophic and quite serious, is sudden cardiac death. And in between, patients may have arrhythmia, coronary artery disease. It increases the risk of stroke, pulmonary hypertension, and heart failure. So hypertension is very common in sleep apnea patients, and you will miss the diagnosis unless you don't check for the blood pressure, and particularly if you don't check it in a way where you can diagnose the blood pressure during the night, which is called nocturnal hypertension. Now, nearly half of the patients who have sleep apnea have got hypertension. So it is very important to check the blood pressure once you encounter a patient of sleep apnea. And blood pressure, these are not simple blood pressure to treat, and they will not respond usually to 1 or 2 medications. They will need 3 or 4 medications in combination. So if you feel that the blood pressure of a patient is not getting under control, and if the patient is particularly obese, and if you have a suspicion that this could be sleep apnea, then please investigate these patients and put them on the right therapy before you go on adding blood pressure tablets. And nocturnal hypertension is something that is seen with these patients. And how do we diagnose nocturnal hypertension? We put a monitor, which is 24-hour blood pressure monitoring device. So it can not only record the blood pressure during the daytime, but also during the night when the patient is sleeping. Because these patients, they wake up several times, there's arousal, there's increase in the catecholamines, as I said, and the blood pressure may be high only during the night and maybe normal during the day. And there's something called non-dippers. Normally, when you sleep, what happens? You relax. And when you relax, your blood pressure is likely to go down and be at a normal level. But in these patients, the blood pressure, instead of going down, it goes up. So these are called the non-dippers. And it has been recognized that non-dipper is actually an independent risk for cardiovascular mortality. Sleep apnea can also cause arrhythmia. However, we do not know the exact prevalence and the pathophysiology as to how this leads to arrhythmia. Bradyarrhythmia is more common. Sinus bradycardia is the commonest arrhythmia that you'll see with sleep apnea. Some of the others you'll see here that various degrees of AV blocks. Tachyarrhythmias in form of premature ventricular contractions, supraventricular tachycardia, and atrial fibrillation has been studied in more depth because it's a very common arrhythmia, and the risk of atrial fibrillation increases by 5-fold in patients of sleep apnea. But also it can lead to a more malignant arrhythmia like sustained and non-sustained ventricular tachycardia. So how do we manage antiarrhythmic? Do we give antiarrhythmic agent? No, because antiarrhythmic agent generally will not work unless there is a specific indication to use it. But we may use some specific targeted therapy if we know there is some electrical conduction abnormality. In the past, atrial overdrive pacing was used for supraventricular tachycardia, but this does not help, and therefore it is not anymore recommended. Sleep apnea does increase the risk of coronary artery disease by 30%. It increases the risk of a stroke by 60%. And atrial fibrillation, as I said, is a common factor that accompanies sleep apnea, and presence of atrial fibrillation itself increases the risk of stroke. Subarachnoid hemorrhage has also been found in these patients, and the incidence is high, and they also occur early. And it also leads to fatal, non-fatal MI. These are the patients that they are more likely to go undergo revascularization like PCI or coronary artery bypass surgery. Now, the problem is that, yes, they do occur in sleep apnea patients, but the other fact is that they occur early, and also they increase the risk of cardiovascular mortality. Sleep apnea and heart failure, they are interrelated. And what I mean by interrelated is if some patient has got sleep apnea, then there's a highest chance of him or her having heart failure. And if somebody has got heart failure, then there's a chance that this patient will also have sleep apnea, and particularly central type of sleep apnea. And it has been recognized that 50% of the heart failure patients will have some degree of central sleep apnea. And sleep apnea does increase the risk of heart failure by 140%. And who are the patients who will have a higher degree of central sleep apnea in heart failure? So these patients are usually elderly, above the age of 60. They are male patients, an advanced degree of heart failure like NYHA class 3 and 4. And for some unknown reason, we do not see central sleep apnea in female heart failure patients. So I mentioned earlier that sleep apnea can also lead to sudden cardiac death, and the risk of sudden cardiac death can increase by 300 to 400%. Now, it obviously will not occur in mild form of obstructive sleep apnea, but the severe form of sleep apnea these are the patients who may die suddenly during sleep, because severe hypoxia in these patients will stimulate a malignant ventricular arrhythmia, and the patients may actually die while they are still sleeping. Now, how about the survival depending on the severity of sleep apnea? Now, the severity of sleep apnea is studied with a sleep study or polysomnography, and these patients may be divided into 4 categories, and based on the apnea-hypopnea index, or simply AHI index. So if the AHI index is less than 5, they are normal. If the AHI index is between 5 and 14.9, and then they are called mild sleep apnea and obstructive sleep apnea. And if the index is between 15 to 29.9, they are moderate. And anything more than 30 AHI index is severe. Now, obviously, as you see in the graph here, higher the AHI index, lesser is the survival. And patients who have got lower AHI index tend to live longer. So let's talk about the management strategies. Now, the management strategy, if you are dealing with a patient of sleep apnea, then do not forget to advise the lifestyle changes. And out of the lot of lifestyle changes, the most important is the weight loss. And when I say weight loss, it is not the weight loss of 1, 2, or 5 kilograms. This patient must lose 10 kilograms, 15 kilograms, 20 kilograms of weight. And that is very important through exercise and a good dietary program. And in addition, the patients are advised not to smoke, not to drink alcohol, particularly when they're going to sleep, because and also to avoid some sedatives and painkillers that may have codeine or narcotics. So because they're going to relax the muscle when they sleep, and they will kind of exaggerate the problem further. CPAP is a machine which is continuous positive airway pressure machine. I'll talk in my next slide what it is. And then there is adaptive servo ventilation. And the adaptive servo ventilation has been used in patients of central sleep apnea. And what it does is that it will stimulate the center for breathing and will provide a drive for the breathing only when the patient stops to breathe. Otherwise, it will not trigger or function. And it is same like the demand pacemaker that we see in bradyarrhythmia. When the heart rate goes slow, then the pacemaker kicks in. So likewise, the adaptive servo ventilation works. If the patient stops to breathe, the machine gets a signal. It will give a stimulus to the brain, and the patient will start to breathe again. And some of the medications like theophylline, azithromycin, amphetamines, they have been tried, but the success has not been great. And so these medications are no more indicated. So CPAP is something what you look in the picture here. So it's a tight fitting mask that covers your nose and your mouth as well. And the patient can go to sleep. And usually it is required that they should have at least 8 hours or more of sleep with this to get the benefit of this CPAP. And this is attached to your tube that connects to a machine that provides pressure, that provides oxygen and the pressure, and that will open up the closed airway. And under this pressure, the oxygen can go more easily into the lungs and then to the rest of the system of the body. So CPAP, what it does, it alters reverses, not completely, but partially the pathophysiology of the sleep apnea itself. First of all, it increases the intrathoracic pressure and therefore decreases the preload and afterload to the heart. Now, this is the meta-analysis I just wanted to share. Sorry, it's not a very clear slide, but what actually it is going to look at whether the CPAP machine actually reduces the cardiovascular mortality. Now, this slide includes on the top some observational studies, and on the bottom they are randomized controlled trials. And as you can see here, there's a line drawn. Anything to the left favors the use of CPAP. That means they decrease the cardiovascular mortality. Anything on the right will say that it will favor the control. And as you can see here, that there is a benefit of using CPAP as far as the cardiovascular mortality is concerned. And all the observational studies and the RCTs, they prove the same. But the p-value, if you see, is not highly statistically significant. And that again proves that, yes, there is a benefit, but the benefit is very small in terms of improving cardiovascular outcome with these CPAP machines. Now, I'll finish with showing you just one study, which is the sleep apnea cardiovascular endpoint study, which is a SAFE study. And this study is from Australia. And this is, again, a multi-center study, international study. And some patients, they came from Australia, although the trial was initiated in Australia, and some from New Zealand, but majority of the patients, more than half of the patients, this study included about 2,700 patients. And as you can see here, 1,700 patients came from China alone. Some patients from India, some from Spain, Brazil, only 4 patients from USA. So what they were looking at as to whether the CPAP machine increases the cardiovascular outcome. And so they randomized these patients. They used to randomize 2,500 to either usual care or to receive CPAP on top of usual care. And these patients were followed up to 2.7 years, 2 to 7 years, and they had a follow-up at 1 month, 3 months, 6 months, and then 6 monthly thereafter. And what you can see here that in the beginning, the curves did not separate, so they did not find for the initial 2 years that there was any advantage of using CPAP on top of usual care. Then the curves started to diverge, and then there is a benefit. If you see the blue line, that represents the use of CPAP. The red line is the usual care, and the mortality or the incidence of cardiovascular events, they were less in patients of who use the CPAP. But what happens at the end, reaching 72 months, you see that the curves they meet. That means the whatever benefit they had was not enough. And if you look at the hazard ratio, is only 0.89. So again, it's not a very meaningful advantage or benefit with the use of CPAP that has been shown through this study. So you can say it's a kind of a mild positive or a neutral study to support the use of CPAP in this patient. But we know that the use of CPAP does bring about a significant change in the life of a patient. And in my personal experience, I have seen that CPAP can be a life-changing experience for these patients. They are more fresh, they look more active, and they are more alert. They can do things, they are not drowsy or sleepy, and it actually motivates them to do more exercise and follow a dietary pattern and so on. So it really helps. So to summarize, ladies and gentlemen, so sleep apnea does carry a high burden for cardiovascular complications, which I've just discussed, and can also lead to a variety of adverse cardiovascular events. And these cardiovascular complications must be recognized. And the whole idea is to recognize before that the patient is having sleep apnea, because if you do not recognize, then you may be treating the cardiovascular complications alone. But what you need to look at is the root cause of the problem, and that you must address. And applying the right management strategies can lead to not only a life-changing experience, but it can lead to a life-saving experience as well. So with that, I thank you for your listening, and I'll take any questions you may have. Thank you.
Thank you, Dr. Said Raza, for your lecture. Actually, so far we have compliments for your great lecture. Dr. Asad, do you have any questions?
Yes, Dr. Sayed, I have a question regarding the hormonal assessment in patients with the apnea, sleep apnea syndrome. What's in your protocol in the hospital to do for these patients?
Yeah, thank you, Dr. Asad. Now, as a normal protocol, there is no protocol to assess the hormones. But certainly, if somebody is interested, then they may look at the catecholamines, particularly adrenaline and non-adrenaline, and also the cortisol levels. And this will be required perhaps in patients who have got severe form of sleep apnea or obstructive sleep apnea, in whom there is significant arousals. But as in general, there is no clear-cut guideline that these patients should be tested for any hormonal assay.
Dr. Ghazi, do you have any comments or questions to Dr. Said Raza?
Thank you very much. This is really an excellent presentation. I just want to know about the diabetic patient advanced who has been on diabetic for a long time. Do they have? Do you see more of them in with sleep apnea?
Yeah, I think that's a good question. The pathophysiology of sleep apnea, particularly of the obstructive sleep apnea, and how it affects the cardiovascular system, we know a little bit, but we do not know in detail. But I also should mention that it leads to metabolic problems as well, and diabetes is one of them. So it does affect the morbidity such as diabetes. And I suppose it is again the pathophysiological mechanism because it causes systemic inflammation, endothelial dysfunction, and then the rise in the cortisol, so the stress hormone like cortisol, which again will have an impact on diabetes.
Do you see a patient with the diabetic with dementia who are they develop insulin resistant in the brain, and that's really a bigger problem, okay, and lead to Alzheimer. Now, do this type of patient, they have aggravated sleep apnea, affecting the other part of the brain?
Yeah, surely. One thing is that these patients, if we talk about the patients who have obstructive sleep apnea, these patients are obese. And they will carry with them all kinds of metabolic diseases, and diabetes will be one of them. And the hypoxia per se, I'm not sure if it will lead to the Alzheimer's or aggravate Alzheimer's. I'm not very sure of that. But certainly it increases the chances of ischemia in the brain. So indirectly, I would say yes, probably it will aggravate the problem of Alzheimer's as well.
Thank you.
Thank you.
Yes. Hello.
I have just Dr. Said. I
Yes.
saw many patients not obese, and they have obstructive sleep apnea. So how to deal with this patient? Obstructive sleep apnea, diabetic, non-obese patient, and he has a severe index of or يعني sleep apnea index, it is very high. So how to deal with them?
Sure. No, that's a very good question. All sleep apnea patients are not obese, but majority are. Now, why you get obstructive sleep apnea? If you're first, I'll discuss that in patients who are not obese. So the problem here is that we have to look at the air passage, and this category of patients are more dealt with the ENT surgeons because they may have the problem in the terminates in the nose. They may have enlarged tonsils. They may have large tongue, and they may have very small or tight space in the pharynx or oropharynx. So this is again a different entity of patients. And sleep apnea is also seen in children where they have large adenoids or tonsils. So this is again a completely different entity, and they are not obese patients. The second of the category of patients are who have central sleep apnea, and patients who have central sleep apnea, by and large, they may be non-obese, but they may actually again coexist in obese patients. So this is how I'll explain and answer your question, Shama.
Yes, doctor, thank you. But also I wanted to a more explanation. If the patient has no ENT problem and the patient now have diabetes, obstructive sleep apnea, and the patient cannot sleep from severe apnea, how we can deal with him?
Yeah, so I think first of all, if the person is not obese, has got no signs of obstruction, so this is perhaps not obstructive sleep apnea. But to confirm that, whether it is a central sleep apnea or just a small, or it could be a mixed apnea or mild type of obstruction plus central sleep apnea, they need to undergo the polysomnography, a sleep study, and get to know the apnea-hypopnea index. First, we have to confirm the diagnosis that this is really sleep apnea and nothing else.
Now we did the sleep apnea test, and he has severe sleep apnea index. How to deal with him? Go for CPAP or a temporary solution for him, or how to advise him?
Yeah, there are. I mean, we are limited with options as how to treat because CPAP machine obviously will help the patients who have got obstruction, but the CPAP machine may be tried in patients who do not have obstruction, just central sleep apnea. There are a few drugs that have been used in the past for central sleep apnea, but again, they are not very helpful. So that is one. The second one I showed you, the servo stimulation. These are the machines that will provide stimulus to the brain. So if there's a problem in the center of breathing in the brain, so these will be stimulated by these servo ventilators. So these are the few options I would recommend for these patients.
Okay, thank you, doctor.
Thank you. I think there's a raised hand from Dr. Adel Salah.
Yes, Dr. Adel, please go ahead.
Yes, now. Very nice lecture, Dr.
Thank you, Dr.
Dr. Said was a very nice lecture. Thank you very much. As a pulmonologist, and I have a good experience with dealing with sleep apnea cases, and I have many patients. I treat them with CPAP and with many other options. The ideal for these patients, as you said, we have to do polysomnography. This is the first step. After polysomnography, according to the apnea-hypopnea index, we can stratify the patient according to the AHI into mild, moderate, or severe cases. For mild cases, the option is just it can be like positional therapy. If you ask the patient to lie to avoid lying in supine position, some sleep hygiene maneuver, they can help. For severe cases or moderate cases, we have to consult first the ANT for any correctable causes, because any correctable causes can be managed and can be corrected. They will help, of course. After that, if there is no correctable causes to be done by the ANT, the CPAP is the best option for these patients. And this is my comment. CPAP is a very big solution for these cases, especially the non-obese person, as Dr. Shaima asked. For the obese person, you have to measure the carbon dioxide, because we have to consider if these patients have obesity hypoventilation, so the BiPAP will be the best solution, not the CPAP. Thank you very much.
Thank you, Dr. Adel, for your comment, but I want you from you to illustrate for me about the patient can use like a temporary method like mandible device.
Of course, there is a mandibular advancement device, which is very beneficial for some patients, but this can be restricted only for patients who have a abnormality in the mandible, like a retracted mandible or any other abnormality, facial abnormality. But if the anatomy is correct, these devices will not help a lot. So there is also another type of device called tongue retracting device. We have tongue retracting device and the mandibular advancement device. This device can help only with some anatomical disturbances, but not for every and each patient with obstructive sleep apnea. Up to the result of many studies and many cases during the last 20 years, CPAP is the best option for treatment of patients with obstructive sleep apnea. But anyway, it is one of the options, and we have to choose between CPAP and other more advanced ventilation like BiPAP and even ventilation if the patient is obese. Okay.
Thank you.
Thank you.
Thank you, Dr. Adel, for contributing to the discussion.
Sorry, Dr. Sayed, sorry.
Yes, Dr.
Dr. There is a comment in the chat box from Dr. Ahmed Salahuddin, ANT surgeon. Can you please have a look at it?
Yeah, sure.
And then Dr. Amr Dirazi, good morning. He has a raised hand as well.
Dr. Ahmed Salahuddin, as for patient, Dr. Shaima asked about they have to go for drug-induced sleep endoscopy beside plethysmography to assess the airway. They may suffer from collapsed airway. Thank you, Dr. Ahmed.
Yes, Dr. Amr, تفضل.
Amr.
Yes, sure. I just wanted to ask, how often do pulmonologists consider referring obese, especially morbidly obese patients with sleep apnea to bariatric surgeons for weight loss surgery? I mean, many studies that talked about the benefit of losing weight and all that. However, the majority of cases I see that they are walk-in patients, like patients that read or that. I haven't seen much referrals really from pulmonologists. So I just wanted to ask our colleagues, I mean, what is the criteria for referring to bariatric surgery to treat sleep apnea, and when would they consider it?
Well, if I can make a comment before anybody else has got any comment to make. Now, first of all, these patients, they are not very well recognized, and there are lots and lots in the community around. And you must have a good eye for suspecting these morbidities, first of all. And once you suspect, obviously, the the diagnosis virtually is clinical. You don't need even to do a sleep study to confirm the diagnosis, but we need a sleep study just to stratify them as to their mild, moderate, or severe. But obviously, the weight loss is an important issue, particularly in the obstructive sleep apnea. And as in all obese patients, we advise the lifestyle change measures. And beyond that, obviously, they need to go to specialists to see if they treat them with their drugs. If that fails, then obviously they'll come to you for such.
I totally agree with that, sir. I mean, I've actually, it's so underdiagnosed in morbidly obese patients that I now routinely screen for sleep apnea. I mean, we use a questionnaire. It's called the Sleep Bang questionnaire.
Yes.
And it helps at least highlight those that are high risk for having sleep apnea that's undiagnosed. But as I said, I mean, we see marked results in these patients because the majority of them come, and the ones that are diagnosed, at least they are on CPAP. We do the surgery, they lose as little as the initial 15 kilograms they lose. They feel better and they stop using the CPAP. I mean, even their respiratory parameters start going back to normal from the first 10 kilograms they lose.
I think
and it makes a big difference in their lifestyle.
Yeah, Dr. Amar, I think that's a very good point you have raised, because one thing we should remember that if these patients are not diagnosed and confirmed that they have got obstructive sleep apnea, and they come to you and you operate, and remember these patients will have a high perioperative complications and mortality if they're left untreated. So I think that's a very, very good point that you have raised, that they must be diagnosed. So the clinical suspicion is important, and the diagnosis must be confirmed and adequately managed before they are put on the operating table. I think that's a very good point.
Absolutely, totally agree with you.
So let me see how we are doing with time. Any more questions from the floor?
Actually, we have 6 more minutes, Dr. Said Raza. But I think if Dr. Amar and Dr. Qasim are ready, we'll ask Dr. Ghazi to present.
Dr. Iman, yes. I will introduce Dr. Ghazi, the chairman of the next session. Dr. Ghazi is a consultant endocrinologist in Al-Manama Medical Center. Dr. Ghazi, he has a long experience in the endocrinology, especially in the calcium and parathyroid in his graduation. Dr. Ghazi, he chaired the endocrinology department in Salmania Medical Complex for many years, and he participated in our scientific committee for the last 5 conferences, and without his support, really this conference we cannot, and his advice, we cannot continue. Dr. Ghazi, floors for you.
Thank you very much, Dr. Asad. I'm really grateful for your nice word, and it gives me now a great pleasure to introduce Dr. Amr Dirazi. Amr Dirazi is one of the stars, in Salmania Medical Center, and I'm sure he will contribute a lot, and he contributed a lot to surgery, and he's consultant in general bariatric and advanced laparoscopic surgeon at the Salmania Medical Center. He's graduated from Alexandria in Egypt, University in Egypt, and he's also a fellow in general surgery and at from Master University Canada, McMaster University, Canada. I think he's going to speak to us now about advanced the adolescent and pediatric bariatric surgery. Thank you very much, Dr. Amr, for your talk. Dr. Amr.
Thank you.
Are you with us, Dr. Amr?
Yes, Dr. Ghazi, he's sharing his slides.
Sorry, yeah. Can you hear me now?
Yes.
Okay, my apologies. Can you guys see my screen now? Perfect.
Yes.
Thank you. First of all, thank you, Dr. Razi. I always remember your teachings when I was a resident. You're not much older than me, but I was really happy to have you as one of my teachers, and I'm proud of that. Today's talk is going to be about the evolution of pediatric surgery in children and adolescents. I mean, initially, when the guidelines for the NIH guidelines came for bariatric surgery, it was clearly mentioned that this kind of surgery should be reserved only for those who are 18 and above. Bariatric surgery was basically, the pediatric group was clearly not included in this type of surgery. However, as time went on, we started to see the problems that I'm going to be talking about, and we started considering it, and now it's becoming an actual branch in pediatric and bariatric surgery. So first of all, let's talk about obesity in children. So this is a study. On the left side, it's for those that are 6 to 11 years old. On the right side, it's 12 to 19 years old. And as you can see, from the 70s until now, we have seen a drastic increase in the prevalence of obesity in children. I mean, you're talking about almost a 3 to 5-fold increase in the rates of obesity in children, which is horrendous. Currently, the WHO recognizes childhood obesity as the next epidemic that's going to be facing the world. In Bahrain, I mean, we're the same. I mean, the latest surveys revealed that 30% of school children are obese. So it's a problem. Why is it a problem? First of all, when they looked into the breakdown of the increase in childhood obesity, what they found was dire. They found that the increase was actually in the higher BMIs. So it was more in class 2 and class 3 obesity. So it's not that the increase was in the overweight. No, the increase was in the super obese population. So these carry a grave danger for these children, especially when they grow up. Why is this important? Because all studies demonstrated that patients who are obese at pediatric patients who are obese at preschool, they have a 30% of continuing to be obese when they're adults. If they continue to be obese when they're in school, they have a 50% chance of continuing to be obese when they're adults. And once somebody is adolescent and they're obese, it's most probably they will continue their obesity as an adult, which gives an increased time to develop the comorbidities associated with obesity. This is just to reiterate what I said. And again, just to emphasize one point, obese adolescents are most likely going to suffer from type 2 diabetes, hypertension, NASH, and sleep apnea, which will lead to premature death. So these guys will die earlier than their counterparts who are not obese. Not only has the rate of obesity increased in children, also there has been a 10-fold increase in the incidence of diabetes from the 90s, early 90s until now. 10-fold increase in type 2 diabetes in children. This is drastic, and most of it is attributed to obesity. Not only is the danger is the increase in diabetes, but you have to keep in mind that in children, the latency between pre-diabetes to becoming full-blown diabetes is very short, unlike adults. So it's really important to treat this important comorbidity. So what do we know about bariatric surgery in children and adolescents? Well, we know that the biggest experience worldwide comes from our neighbor to the west, Saudi. So my friend, I'm really proud to call him my friend, Arad Gahtani, is a pioneer. He has the biggest series worldwide in performing bariatric surgeries in children. So he has demonstrated that, one of his arguments was that children were not provided access to bariatric surgery because of concerns regarding the safety of the procedure in children. Moreover, people were not sure, does it work in children the same way it works in adults? And a lot of people had concerns about growth. These children are growing. What do we do if we do restrictive or malabsorptive procedures? How will that impact their growth? And that's the main concern why these procedures are not offered for these patients. Mind you, in his team, it's a multidisciplinary team, and they had very stringent criteria into whom they were performing surgery. So their criteria was a BMI of 40 kilograms or 35 and above with comorbidities. Moreover, they had to have failed attempts to lose weight. And if they're less than 17 years old, they have to have consent of their parents. They had very stringent criteria. I mean, they have pathways for everything. So this is the pathway they follow for the different types of BMIs. Clearly, as I said, they will only consider surgery in class 3 BMI. They offered lectures for the patients and their parents. They also educated them on healthy feeding food habits, and these are just pictures from that. Even in the surgery itself, there are clear pathways into what happens pre-op, post-op, in the operation, and post-op. Everything is clear and standardized. So here is a paper that they published, and initially they were doing gastric bands, and then they moved into sleep. So this is the paper they published regarding gastric bands, that it was safe. However, as their experience progressed, they started seeing complications of bands. Here is one of these complications. If you look closely, this is the result.
Can you meeting as attending and as listening also now? Because my talk is soon.
Today? Sorry. Can I continue, or is there a problem here? Hello?
Sorry, Dr. Najah, can you switch off? Yeah, it's up.
Okay,
no? Okay.
All right. So basically, this is one of the complications in which you can see the band is way over in the pelvis, like it's moved. It's usually somewhere over there. Another complication they noticed is one patient presented with obstruction, and then when they went in and did laparotomy, the band has eroded through the stomach all the way to the intestine. They found a number of slipped bands, and of course there is the notorious megaesophagus. So they stopped doing bands, and they moved into doing sleeve gastrectomies. And this is their experience, initial experience in 108 obese patients. So as you can see that baseline BMI was an average of 50. All these patients, almost 90% of them have comorbidities. Again, they had very strict criteria into which patients they operate. So 90% of them have some sort of comorbidities. The majority of the major comorbidity was dyslipidemia, hypertension, and sleep apnea. Only around 20% of their population had diabetes, and another 20% had hypertension and prediabetes. They tried to look into the difference between those patients that had NASH or they didn't. What they did notice is that patients that had NASH were more likely to be diabetic and have portal hyperinflammation. Otherwise, the results were the comorbidities and results were the same. So, what happened in these patients? Here we can see the post-operative follow-up. So this is 3 months, 6 months, 12 months, and then 2 years. So there was drastic weight loss as early as 3 months. So on average, patients lost 20 kilograms at the 3rd month, and this moved into 40 kilograms at 2 years. The change in BMI was roughly around 40% in 2 years. What about comorbidity? So we know that there is weight loss that is sustained up to 2 years. What about comorbidities? Well, there was resolution. These are the comorbidities that were there, and there was almost close to a 90 to 100% resolution of these comorbidities. Diabetes, pre-diabetes was resolved in all patients. Diabetes in almost 93% of these patients. The rest of the comorbidities, the lowest was dyslipidemia, and it was there in 70%, which is great results. So now we talked about efficacy, we talked about resolution. What about comorbidities? What about safety? Well, thankfully, there was zero mortality in their series and zero leak, which is the notorious thing that we are afraid of. Out of the 110 almost patients, only one patient was readmitted, and it was because they were afraid, they suspected leak, and when they investigated them, they did not have leak. The only comorbidities they witnessed was wound infections and GERD, and it was less than 3% in total. So having said that, how does that differ from their adult counterparts? So what Ayub did, he compared in his same series with adult patients that he himself operated on. And as you can see that the BMI in the beginning was the same, and so were the comorbidities. When they compared adults to pediatric patients that underwent laparoscopic sleeve gastrectomy, they noticed that the weight loss was the same over 24 months, which is 2 years. But what they noticed is that pediatric patients were more compliant than their counterparts that are adults, probably because the parents are the ones that are bringing them and they're more stringent in their follow-up. So then they had a bigger series and they started following these patients for up to 5 years, and they published their papers. So they by that time they had around 230 patients in their series, and they followed them up between 3 to 5 years. As you can see, the weight loss was sustained up to that time. When they looked into the different comorbidities, they had very stringent criteria into when they call it a complete resolution and when they call it a partial resolution. This is the baseline comorbidities, and in their series, in average, there were 2.1 comorbidities in their patients because they picked patients with higher comorbidities. Again, the majority of the comorbidities, as we said, were dyslipidemia, hypertension, and obstructive sleep apnea. Diabetes was there around 30%. We can see here that overall, after 3 years, almost 90% of the comorbidities had either some partial or complete improvements. And we can see that the majority of the best improvement occurred in prehypertension, diabetes, and prediabetes, which is what we will see in this slide. So if you look at this graph, you can see that prediabetes, diabetes, obstructive sleep apnea, and prehypertension had almost 100% resolution rate, whereas triglyceride, hypertension, and cholesterol improved more than 80% of these patients. So this is a very great result. What about complications, long-term follow-up? Again, complication rate did not increase. It's remained at 3%. Then comes the big question: does these operations affect patients' growth? So when they followed up, this is for girls. The majority of the patients were above the 3rd percentile. This was for girls and this was for women. We're going to talk in a bit of more detail in a bit. And they've achieved high-grade follow-up. I mean, at 3 years, almost 90% follow-up rate. So, to cut things short, more than 90% of the patients had one or more of these comorbidities. More than 40% of them had 3 comorbidities. Overall, 90% of these comorbidities were resolved, and more than 50% of the overall comorbidities were complete or complete remission or improved remission after 3 years. When you compare this 90% figure, I mean 90% figure of improvement of comorbidity after 3 years, remember that in adults, most series talk about 70 to 86% improvement of these comorbidities. So it seems that the rate of resolution of these comorbidities is better in children. So after these studies, a lot of the guidelines and consensuses worldwide started to include children and adolescents in the criteria for pediatric surgery. And currently, we consider patients, routinely we consider patients below 15, and then above 5, we require some sort of surveillance and special tests on pediatric surgery. What about physicians' opinions? So what about pediatricians or GPs? How do they favor pediatric surgery? This basically survey was conducted in the US, and they asked the physicians, when do you think patients should be referred for bariatric surgery? You can see that the majority quoted the earlier guidelines that talked about 18 and above. So still, there is reluctance in referring pediatric patients for bariatric surgery. Then came the question, how low should we go? Initially, it was 18, we talked about 14 then and 15, and then we started looking into younger ages. So here, this study compared sleeve gastrectomy in patients below 14 years old of age and patients that are between 14 and 18 years old. So we saw that at baseline, everything was comparable. And here they compared the effect in the different age groups on growth. So this is these patients that underwent sleep, and these are patients their counterparts that underwent weight management by other ways other than surgery. We will see that in the graph. So basically, again, blue is sleep patients, red is weight management. We can see that height increased in patients that were 5 to 9 years old that underwent sleeve gastrectomies more than those that underwent weight management. The same thing happened to patients that were 9 to 13 years old. Their growth was much better when they underwent sleeve gastrectomy. Same thing happened in the adolescents and teenagers. Then we looked at the Z-score. So for the Z-score, it measures how far from the normal population you are. So the closer you are to 1, the better. So as you can see, the red here is the sleeve patients. So with the red, they maintained they were very close to the 0. Whereas medically managed patients started drifting away from the 0. So as time went on, their growth was more retarded. When we looked at how sleeve gastrectomy affects weight loss in the different groups, so 5 to 8, 9 to 12, 13 to 16, and then adults, we can see that the weight drop was almost the same, difference between 5 BMIs, which is not much. And here we compared 14 years old, below 14 and above 14, and how their weight loss is maintained after 5 years. And we can see that it's the same. That's why a lot of people started calling for bariatric surgery to be performed in as early as 5 years of age, if indicated. So in short, there is excellent and sustained weight loss after sleeve gastrectomy in the pediatric age. 4 to 5 year results show a mean excess weight loss above 75% in children and adolescents, which is compared to 50 to 60% in adults. So it actually reduces the weight more in pediatric age group. Moreover, sleeve gastrectomy has an excellent safety profile. We talked about 3 to 4% complication rate, 0 mortality, 0 leaks. This, when you compare it to the complication rate in adults, which is 11 overall complication rate and 0.3 mortality. So even it's safer to perform in pediatric age than in adults. So do we do this to make patients look better? This is one of the pediatric patients that underwent the surgery and shows how the pants he used to wear before surgery and after. Here is an example of an 8-year-old that basically had a BMI of 70 pre-op, was suffering from obstructive sleep apnea, diabetes, and was in wheelchair all his life. So after the surgery, and this is 2 years later, we see that there was an estimated excess body weight loss of 60%, complete resolution of their comorbidities, and the patient's able to walk. This is another patient that had a BMI of 48 and a lot of comorbidities. Once they lost weight, 2 years later, everything went back to normal. This is an unfortunate patient. So he was 9 years old. He had a BMI of 60. He suffered sleep apnea, and he actually had cardiac arrest. 6 months later, after the sleep gastrectomy, his BMI dropped to 40. 2 years later, he's back in BMI of 27. And he got rid of the comorbidities that caused him the cardiac arrest and would have killed him if we did not do anything. I will leave you with the take-home messages. Always remember that the prevalence of childhood obesity is increasing, and we're talking about the next epidemic of childhood obesity. Childhood obesity is strongly correlated to developing comorbidities at adulthood. So the earlier we treat it, the better these patients are. Bariatric surgery in children is effective and safe. Keep in mind that bariatric surgery not only improves the comorbidities of obesity, but it also improves their growth if not treated with surgery. Thank you very much. With this, I will come to the end of my talk, and I will leave the take-home messages. And the floor is now open for questions.
Thank you very much.
So I see there is one question from Dr. Hisham Bakri. What is the recommendation about the optimum age for children that's safe to go for bariatric surgery in Bahrain? So currently in Bahrain, the youngest child we have operated on was 12 years old. We routinely operate on 14-year-olds, but the youngest was 12 years old. We have not operated younger than that. Usually try other non-surgical modalities until they are a bit older, and then do the surgery. Any other question?
Dr. Amer, I would like to ask a question myself. It's a fantastic job with these children and really putting them on a healthy lifestyle and all that. But do these children get any psychiatric support before surgery, after surgery, and do their family get any training on how to deal with these children later on to keep them on the right track? To keep the weight at the normal rate?
Sure. So first of all, it's very important that a multidisciplinary team assesses these patients, including the pediatrician. Not only do the children need intensive psychological support, but also the parents need that. Because for the younger patients, I mean, we're talking about 9 or 12. The parents are the ones that are going to be caring for their children. They're the ones that are going to be supplying the food. They're the ones that are going to be following up these patients to see whether they are compliant with their medications, whether they're compliant with adopting a healthy lifestyle. So as you can see, I mean, we're not as advanced as the Saudi program. I mean, in Saudi, they have intensive lectures, patient support groups, home visits by nurses, etc., etc. But here we tend to bring them to the pediatrician clinic and to the bariatric surgeon clinic quite often, and with the dietitian to go over through what is expected from them pre-op. So we give them a realistic expectation what to expect after the surgery, and then after the surgery to see their compliance, to follow up their weight loss, and once there is a problem, to identify the causes of it. So yes, psychological support is paramount in these patients.
Thank you, doctor. I think we should start a program for these patients, for the pediatric surgery weight loss program.
Sure. I think Dr. Dalal has a question. I see her raising her hand. Dr. Dalal.
Thank you, Dr. Amer, for your very interesting talk. It's a very important topic. Very well done. I wonder if there is long-term data or the longest data, at least follow-up we have for weight regain in children after surgery.
Sure. So the longest series is by Dr. Ali Gahtani. I mean, he published the 5-year series. He did not talk about weight regain. He talked about the average weight loss. This was one of the things that a lot of the criticism that came along when he was presenting his papers is that he did not talk about weight regain. What happens, how many patients the surgery fails, and what happens when they fail. However, he is in the process of publishing his 10-year follow-up, and he promised to talk about that in his paper. I suspect that in the 10-year follow-up, just like in the adult patients, the sleeve gastrectomy specifically is associated with almost 40% weight regain after 10 years. I'm suspecting the number will be the same, maybe a bit less, but it will be the same. Having said that, keep in mind, these patients have high comorbidity. And if you remember from my lecture yesterday, we talked about the legacy effect. The longer you keep these patients in like normal weight, the better the protective effect of the complications of diabetes and hypertension. So even if you do the surgery for a patient and they lose their weight for 5 to 6 years and regains it later, they are better protected than not having had the surgery at all.
Thank you very much, Dr. Amr. This is an excellent lecture. I don't know. I have a question. Are we really losing our way in recommending bariatric surgery for children and adults instead of looking really in the long term, which is really, it seems to be, it is a behavior problem, and it is mostly related to carbohydrate consumption and a soft drink, which is from most of the, you go to any shop, you will find it easily. Do you think we are really, I mean, your recommendation, I could not recommend bariatric surgery for everybody. I could not even for obese patient. I mean, I don't know. Have you consulted the medical section? What are you going to do with it? Certainly new data is coming, which shows a different way. What's your view?
Sure. As I mentioned yesterday and today, I mean, at least for us in Salmania, I'm pretty sure in all other hospitals, we have a multidisciplinary team, and the endocrinologist is an integral part of this team. Endocrinologist representing the medical specialty. So we do not embark on any bariatric surgery before getting the agreement of the endocrinologist. So the endocrinologist, their role is they're going to screen for any endocrine problem that causes obesity. And if they're there, then they will try to treat it in other non-surgical modalities. Having said that, as you mentioned, when bariatric surgery first came out, we were restricted when it came to obesity medication. And now there is a number of injectable, at least, obesity medication out there. We're starting with liraglutide, and now we're talking about semaglutide. The data shows that with the semaglutide 2.4, you're talking about a loss of 20% of your weight after at least 6 months of use, which is quite good. Having said that, this medication might fill a small void because this will be indicated in the lower BMIs of obesity. So you're talking about the medical use being highly recommended for BMIs of, let's say, between 27 to 35. But once we get into the higher BMI categories, especially above 40, I mean, it's unequivocal that surgery is superior for these patients when it comes to reducing their weight, improving their longevity, it improves their, they will live longer, and it improves their comorbidity. But in short, even for these patients, we will not embark unless we get the blessing of all the multidisciplinary team, with the medical doctors being a member of that team.
There is more questions, Dr. Amr, in the chat box and in the question and answer. One for Dr. Qasim.
Sure, 1 second. In the question, where were in the chat room? Sorry.
Yes, Dr. Qasim. Could you show us the number of children operated in Bahrain and our local results?
In Bahrain, والله يعني, they're sporadic. I mean, we're no close to we're far away from the Saudi experience. Yani, below, I would say below 18, probably overall we've operated around 20 patients. But it might be a good idea to actually do a collection of these cases and present them maybe by the next IMDO.
Another question from Dr. Jamil Nasser. Any specific criteria for referral in Bahrain?
Currently, as I said, we especially in the pediatric age, we insist that we get the referral from the pediatrician, preferably the endocrine pediatric doctor. I know that some people in private, they started operating on 14-year-olds and above by parents taking them in, but I still think that our experience is still at its infancy. We really need to stick to the guidelines. We really need to have the full team assess these patients before we embark on these surgeries.
Dr. Amr, there is a question also in the chat box. How many percentage of patients will need a second surgery by 5 years because weight increases gradually due to metabolic set point?
Yeah, well, I like this question because here we're talking about weight regain and we're talking about the metabolic set point. Keep in mind that the metabolic set point is not going to occur in every single patient. However, having said that, currently the commonest procedure that's being performed in the pediatric age group is the sleeve gastrectomy. And as I told you, drawing back from our experience in adults undergoing sleeve gastrectomy, it is our anticipation that around 40% of those that undergo sleeve gastrectomy will have some sort of weight regain after 10 years. So the expectation is after 10 years, around 40% of them will either need some sort of medical therapy, like by that time, the medication for losing weight will increase, so some sort of medical therapy, or revisional surgery. I mean, it's going to be up to whatever modality we have at that time. Keep in mind, there isn't a single modality out there, surgery being included, that will guarantee that there is zero weight regain after 10 years. Everybody that is using any sort of weight medication will experience some sort of weight regain after some time.
Thank you, doctor. We are right on time. Dr. Asad?
Sorry, Dr. Ghazi. Dr. Ghazi. Dr. Ghazi, you are on mute. Can you unmute yourself, Dr. Ghazi?
Give me a great
okay.
pleasure. Yeah, give me a great pleasure to introduce Dr. Qasim Aradati. Dr. Qasim Aradati is one of the pioneers who really looked after the pediatric section at Salmania Hospital for many years, and he contributed a lot, and many of the present doctor graduated under his auspices. And of course, his main interest is infectious disease, and now he's working in Bahrain Specialist Hospital. Of course, he graduated from American University of Beirut. Then he went to Florida to specialize in pediatrics, and he continued, and he went to the Children's Hospital at Wayne State, and he have done a lot, for all these years, and with his Of course, his wife, Dr. Najah, you know, they contributed really a lot, you know. He's going to speak to us now about antimicrobial susceptibility pattern of bacterial pathogen in tertiary care hospital in the Kingdom of Bahrain. Thank you very much, Dr. Qasim. We're really grateful that you're present. Thank you.
Dr. Qasim, we are sharing your recorded session, right? You're muted, Dr. Qasim.
He's not hearing you.
You can go ahead and share my recorded session. I'm going to be available for answering questions.
Inshallah,
Please, Dr. Iman, go ahead.
Yes, inshallah, Dr. Sure.
Thank you. Everybody. Before I start in my presentation, I would like to thank the organizing committee and thank the scientific committee for hosting me in this presentation. I believe that the IMDO in this 5th year right now has been doing a tremendously excellent job in providing the opportunity for research papers to be presented locally and internationally. And I definitely congratulate the organizers on this big effort, and I wish them continuous success. My topic today is, as you see, antimicrobial susceptibility pattern of bacterial pathogens in a tertiary care hospital in the Kingdom of Bahrain. And what I wanted to emphasize is that treatment of serious infections became more challenging recently because of emergence of antimicrobial drug-resistant bacteria. The consequences of such emergence lead to an increased mortality and morbidity of patients with underlying medical conditions, such as obesity, chronic lung disease. All of the chronic conditions are really going to be impacted by infections. So it is important that we take this very seriously. In addition to the financial burden where patients with infectious due multi-drug resistant bacteria are treated, the speed by which bacteria acquire drug resistance far exceeds that of discovering new antibiotics that can be used to treat patients with such infections. And I'm sure that we are all aware that we do not have as many newer antibiotics as we would expect with this emergence of the resistant bacteria that's being isolated repeatedly. So it's important to keep in mind that increased awareness of the local and regional antimicrobial susceptibility patterns is essential to direct the treating physician to choice of optimal treatment of serial bacterial infections. What I would like to start with is to present this article that was published recently in the journal Lancet, and it's titled Global Burden of Bacterial Antimicrobial Resistance in the year 2019, and this was a systematic analysis. This actually was the first study that analyzed data from many locations all over the world for 1 year, and that study revealed that almost 5 million deaths were associated with bacterial antimicrobial resistance globally, and 1.27 million deaths of those were directly attributable to antimicrobial resistance. At the regional level, all death rates attributable to resistance was the highest in Eastern Sub-Saharan Africa at 27.3 deaths per 100,000 population, and death rates were the lowest in Australasia at 6.5 deaths per 100,000. Next lowest rate was in North Africa and the Middle East region. This study shows the extent of the data that was collected, whether it is microbiology data, literature studies, hospital discharges, single drug resistance profiles. So it was a combination of data, and it was analyzed thoroughly to come up with the numbers that I mentioned earlier. As far as regional incidence of actual mortality in relation to antimicrobial resistance, as you can see on this chart, the biggest was in Western Sub-Saharan Africa, and the lowest was in Australasia. Next to that was North Africa and the Middle East. As far as site of infection, the lower respiratory infections were the most commonly encountered infections causing mortality. Bloodstream infections followed by intra-abdominal infections, followed by urinary tract infection, and then tuberculosis, skin, CNS infection, etc. As far as organisms are concerned, E. coli was the highest number of organisms responsible for these deaths. Staph aureus followed by Klebsiella pneumoniae, Streptococcus pneumoniae, Acinetobacter baumannii, and Pseudomonas aeruginosa, and other pathogens. It is important to note here that Streptococcus pneumoniae is the fourth leading cause of death in patients causing mortality due to antimicrobial resistance. The interesting fact here is that this is the only organism that can be prevented by immunization. So this is a plea to all of us to make sure that our patients are protected and immunized, particularly against Streptococcus pneumoniae, since this is a significant cause of death in organisms that are resistant to bacterial pathogens. So, to repeat, need to mention that the lower respiratory infections accounted for more than 1.5 million deaths associated with resistance in 2019, making it the most burdensome infectious syndrome. The six leading pathogens of death associated with resistance: E. coli, Staph aureus, Klebsiella pneumoniae, Streptococcus pneumoniae, Acinetobacter baumannii, and Pseudomonas aeruginosa, were responsible for 3.57 million deaths associated with antimicrobial resistance and almost 1 million deaths directly attributable to antimicrobial resistance. One pathogen drug combination, and that's methicillin-resistant Staph aureus, caused more than 100,000 deaths attributable to antimicrobial resistance in 2019, while six more each caused 50,000 to 100,000 deaths. Multi-drug resistance excluding extensively drug-resistant tuberculosis, third-generation cephalosporin-resistant E. coli, carbapenem-resistant Acinetobacter baumannii, fluoroquinolone-resistant E. coli, carbapenem-resistant Klebsiella pneumoniae, and third-generation cephalosporin-resistant Klebsiella pneumoniae. I'm glad to share with you results of our data that was the result of collecting all microbiological isolates for 1 year in our hospital and analyzing the isolates according to the source of the specimen and according to the antimicrobial resistance. The objective was to evaluate the prevalence of multi-drug resistant, extensively drug resistant, and pan-drug resistant bacterial isolates from clinical samples taken from patients treated at a tertiary care hospital in the Kingdom of Bahrain. So data on all microbiology isolates obtained from inpatients and outpatients treated at Bahrain Specialist Hospital in the year 2017 was analyzed. The samples were from cultures of blood, urine, wound, body fluids, throat, catheter tip, ear and eye swabs, sputum, and other clinical infection sites. The organisms were identified by conventional microbiological techniques such as morphological characters, gram stain, biochemical tests, and automated methods such as the Vitek analyzer. Susceptibility profiles were assessed through standard microbiological techniques using Dix diffusion method and were derived using Kirby-Bauer charts as per the Clinical Laboratory Standard Institute guidelines, as well as automated methods of Vitek analyzer. Data obtained were coded and entered into Microsoft Excel spreadsheet and were expressed as rates, ratios, and percentages, and were compared with different groups, which included susceptible group, followed by multi-drug resistant, extended drug resistant, and pan-drug resistant groups. A total of 1,862 bacterial isolates were assessed for antimicrobial sensitivity pattern. From the total isolates, 61.6% were gram-negative and 38.4% were gram-positive. Among the total isolates, 65.2% were susceptible, 30.7% were multi-drug resistant, and around 4% were extensively drug resistant, and no isolate that was pan-drug resistant was detected, fortunately. Multi-drug resistance isolates were exclusively encountered in nosocomial infections. And this is something to stress, particularly in relation to the fact that patients who are already in hospital being treated for serious conditions are the most susceptible to nosocomial infections. And this is where multi-drug resistant organisms may actually cause significant morbidity and mortality. This is a pie chart showing the distribution, as I mentioned earlier. Almost 65% were completely susceptible to antibiotics. Multi-drug resistant was isolated in around 30%, and extensive drug resistant was about 4.5%. Again, patterns of resistance, it's important to keep that in mind, because when you're dealing with certain bacteria, you need to keep in mind this pattern of drug resistance. Whereas the susceptible organisms were mostly E. coli, Staph aureus, and Klebsiella pneumoniae. The partially multi-drug resistant were Haemophilus influenzae, E. coli, and group A streptococcus. I need to stop here at group A streptococcus. Of course, all of us are aware that group A strep is uniformly sensitive to penicillin. So this is not the issue that we're talking about. What we're concerned about is that in patients who are known to be penicillin allergic, we need to find out exactly if they have group A strep infection, if the organism is sensitive to a certain other antibiotic or not. And we found that 10% of group A streptococci were actually resistant to antibiotics, and these are mostly macrolides. And this is something quite important when we are treating patients with group A strep infection who happen to be allergic to penicillin, where this cannot be used. As far as multi-drug resistant organisms, E. coli, particularly extended spectrum beta-lactamase producing E. coli, were isolated 35.2%. Methicillin-resistant Staph aureus was in 16.4%. Methicillin-resistant Staph epidermidis was isolated in 14.3%. And extended spectrum beta-lactamase producing Klebsiella pneumoniae was identified as causing 11.3% of multi-drug resistant organisms. Extensively drug-resistant organism distribution is shown here. It is mostly ESBL E. coli, Acinetobacter baumannii, and ESBL Proteus mirabilis, and extensively drug-resistant was mostly MRSE, MRSA, and ESBL Klebsiella pneumoniae, as shown in this graph. Of the isolates that were identified, 715 were gram-positive, and the source was the throat in 18.1%, nasal swab was 15.6%, and wound was 11.3%. The pattern of resistance and susceptibility reveals that of all gram-positives, 66.7% were susceptible to antibiotics. Multi-drug resistant, whether it is partial, complete multi-drug resistant, was isolated at 30% of the instances, and extensively drug resistant was around 2.7%. In gram-negative isolates, not surprisingly, the urine was responsible for 41% of these isolates, sputum was in 10.9%, and wound was 9.6%. Of all gram-negative isolates, 64.2% were susceptible to antibiotics. Multi-drug resistant bacteria were 30%, and extensively drug resistant was around 4.8%. Among multi-drug resistant and partial multi-drug resistant and extremely drug resistant isolates, most of the organisms were resistant to fluoroquinolones, beta-lactams, cephalosporins, and aminoglycosides. And I'm sure you appreciate that these are the antibiotics that we more commonly use to treat infections. So it's important to keep that in mind. And that's why it's important to review the data in each institution to find out what the pattern of resistance, to make sure that we are able to select the proper antibiotic, whether it is at the empiric level or at the definite level, depending on the sensitivity pattern. An important observation was noted that among 23 isolates of Neisseria gonorrhoeae, 7 were penicillin resistant, and that accounted for 30% of the isolates. In these tables, and this table and the following one, I'm showing what the type of organism and what antibiotic categories are showing the resistance pattern. This is something to keep in mind. I'll not be able to read all of them, but the information is available in reprints of the article that I mentioned that was published in the Journal of Bahrain Medical Society. This is a continuation of the same table, and the information is quite important to identify which antibiotics are isolated to be responsible for resistance in certain types of bacteria. I would like to highlight that this exercise is being done on regular basis in our hospital. So we do collect data on all isolates on every year, and we identify what the organisms are, where the sources of these organisms are, what is the antibiotic sensitivity pattern according to these organisms. And we regularly share this data with our physicians and all people involved in management of infection, including infection control team, on a yearly basis. And that is very valuable information to our staff because it gives an idea of the pattern of resistance, particularly related to our hospital. And at the same time, the data that we are isolating is shared with the Bahrain National Antibiotic Stewardship Program. One observation that I would like to share with, because we have been able to collect data over 16 years, we were able to identify certain trends that I would like to share with you. And these are quite important, and I hope you will appreciate the reason that I'm mentioning that these are quite important. This is, for example, the urine extended spectrum beta-lactamase isolation from 2004 to 2020. And the percentage is shown here. Whereas in 2004, 7% of urine isolates were extensive spectrum beta-lactamase producing. This increased gradually to 25% in 2014. And I need to mention here that during this time in our hospital, we started to practice stricter control of antibiotic utilization, where antibiotic utilization was done more appropriately against what is the suspected organism, keeping in mind the resistance pattern. And actually, we were very fortunate in the finding that within a few years' time only, the percentage of urine ESBL isolation went down from 25% to 14%. And that was very statistically significant information. And that really is a reflection of the importance of antibiotic stewardship when dealing with antibiotic resistance. And that really is a reflection of the success to the management of infections due to these organisms. Another trend that was very important to highlight is the resistance pattern to gentamicin and tazocine in E. coli ESBL isolates. Whereas in 2010, the percent of gentamicin resistance was 59%. It went down to 24% in the year 2020, and the tazocin resistant went down from 22% to 6% in 2020, and the decline between 2010 and 2020 was statistically significant for both isolates. And again, this illustrates that when we start to use antibiotics judiciously, we will be able to get results of improvement in sensitivity pattern, as this was documented in this data. Same thing was observed in drug resistance to gentamicin and amikacin in Pseudomonas aeruginosa between 2015 and 2020. The percentage went down from 15 and 16% to 5 and 2% respectively, and that decline was statistically significant, as can be seen. So in conclusion, I would like to stress that awareness of types of bacterial isolates commonly encountered in the hospital setting is essential for optimal management of all patients. Most of the time, we base our empiric treatment depending on what we have as experience in isolates and antibiotic sensitivity pattern in our local community. And so this data is quite important in helping us identify what the empiric antibiotic to use to treat certain infectious syndromes. And then antibiotic analysis of antibiotic sensitivity patterns and the proper selection of antibiotics in managing infections in particularly specific patients definitely lead to better care, improved clinical outcome, and ultimately will help in prevention of increasing the resistance pattern of commonly isolated bacteria. And as a matter of fact, we demonstrated there was a decrease in the resistant pattern of commonly isolated bacteria to certain organisms, as I demonstrated in the previous few slides. Again, it's important to emphasize that isolation of multi-drug resistant organisms was mostly noted in patients with nosocomial infections. This is something that's important to keep in mind because most of the patients who acquire infections in the hospital are patients who have already underlying diseases, whether it is post-surgical or medical conditions that make them susceptible more to infections and make them susceptible to prolonged hospital stay, thus more of a chance of acquiring nosocomial infections. And that's why we really need to make sure that infection control is completely stressed at all levels, and the practice of infection control has to be maintained for all patients. So implementation of guidelines on selection of antibiotics at our hospital was definitely associated with a significant decrease in the rate of antimicrobial resistance to commonly used antibiotics, as I illustrated in the slides that I presented earlier on, particularly through comparison of the years between 2010 and 2020. I need to mention here that antibiotic stewardship program is the responsibility of everybody. So implementation of national and regional antibiotic stewardship program will lead to better patient outcome and significant saving in healthcare expenditure. And I'm glad to mention that our hospital, among other hospitals in the community, whether it's in the private sector or the government sector, are feeding their data up to one central data repository where antibiotic stewardship program is being planned, and the guidelines for utilization of antibiotics will be implemented for choosing the proper antibiotic for particular syndrome of outpatient or inpatient infections, and that will eventually lead to significant better patient outcome and significant saving in healthcare expenditure. As I mentioned earlier, adult immunization needs to be emphasized. Among all the bacteria that are associated particularly with resistant infection and causing deaths, as I illustrated in the study that was published in The Lancet, Streptococcus pneumoniae was the fourth common cause of mortality in such patients. And it is important to keep in mind that vaccine for pneumococcus is available and guidelines for utilization of the vaccine is available for infants, children and adults. And this is something that it is our duty to make sure that we keep track of immunizing our patients, whether they are children or adults, particularly people who are having underlying medical condition that makes them more susceptible to serious infections. Again, I need to emphasize that infection control measures need to be strictly implemented, particularly in relation to strong concern of nosocomial spread of infections caused by multi-drug resistant organisms, particularly in the hospital setting. And this is where implementation of infection control practices is essential in the management of patients. And with that, I would like to thank you for your attention. This is the list of references that I have, and I'll be very glad to answer some questions if the time allows. Thank you very much.
Dr. Asad, thank you, Dr. Qasim, for your presentation.
Dr. Ghazi.
Dr. Qasim, this is a very excellent talk, and your experience really highly evaluated. The problem with it that the use, does the government interfere and the Ministry of Health interfere in the use of antibiotic in hospital or by private doctor?
Actually, what's happening right now with the antibiotic stewardship program, which is led by the Ministry of Health with involvement of all major and private and government hospitals, is preparing guidelines to be implemented as far as antibiotic stewardship program. We're starting with outpatient antibiotic prescription, and gradually this will become more and more widespread. And it is very important for us all to adhere to the guidelines when they are published. So data is being collected. I must say that Dr. Jamila Salman, who is leading this group, is doing an excellent work with the team from all government hospitals and, of course, data from private hospitals. And I'm sure this is going to be implemented. As a matter of fact, already there is information from implementation in Salmania where the mortality was decreased, and actually there was a very significant saving in cost of antibiotics when antibiotics stewardship program was implemented.
Thank you very much. I just want to ask you another question. And this conference is for diabetes and obesity and related matter. Where you haven't mentioned about the infection in diabetic, especially with complication with diabetic foot.
No. Yes, Dr. Ghazi, thank you very much. Thank you very much, Dr. Ghazi. It's obvious that patients who are obese, who are hypertensive, who are having underlying cardiovascular disease, chronic kidney disease, all of these patients are already going to be susceptible to infections, and we really need to be very careful about managing them. And managing them appropriately will definitely decrease morbidity and mortality. I do not have specific data to share about obesity, but this is an eye-opener when we are talking about a conference of obesity, that we really need to look at it from all aspects, including the risk of infections. And this is why I believe the data that I presented is useful in that regard.
Thank you, Dr. Qasim, Dr. Amr, for your nice presentation. Thank you, Dr. Ghazi, to chair this session. We will have a break for 15 minutes, then we will start the next session. Thank you for audience.
Okay,
Good afternoon, ladies and gentlemen. Dr. Amar is here.
Yes.
Yes, Dr. Amar, you want to start the session?
Just a second. Yeah, it gives me great pleasure to start the session this afternoon. Thank you all for your attention. I will introduce now somebody who does not need any introduction, Dr. Najah Zayani, who's a consultant internist and gastroenterologist at Bahrain Specialist Hospital and an associate professor in the AGU. Dr. Najah graduated from the American University of Beirut and had a fellowship in gastroenterology from the Baylor University of Medicine in Texas. She has taught most of us practicing in the field have been taught in the hands of Dr. Najah Zayani, and I consider her an expert and a pioneer in the field of gastroenterology in Bahrain. With that, I leave the mic to Dr. Najah to present her lecture.
Dr. Iman is presenting a pre-report. Dr. Assad for allowing me to present the talk on NASH diagnosis and treatment with our local experience. First and foremost, I want to say that obesity is a chronic multi-system disease, and NASH or non-alcoholic steatohepatitis is a complication of obesity. I will illustrate this by presenting two cases. We met with NASH diagnosis and narrate their story. The first case is a 36-year-old Bahraini lady presented in January 2016, complaining of dull right upper quadrant abdominal pain and immediate postprandial diarrhea of 7 years duration. Endoscopy was performed at another hospital and she was labeled as irritable bowel syndrome, prescribed tiriptizole for management of her irritable bowel syndrome with weight gain from 110 to 124 on this drug. She suffered with diabetes mellitus and hypertension since age 30. On examination, her weight is 124 kilograms, the BMI is 40.6, and abdominal girth is 125 centimeters. Markedly enlarged tender liver is noted. Lab results show a high blood sugar of 276, elevation in ALT and AST to twice normal, CRP is elevated to 154, and hepatitis serology was negative. Alpha-fetoprotein was normal. Liver ultrasound showed hepatomegaly with a size of right lobe of liver of 20 centimeters. Multiple hypoechoic nodules were seen throughout the liver. Shear wave score revealed a score of 3.3 meters per second, and patient underwent a liver biopsy which revealed diagnosis of NASH, score 5, fibrosis score of 2. The patient was advised low-carb diet, but she refused to follow weight reduction diet and underwent a mini gastric bypass in February of 2016. 9 months after her surgery, her weight dropped from 124 to 77 kilograms. Her diabetes is well controlled on glucophage 1 gram daily. Insulin and antihypertension medications were stopped. Right lobe of the liver dropped from 20 centimeter 0.5 to 14 centimeter, and all hypoechoic areas disappeared on ultrasound. Shear wave score dropped from 3.3 meter per second to 1.2 meter per second in 2017. Patient returned to the clinic in 2021 with a regain of weight to 91 kilos with elevation of blood sugar and relapse of hypertension. She gained weight due to quote-unquote COVID, being bound at home and eating chocolates. Large liver of 18 centimeter was again noted with relapse of shear wave deterioration to 2.8 meters per second. She was informed of relapse of her liver condition and warned against regain of weight. Low-carb diet and semaglutide were started with drop in weight to 75 kilo with normalization of her blood sugar and blood pressure. The second case, unfortunately, showed up 20 years later than the first one at age 56. In other words, there is a 20-year difference between the two patients in age. She presented to ER in July 2017 with nasal bleeding, bruising, and hematemesis, past history of obesity, diabetes mellitus on multiple doses of regular insulin, and hypothyroidism. The physical exam showed central obesity. Weight is 112 kilograms with BMI of 44 kilogram per meter square and abdominal girth of 110 centimeters. Ascites was noted and MELD score of her liver was 11. Lab revealed low platelet count of 70. AST is 61, ALT is 33, and albumin is marginally decreased to 3.4. Fasting sugars of 83 and CRP of 8.8. Hepatitis serology, iron studies, autoimmune screens were all normal. Ultrasound showed scalloped margin of the liver with small liver of 12 centimeter and enlarged spleen, 14 centimeter. Portal vein was dilated to 14 mm and ascites was present. Shear wave recorded at that time is 3.3 meter per second, and endoscopy showed grade 3 esophageal varices. Patient was on multiple doses of regular insulin for diabetes mellitus, but started to develop hypoglycemia. Insulin was stopped while on diet in order to reduce her weight. Inderal and aldactone were started. She managed to reduce her weight to 83 kilos, but liver deterioration led to the development of persistent dyspnea due to hepatic hydrothorax, a condition associated with very high liver mortality at 1 year. Patient therefore was advised liver transplantation, but unfortunately all her first-degree relatives were not suitable donors due to their obesity and fatty liver. Patient was referred to Kingdom Saudi Arabia National Guard Hospital when her nephew volunteered to donate right lobe of liver, and transplant was successfully done in October 2021. The natural history of progression from non-alcoholic fatty liver disease to NASH is a beautiful example of how management of these cases at early age can prevent death and end-stage cirrhosis. As we all know that in healthy population, 24 of the population are unhealthy due to obesity. This leads to the development of non-alcoholic steatohepatitis and progression of non-alcoholic steatohepatitis either to cardiac death due to associated atherosclerosis or development of non-alcoholic steatohepatitis with inflammation in addition to fat, leading to progressive fibrosis, eventually leading in 10 to 15% of cases to cirrhosis or hepatocellular carcinoma or both. The figures from our area are staggering for the predisposition to the development of NAFLD and NASH. This statistics from Kuwait shows the rate of diabetes is 21%, the rate of obesity is 78% in adult population, and metabolic syndrome is seen in almost 33% of the population. The figures for NAFLD are clear from our area, as I said, in Kuwait, 33%. And the prevalence is even higher in certain countries of the Arab world like Sudan. Recent epidemiological data shows that the prevalence of diabetes in the Middle East is scary. The percentage of diabetics among adult patients ranges about 20% in Kuwait, Lebanon, Saudi Arabia, Bahrain, United Arab Emirates, and Sudan. Increase in diabetes prevalence has been attributed to increasing urbanization, aging of population, obesity, reduced physical activity, and unhealthy diet. 90% of our diabetics in the area are type 2 diabetes. There has been a general increase in NAFLD in Asia, leading the world in development of NAFLD, followed by the United States, estimated at 25% in adult population. How do we assess for development of this condition? Liver biopsy remains the gold standard for staging fibrosis, but it is invasive, expensive, and subject to sampling errors. Liver biopsy is also impractical for repeated assessment of progression of liver disease. Therefore, non-invasive ultrasound methods like shear wave and fibroscans are emerging as safe bedside tools to detect liver fibrosis. The stiffer is the liver, the faster is the pulse of ultrasound. Therefore, normal speed is 1 meter per second or less. And it correlates very well with liver fibrosis, which is staged by this system. In stage 0, there is no fibrosis. In stage 1A to C, there is perisinusoidal and periportal minor fibrosis, but no bridging. And in stage 2, perisinusoidal and periportal fibrosis is there, and stage 3 is bridging fibrosis, stage 4 is cirrhosis. If we correlate this with shear wave measurement, there is a significant positive correlation between median velocity measured by this technique, shear wave, and severity of liver fibrosis. Normal liver score is 1 meter per second or less. Scores between 1.5 to 1.9 indicate fibrosis, above 1.9 indicate significant fibrosis or cirrhosis. In this study, comparing the results of liver biopsy of 54 patients with NAFLD with their shear wave scores, found that sensitivity of 100% and specificity of 91% for scores above 1.9 meter per second correlating with cirrhosis. Another major study on 1,200 patients comparing the shear wave scores with fibrosis on biopsy revealed the similar finding that above 1.8 cirrhosis is fully recognized. So using this data and the availability of shear wave measurement at our center, we detected between 2016 and 2021, 314 cases of NASH. Data was collected on their demographics, presenting symptoms, medical histories, and patient anthropometric measurements. Lab tests including their CBC, liver function test, blood sugar, lipid profile, insulin levels, and post-glucose challenge insulin tests. NASH diagnosis was made based on the above data and imaging of the liver by ultrasound examination with shear wave measurement in fasting state. Any ultrasound features of cirrhosis were recorded. Shear wave scores above 1.5 indicated early fibrosis and above 1.9 indicate cirrhosis. All patients who had surgery during the follow-up for cholecystectomy or bariatric surgery, a liver biopsy was obtained during the surgery after obtaining consent of patient. The diagnosis of NASH was explained to these patients, and since weight loss is the only proven modality of therapy, patients were offered counseling for low-carb diet by a certified dietitian with free access of follow-up every 2 weeks. During follow-up, dietary history, weight, and abdominal girth were recorded. Follow-up by the physician for blood sugar charts in diabetic patients and adjustment of the medication was done regularly. After 6 weeks of diet, the patients were seen by the physician, medications were reviewed, and liver size was recorded. Repeat liver function tests and shear wave measurements were done after 40 weeks. 14 patients of the total 314 failed or refused diet and elected to do bariatric surgery. 2 patients during the follow-up underwent liver transplantation from living-related donors, and 2 patients died due to liver cirrhosis complication, one of them with HCC. So if we break down the number of cases encountered, 314, low-carb diet consultation was obtained in 274, and the rest of them refused consultation with dietitian. Among those 274, 169 of them were compliant to diet and managed to lose on average 9.1 kilograms in 40 weeks. The rest of them were non-compliant, and 61 were lost to follow-up after diet consultation. The nationality distribution, 80% of the sample is GCC citizens. These are predominantly females, and predominance of female in NASH cirrhosis is also reported in other series. The age distribution reveals that most of them were detected between the 3rd and 6th decade of life. However, unfortunately, we're seeing younger age group. We're seeing people as young as their teens and in their 20s with this condition. The initial presenting symptoms to the clinician ranged from bloating, uncontrolled diabetes, upper abdominal pain, nausea, postprandial diarrhea, fatigue, and/or overt symptoms of cirrhosis. The total number of patients were also noted to have a very high prevalence of diabetes mellitus, hypertension, and hyperlipidemia. Abdominal girth was a very useful bedside method of detecting or suspecting cases with NAFLD and with NASH. And majority of our patients exceeded the normal abdominal girth of 85 centimeters for males and 80 for females. And majority of our patients ranged between 90 to over 130 centimeters in their abdominal girth. The BMI also reveals that patients were mostly in the BMI range between 30 to over 40. Unfortunately, liver function tests are not a very useful guide in suspecting this diagnosis, since only about a third of the population of NASH in our series, as well as other series, reveal derangement of liver enzymes. The shear wave distribution among our patient group and their gender distribution is reflected in this slide, which show that majority of patients fall in shear wave above 2 and some of them above 4. Low carb diet, as I said, was advised. The compliance is another story. It was observed only in 54% of these patients. The average weight loss after 40 weeks of diet in those who followed the diet was approximately 9.16 kilograms. The weight loss distribution among the group who received thorough instruction on diet revealed that majority lost between 5 to 9 kilos, but some patients far exceeded that and lost above 15 kilos, and these are the people I will focus on. Some people who totally ignored the diet restriction actually gained weight after 40 weeks. The shear wave measurement and weight loss measurement correlated very nicely, revealing that the group who lost significant amount of weight above 15 kilos showed the most remarkable drop in shear wave measurement, indicating reversal of their liver fibrosis to some extent. If we compare average weight loss among those who underwent bariatric surgery, out of the 14 patients, 13 patients showed up to regular follow-up and demonstrated a 38 kilo weight loss after 40 weeks of bariatric surgery on average. The weight loss group comparing those who were on diet alone versus those who were on bariatric surgery plus diet revealed that those who, in a group of people who lost more than 16 kilos, the average weight loss was 23.8. For those who underwent bariatric surgery, it was 38 kilos. This is what happened to their shear wave. Interestingly enough, those who achieved very good weight loss on diet also managed to drop their shear wave as good as the bariatric surgery group. So what else can be done for NASH? The new player is the glucagon GLP agonist drugs, and they are effective in reducing weight. They work through the central and peripheral nervous system through direct activation of the hypothalamus as well as the vagus nerve, and resulting in reduced appetite and food intake. GLP influences reward and motivation reaction towards food. GLP-1 agonists also are known to delay gastric emptying, but this effect has not been shown to affect weight loss. Overall, the mechanisms appear to affect energy intake at resting and not the resting metabolic rate. GLP agonists like liraglutide and semaglutide also have cardioprotective properties. Unfortunately, nausea, most common side effect encountered, led to discontinuation of drugs in 8% of cases. GLP-1 agonist trials demonstrated that semaglutide 2.4 milligram given once weekly achieved better weight loss than 1 milligram once weekly. However, discontinuation of this drug after 20 weeks led to 6 kilograms weight regain. Subcutaneous semaglutide was more effective in inducing weight loss than orally administered semaglutide. Currently, the FDA approved the drug of 2.4 milligrams semaglutide subcutaneously as an anti-obesity medication. Bile acids are other factors involved in development of NASH. It is noted that patients with non-alcoholic steatohepatitis have lesser hepatic expression of bile acids. Bile acids are also known to stimulate enterocyte secretion of gut hormones involved in blood sugar and appetite regulation, including GLP-like substances. So a trial on 141 patients treated with obticolic acid, bile acid derivative, showed that there is significant improvement in liver histology and reduction in steatohepatitis and inflammation. And it also was associated with a 2-kilogram weight reduction and decrease in alanine aminotransferase and gamma GT. However, the patients treated with this drug experienced a rise in cholesterol and serum and insulin resistance. Pruritus was observed in minority of patients on this drug, and more studies are underway looking at different bile acids and different doses. Probiotics and symbiotics are another group of drugs which are under examination for management of obesity, and it was found that gut microbiota imbalance and lower microbial diversity is observed in obese subjects compared to normal weight subjects. People who are overweight or who suffer with obesity show specific microbial flora and imbalance with lower microbial diversity compared to people with normal weight. Obese subjects show lower proportion of Bacteroides and firmicutes than normal subjects. Therefore, the intake of probiotics or symbiotics belonging to the genus Lactobacillus or Bifidobacterium has been shown to result in reducing body weight. Both probiotics and symbiotics have the potential to help in weight loss in obese population. Bariatric surgery remains the most effective way of significant long-term weight loss, has been associated with liver improvement. Unfortunately, when patients present with established cirrhosis or associated cardiovascular disease, they are not very good candidates for surgery. The high cost and lack of insurance coverage is a major obstacle to bariatric surgery, and the overall mortality and morbidity of those small deter many patients from undergoing this procedure. Weight regain is still seen in 30% of cases, and in our cohort of 14 out of 34 patients who underwent bariatric surgery, 4 of them had partial weight regain after 2 years. In conclusion, the role of the clinician taking care of diabetic and obese patient is to recognize this liver condition and alert the patient before end-stage liver disease develops. Common clinical presentation range from poorly controlled diabetes, hypertension, gastroesophageal reflux, sleep apnea, postprandial diarrhea, and upper abdominal pain. Depression is also another symptom that brings these patients to the clinician. The above symptoms appear much earlier than overt liver disease, so early intervention can prevent end-stage liver disease and hepatocellular carcinoma. Simple bedside findings like abdominal girth, BMI measurement are excellent clues to the diagnosis, and the availability of liver ultrasound and shear wave measurement is very helpful in clinching this diagnosis. Weight loss as little as 10% can lead to marked improvement in liver inflammation and fibrosis score. Therefore, every effort should be taken to help patients lose weight by diet, exercise, or medication. Bariatric surgery should be offered to those patients who are unable to reduce weight. The epidemic of obesity in the GCC region, affecting even children and young adults, is a public health problem. NAFLD affects 25 to 33% of our local population, and NASH will affect 5 to 15% of obese diabetic patients. Renal failure affects 10 to 20% of type 2 diabetics, but unlike CKD, the only treatment for advanced liver cirrhosis is liver transplant. The need for liver transplant in our region will be a big burden on the healthcare system. Therefore, health education and public health awareness are the essence to stop the increasing prevalence of obesity, diabetes, non-alcoholic fatty liver disease, and NASH in the Middle East. Thank you.
Thank you, Dr. Najah, for this very comprehensive presentation. Very informative and great job you guys are doing. I just have one question. I mean, we definitely do see the differences in the liver when we do bariatric surgery. So when we go in and do the bariatric surgery, the liver is huge, tough, hard, and then later on, 2 years down the road, if we have to do a lap chole or any sort of procedure on these patients, we go in and the liver is soft. My question to you is, do you think that every single class of the shear measurements benefit the same? Let's say the higher the score, the worse the improvement, or do you think all of them benefit the same? Dr. Najah?
Thank you, Dr. Drazi, for the question. I think
I don't think we can hear you. We still cannot hear you. Yes. Yes.
Do you hear me now?
Yes.
Do you hear me
now
now?
we can hear you. Yes.
Okay. Any significant weight loss, be it by bariatric surgery or by strict diet and exercise, lifestyle modification, will be extremely helpful in modifying the prognosis of these patients. Therefore, I think it is so important that we make every effort to approach this problem early before end-stage liver disease happens, not wait for the full-blown cirrhosis, because at that point it's too late to win the game. As I demonstrated in my second case, when I saw this lady, it was too late to save her liver and she ended up with a liver transplant. So the sooner we get to do the surgery, or the sooner we intervene with education, lifestyle modification, diet, and weight reduction, the sooner we prevent not only NASH, but the cardiovascular complications of obesity. As I said, obesity is a chronic and multi-system disease, and we should approach it in medicine as such. We tend to treat secondary things like diabetes, hypertension, proteinuria, but actually what we should focus on is treatment of obesity, which is the root of all these problems. Yes, I agree with you that whenever you do bariatric surgery, actually one of the problems is the mechanical size of the liver affecting the surgical accessibility.
Absolutely.
And therefore many people in massively obese patients will ask us to do an intervention to reduce the size of the liver to make their surgery safer.
Absolutely. I mean, so a few of the tricks we resort to usually is either to go for, as you mentioned, the GLP analogs. We give them liraglutide for 2 to 4 weeks.
If there are any other questions, I'll be happy to answer.
Sure.
There is, thank you, Dr. Najah, for your presentation. There is a question from Dr. Dalal, and there is more questions in the queue and answer. So, Dr. Dalal, please, your question.
Good afternoon, Dr. Najah. It's nice to see you. Dr. Najah, can you hear me? I think she's having an audio problem. In the meantime, I can start the question because it's mostly a comment or an invitation to all of us, Dr. Amer, Dr. Asad, everyone who's interested. I see Ms. Nagham's camera is on. I mean, we have all these fantastic options, whether it's surgery or it's medical management or visits to qualified dietitians. But this is expensive care that not every patient can afford. And this is not a luxury anymore and not optional anymore. It's mandatory that the government covers or the insurance covers or payers cover this very valuable option of care for patients with obesity. So I want to pick up on your thoughts. I mean, mashallah, Bahrain Diabetes Society has done a lot for diabetes, and now they're moving on working a lot for obesity because we value that if we intervene at that stage, we can do an impact on obesity and diabetes in the future. Should we do something else? Should we think of a society to combat obesity within Bahrain with all the scientists here, members and advocates for our patients? Should we go to the Supreme Council of Health and talk about in the new national health insurance, these modalities should be covered? It's not a luxury anymore. What are your thoughts?
My thoughts, first of all, there are many countries in the world now where the government mandates insurance coverage for obesity treatment, like Saudi Arabia now, for example. Second, we should really limit the propaganda for food delivery of very bad high glycemic food to our pediatric population. The state of California put tax on soda vending machines, and it made a big difference in children. Imagine just raising the price of Coca-Cola delivered at schools made a big difference in the obesity in the districts which implemented this tax on soda. In Bahrain, I see that the social media and the advertisement for food and the availability of things like talabat 24 hours is a big problem. The government really should tax these people and put a limit to it. We can't go on this way and expect results. In the future, it's going to be disastrous. Let's look at our children population. I think Dr. Naseger has published obesity data on children in Bahrain, showing disastrous outcomes. What we offer in school lunches and school cafeterias is very sad. People, I have seen children eating biryani rice at 10 o'clock in a.m. Imagine that. What we're doing to our children is sad. The availability of sugar everywhere and lack of physical exercise, and now learning at home, sitting in front of a computer. I call the last 2 years COVID-15 because my average patient increased between 10 to 15 kilos. And even among the bariatric cases, I have seen weight regain as I demonstrated on my first case. And I said, why? She said, what else can I doing? I'm sitting at home eating. Maybe I don't know if other speakers have seen this COVID obesity epidemic. We should mention this, that a lot of patients, minority took advantage and did exercise, majority sat at home in front of TV and ended up ordering food 24 hours and eating. So we really, if we are to tackle this problem as well as diabetes, we have to work at the nutritional aspect, education of patient, limit the importation of horrible high glycemic foods. Look at the amount of crisps and chips available in our groceries. Look at it at cheap price. So people buy by the bag load for their kids. Sometimes when I go to grocery shopping, I ask mother, why are you buying this? She said, to keep my child quiet. So
I agree with you, Dr. Najah. It's really, this is a hot topic about NASH. I agree with Dr. Dalal and all of the faculty. And as you mentioned, Dr. Dalal, this should be stated at the end of the conference, a letter to be sent to the Supreme Council of Health. And it was yesterday lecture about obesity and women, and specifically women. I think we should also take care, because as Dr. Najah mentioned, that although there is many women working, but there is a remarkable percentage sitting at home and caring kids with the COVID. Again, there is a big problem with the obesity and its complications. So by this, we have really questions. If you can answer it directly, Dr. Najah, I will just try to summarize it. There is Dr. Najla Shamsi asking the probiotics, do you advise certain concentration?
There are good brands available in Bahrain. I don't want to bias the group, but there are, you look for the load of bifidobacterium and look for lactobacillus in the combination. It helps, especially in those constipated patients. It helps regulate their bowel. And when you put patients on diet, generally, especially low carb, they do complain of constipation, by the way. So addition of probiotics help in these people. You should remember that you will not give probiotics without checking that the patient is not immune suppressed for whatever reason. Okay, so it helps, but there is no randomized trial yet showing that it reverses NASH. There is good trial on obesity, which shows it helps in management of obesity.
There is another couple of questions. There was a question about vitamin E and bile acid, maybe bile acid sequestrant, as I understand.
Bile acid derivatives like obticolic acid
Yes.
not
Also,
sequestrants. Sequestrants will work the opposite. You don't want to use them. Bile acid are going to be extremely useful in the future for management of any cholestatic liver disease, like primary biliary cirrhosis, and they have been shown to decrease fibrosis. They're also going to be used to encourage liver metabolism of fat. So instead of storing fat, these bile acid like derivatives are actually encouraging metabolism, not only at the liver level, but at the GLP production in the small bowel, and also they work on the fat cells. So interesting, bile acids have receptors not only in liver, which we thought enterohepatic circulation is restricted to the liver. It's actually working on the gut. It's working on white fat cells, storage fat cells. It works even at the kidney level. So there is a lot of research happening with bile acid derivatives. I expect in the future we'll have very effective compounds. So far, the problem is pruritus, cost, and not enough knowledge about dosing, safe dosing.
the last question is is ultrasound indicated routinely in the workup of the irritable bowel syndrome to exclude NASH, or only in obese diabetic patients?
I think ultrasound is the stethoscope of the GI person. I really think, like echo has replaced the stethoscope in cardiology, ultrasound should be available and taught to every gastroenterologist. And any person who has a high abdominal girth, for whatever reason, you should refer for an ultrasound look at their liver. The first thing you're going to see is fatty infiltration, which is so easy to recognize. You can teach a GP to do this in the outpatient clinic and recognize fatty liver and measure size of liver. What is interesting is as they go from fat to inflammation, their fat disappears and their liver becomes hypoechoic and small. So now with thousands of patients I have looked at, when I see an obese patient coming in with no fat in their liver, I get worried. I get very worried. I say, uh-oh, it turned from fat into fibrosis. The liver margin becomes scalloped and the portal vein becomes dilated, and I always look for these signs. In obese patients who have a normal echogenicity of liver, there's something going on.
Thank you, Dr. Najah, for your nice presentation. And now we will shift for the next speaker, Dr. Amr. You can introduce Ms. Nagam.
It gives me great pleasure to introduce Ms. Nagam Noureddin, who is one of the original teams, MDT team in Salmonia Hospital. However, she left us to pursue a much bigger career elsewhere. She is currently the clinical didactic director of Smart Studio Medical Center. She's also head of clinical department of Bahrain Specialist Hospital, managing teaching menus as well as medical needs. With this, Ms. Nagam, I leave you to present your lecture.
Thank you, Dr. Amr, and thank you for IMDO 5, for all the organizers, for having me today. It's a great pleasure and honor. Without further ado, we'll start today's lecture. Just a second. You can see my screen?
Yes, Nagam, it's clear.
Okay, Dr. Aiman. Yeah, just a second. Heading up. Right. Okay, so today's lecture, we're going to be definitely, so I have no disclosures and no conflicts of interest. And today's lecture is going to be about the complications, the long-term complications with bariatric patients. Now, if you see this photo here, I'd like to start off with that, because as you see here, what defines success? Is it really just the excess weight loss we talk about? Is it the first 3 months after the surgery? Well, if you see this photo, you'll definitely see there's a success in this bariatric surgery. But if you look in between the lines, 6 months down the line, 12 months down the line, is his blood markers okay? We need to start asking these questions. Is he slipping back to his old habits? Is he still motivated to continue? Is he struggling from medical nutritional abdominal pain? And maybe that can be a reason why his weight is dropping so quickly. So we need to ask and start addressing these questions when we start thinking long-term. Now, just a small introduction. We all know that obesity has become an important public health priority because of its link to comorbidities. And we also know that the latter has affected the quality of life and life expectancy, which was very well documented. We also know that the prevalence of obesity and comorbid conditions worldwide prompts for effective strategies. Some of these strategies can be as lifestyle changes, which is the baseline for any kind of changes we need to do for these individuals. But also we know that there are other tools that we can add on to make the best out of it. And by far, we see that bariatric surgeries has importantly proven to maintain that weight over the long run. Now, we should highlight on the importance of nutrition screening here before and after surgeries, which is definitely strongly recommended. Now, I wanted to highlight on ERABs, which is quite of an importance when we talk about good outcomes for patients, particularly bariatric surgery patients. So what I really care about preoperatively as a bariatric dietitian is to look at the prehabilitation. So we look at exercise. We try to focus on the leg exercise to increase the muscle mass. We also like to give an exercise program to improve the breath for these patients as well. We go on a carb loading before the surgery, which really helps after the surgery. And of course, we should not be forgetting the liver shrinking, which is the very low calorie diet given 2 to 4 weeks prior to the surgery. And of course here, smoking and alcohol cessation is a must. So we usually recommend them to, wean off at 1 year before the surgery. And also sometimes it can be as 6 weeks before surgery. Why is pre-op education counseling critical? Because it does allow me as a clinical dietitian to debunk these myths. You know, Dr. Google is definitely something on the rise here, and I get a lot of myths in my clinic pre-op when I'm trying to educate these patients. Education on proper eating mechanics. I also like to establish strong support, a strong relationship with these patients. I want them to feel that there is a sort of, I want them to come back after 6 months or 12 months down the line. I don't want to lose these clients after these surgeries. I'd like to educate on potential nutritional complications, including the micronutrient deficiencies. So the more you educate, the more you're going to get them coming in before the problem exacerbates. And of course, here we reinforce that bariatric is not a quick fix, rather a lifestyle change. So this is a paper I picked up from published by Mechanic et al., quite recent, and it does talk about the preoperative enhanced recovery after bariatric surgeries, after surgery, and in particular the ERABs. It does mention here that the pre-op ERABs clinical pathways should be implemented in all patients who are having bariatric surgery to improve the post-operative outcomes. Now, as a clinical dietitian, what are my 5 major domains of assessment? What do I look with these patients before and after the surgery? We always look at the 5 pillars. So food nutrition is a must. Anthropometrics, of course, the labs of these patients. Nutrition-focused physical assessment is something that dietitians tend to miss out, because if I see the nails, for example, in a cup-formed shape, spoon-formed shape, I would know that they have iron deficiency. If I look at their hair, if I look at their neck, if they have, certain signs of prediabetes. So we need to be, as dietitians, aware of physical assessment as well as other pillars that I've mentioned earlier. And of course, not to mention here the client history. So socioeconomic status is a very important aspect that will really help in the future to give me a good idea where these patients, how much they're able to invest in certain commodities or in certain foods. Now, when I talk about predictive equations, we talk about the most statistically accurate equation when assessing caloric needs for these overweight or obese individuals, which is known as the Mifflin-St. Jean. And we also have to add on to that the physical activity factor to make sure that they're meeting their needs. Now, what are the biochemistries that I look into? So everything from CMP to DEXA, if it's like a major, it's a major surgery, lipids, HbA1c, nutrient screening, CBCs, you name it. So definitely, along with a good multidisciplinary team, we need to look into these before, have a baseline, and of course, compare it 1 year, 3, 6, 9, and 12 months down the line. And other lab tests as deemed necessary, of course. So these are not the only ones that I might be asking the patient to bring along. Now, what is the importance of therapeutic diet? as a clinical dietitian, we have to be disease specific when we talk about certain diets. I can't come to one individual saying, okay, so since you're obese, and compare him with another patient, for example, with renal failure and diabetes, and we give them the exact same diet. So here, the importance of having a disease-specific diet before surgery will definitely help me control the markers, inflammatory markers, probably, you know, the if it's a renal failure, control his electrolytes, and maybe if it's a renal diabetes, a stroke patient, I might be looking into prioritizing what's more important here, probably giving a renal, low-carb, low-fat diet. So it really depends on the kind of patients that come into the clinic and what diet specific we need to tailor these diets to meet their needs. Now, I really encourage METs, which is the metabolic equivalents, because these are things that tend to keep them motivated as to how much they will move, and it's really tailored to meet the patient's needs. So my goal here is 21 METs per week, and when we explain METs, it's basically the amount of energy used to perform a certain task. So maybe, for example, I might have a patient who would like to go, he has a dog and he'd like to walk the dog. So this is a 3 points right there. Maybe I have a client who has his plants are super important to him. So we go for 2.5 and we encourage him to go for things like that. Maybe they're a little bit on the younger side and they like to go for swimming. So that's a 4.5. So then again, trying to mix and match with these and tailoring them to meet these patients' need will give them this motivation to get their 21 METs a week. Now, post-operative nutritional management, these are the pillars that I usually like to include in the nutritional management. So as we mentioned earlier, nutrition assessment, we have the nutrition education and support groups. I really find it very difficult here in Bahrain to find support groups for bariatrics. I want more of these because these will keep these patients motivated for a longer time. And we tend to get the best results post-operatively. And of course, here encourage the follow-up visits, and we'll talk about motivational things to give these patients so they can keep coming back to our clinic. Now, what are the post-op assessment long-term goals? There's a lot of achieving and maintaining, as you can see. So we need to achieve and maintain optimal health, weight loss goals, and of course, promote the intake of healthy food and maintenance of well-balanced diet, promote healthy eating habits to achieve and maintain a healthy weight long-term, and of course, here reinforce the importance of follow-up visits and monitoring. So we need to incorporate CBT. As all of the studies has shown, this has definitely helped with the weight maintenance for these clients in particular. And of course, mindful eating is very important. Now, what have I seen in my practice? Everything from abdominal pain to nausea, vomiting, to constipation, you name it. So the list goes on here. And for people who usually do their surgeries abroad and come into Bahrain, we also can see hospitalized patients with fistulas or gastric leaks. And some people tend to lose motivation, so they might be also ending up with vitamin mineral deficiencies, which definitely here will hinder weight loss. Now, what are the complications that we'll be talking about today? We'll be talking about SIBO, and this is linked to abdominal pain, as we will see. This is we will also be talking about dumping syndrome, non-insulinoma pancreatic hypoglycemia syndrome, which is also one of the complications post-bariatric. We'll be talking about sarcopenia and malnutrition, patyrocystacean, and micronutrient deficiencies. Now, when we talk about abdominal pain, there is two sects to that. So we have a medical surgical reason, and of course, a dietary behavioral and nutritional reason. And as a clinical dietitian, we need to know both so that if any problems tend to be linked to, if they come into our clinic, we need to make the right referrals accordingly. Now, when we talk about SIBO, which is known as small intestine bacterial overgrowth, it's basically the number of bacteria that is exceeding 10 to the 3 organisms per ml. And it's not only that, it's quite also the type of microbial flora which is usually present in, which is very important, it plays a very important role in the manifestation of the signs and symptoms of overgrowth, such as streptococci, E. coli, lactobacillus, and bacteroides. And here, why does this usually happen, and to what kind of patients post-bariatric? Let's find out. As you see that this is a paper by Sabete al, published in 2017. It does talk about the prevalence in lean individuals up to 2.5% versus 15% in obese individuals before bariatric surgeries, and usually doesn't increase after the gastric bands, but it can rise as high as up to 40% after the Roux-en-Y gastric bypass. And this is usually associated with lower weight loss. So this is a red flag we can look at if these patients come in with difficulties losing the weight. So why is bacterial overgrowth nutritionally important? Because as we know, and we will see in the papers down the line, that thiamine deficiencies are usually as a change in the bacterial, due to the bacterial overgrowth, we're going to get thiamine deficiency, we're going to get fat malabsorption deficiencies, we're going to get carb deficiencies, and the more the problem continues down the line, the more deficiencies we're going to be getting, and the more difficult to tackle. So here, what is the gold standard? It's to pick it up. It's usually through an endoscopy with jejunal aspirate of more than 10 to the 5 organisms per ml is usually an indication of SIBO. And of course, the glucose breath hydrogen test, if it's higher by 12 ppm above the basal, then definitely we have a SIBO here. So this is a paper published by PubMed by Shilane et al. And it talks about the small intestine bacterial overgrowth and thiamine deficiency after the Roux-en-Y gastric bypass surgery in obese patients. This was published in 2008. And we see that in this study, which took place in Washington Hospital Center, and they took these obese patients, it was 2 randomized controlled trials. And we see that these obese patients were looked at from the years 1999 to 2005. So the first study, we had 80 patients, 52 were women and 28 were men. The blood work that were done for these patients is the thiamine diphosphate level and the serum folate. And we see that from the 80 patients here, 49% of them had thiamine diphosphate levels less than the lower limit, and 72% of the 49% had folate levels higher than the upper limit, which was an indicator of SIBO. And in 41 patients with normal thiamine levels only, which was 34%, they had folate levels higher than the upper limit. In the second study, 21 patients here, 17 were women and 4 were men, did the same blood work. And we see here that all the 21 had thiamine diphosphate levels less than the lower limit and an abnormal glucose hydrogen breath test consistent with SIBO. Noticeably, the 15 patients received oral thiamine supplements, but repeatedly had a thiamine level which is continuously low in all the 15. Once these 9 of these patients received oral antibiotics therapy, the repeated thiamine levels were found normal. So this is a clear cut, this was a hypothesis, and of course here the result supported the hypothesis that SIBO results from altered gut ecology and induces thiamine deficiency after gastric bypass in obese patients. Now, what are the, how do we tackle bacterial overgrowth? Very simply, as per the paper by Dai Bias, published in 2008, we see here that there's 3 goals. First of all, trying to find the underlying cause if possible. Nutrition guidance and correction of deficiencies is a must, especially if it's like really severe deficiencies. And of course, treat the overgrowth with antibiotics. So what is the proper diet for these patients? We know that they have abdominal pain. We know that they have diarrhea, which has been going on for a while. So they are not very well tolerable to certain foods. Should we give just a FODMAP? Should we give just a gluten-free? Quite not. So what the studies have shown is that therapeutic diet should be a combination of a FODMAP and a specific carbohydrate diet, which limits specific sugars and starches in combination with fruits and veg indicated in the low FODMAP. And of course here, a probiotic with good prebiotics, as shown by all the studies, it's anecdotal evidence in the treatment of SIBO. Now, moving to the next complication, which we all know about, which is the dumping syndrome. I have patients coming 1 year down the line with this complication, and they've lost so much weight. They're really struggling here. And simple as that, they're not knowledgeable of the problem. So once you educate these patients with the problem, they can definitely find a solution. They can go back to their consultant, they can get something fixed up, probably a surgery can be done in this case, for example. So we need to really make these patients aware of these symptoms. And of course, there are nutritional methods to prevent it until the problem is solved. So avoid eating and drinking together. We usually prepare these patients before the surgery so that they know that we should always avoid the solid and liquid foods mixed together. Avoid sugary and fatty foods. Take small bites and chew slowly. Read your food labels, keep a food diary, and definitely here, being aware of the lactose intolerance is part of prevention. Yes. Now, one of the also rare complications, but it is there, it's known as the nasirioblastosis or the hyperinsulinemic hypoglycemic in adults. So this is usually a complication post-Roux-en-Y gastric bypass. And the dietary here recommendations is to go for, very similar to dumping. So go for small volumes, don't give rapidly absorbed carbs, go for mixed meals of high fiber and protein, and small frequent meals. I'll skip the pharmaco-treatment part, moving on to the surgical part. So there is a corrective surgery in this aspect. So probably it can be a gastrostomy tube placed in the ruminant stomach, can provide a method of nutrient delivery direct to the bypass stomach proximal duodenum. It can be a gastroesophagostomy restriction to slow the passage of food into the small intestine. It can be as simple as reversal of the Roux-en-Y gastric bypass or a partial pancreatectomy. Now, also another complication is the sarcopenia and malnutrition. These patients, they tend to forget protein intake down the line. We're talking 6 months, 12 months down the line. So how can I make sure that their muscle mass is still intact? How can I make sure that I need to push the muscle mass as far as possible to make sure that they're still gaining muscle mass down the line? So this is a paper, evidence-based nutritional guidelines for patients with sarcopenia based on recommendations from the American Medical Directors Association. So these are supplements that has shown by science that will increase muscle mass. So whey protein is one of the examples. We can give at a dose of 1.2 grams per kg per day. Leucine is another one. Beta-hydroxybutyrate is another one. Creatine is also one of the supplements. And of course, we should not be forgetting vitamin D and omega-3, which should be part of the supplements given post-bariatric. And just to highlight on the omega-3, so basically, it should be 1.86 grams of EPA per day and 1.50 grams of DHA per day. Now, these different types of whey proteins, as you can see in the table on the right, and definitely here, I do get asked a lot of, from all my clients, what is the best whey protein? How much protein would I be getting? Does it have a lot of lactose or not? So this is a table we can definitely share with our clients so they can make the right decision on what is more suitable to them based on their tolerance and on their goals. And of course, we always go back to food. So food is the medicine. Leucine containing foods are definitely the things that will accelerate muscle growth. So anything from soybeans to steaks to tofus to cheese, beans, nuts, and seeds are definitely here leucine containing. And for vegan patients, you definitely have a chance for bariatric surgeries because these are the protein sources for vegans. And we can, as per science also, we can get a good muscle mass with eating vegan foods. Now, so bottom line, sarcopenia should be treated with the following manner: giving a 60 to 80 gram for females and up to 120 grams for males of protein per day. We need to focus on leucine-rich proteins. We need to focus on not exceeding the 130 grams of carbs per day to maintain that weight loss and increase the muscle mass. Giving the form of complex carbs, vegetables, legumes, and of course, low glycemic fruits. I actually also allow them to read labels. So sugars and certain commodities should not be more than 5 grams per serving. And fibers definitely are here one of the most important aspects to prevent constipation. And when we talk about fats, so I'd like to show this table right here. So as we see the different papers published as we move down the line, and we see here that with proteins, the ERABS recommends up to 120 grams per day. For the carbs, we shouldn't be exceeding 130 grams per day. And for the fats, it's usually mostly recommended in the form of MUFAs, giving 20 to 35% from the total calories from the MUFAs. Now, what is patulous eustachian? This is something that we need as dietitians also to be knowledgeable about and aware about. Why is that? So what happens is that these patients that lose a lot of weight, they lose a lot of fat from the cheekbone, and there's a fat pad right here that usually supports the eustachian tube, which opens and closes. So what happens here with the quick weight loss is that this tube is usually open all the time. So you have complaining of tinnitus, autophony, so hearing one's own breathing, and And how do we tackle this? So just a little bit of a heads up on PET. It was first cited, the first cited case in bariatric literature was published in 2009 by Al-Hamadi et al. And we see here that 141 patients with the gastric bypass were studied by Manoz et al. Symptoms and clinical signs of PET presented in 21% of these cases. So it's interesting that the number of these patients is quite significant here. And when we talk about the more recent study by Pascotto et al. In 2014, we see here that the researchers noted that almost 47% of patients who underwent gastric bypass had symptoms of PET by 6 months post-op. So this is quite significant if you ask me when we do pick up these patients down the line, if they're 6 months post-op or 12-month post-op, and they tell you we have this, and they're complaining of this. So what is the profile of these patients? Usually these patients have lost 15 kilograms in less than 2 months. They're definitely low on protein. They're definitely deficient in vitamin A, might or might not be deficient in B12. And what I usually do is I refer them to an ENT. We correct the protein status. We might be asking of course, the doctor here to give a proper vitamin A supplement to, aid with the vitamin A, to fill in the gaps here. And of course, I, from my side as a clinical dietitian, will be giving vitamin A containing foods. And we encourage fatty acid intake, probably give some B12 here, avoid caffeine, alcohol, and a low sodium diet. Now, what does the research say when we talk about following up on our patients? Unfortunately here, this paper clearly explains by the obesity surgery published quite recently in 2020 here. It does mention that the research continues to suggest that the prevalence of micronutrient deficiencies is increasing while the monitoring of our patients at follow-up is decreasing. And I really wanted to take this time to really light up on this because we really need to find ways to get these patients back. We need to follow up on these patients. So what can be nutrient deficiency causes? We all know that it's the type of surgery, definitely. Food intake is definitely here an important pillar. The pre-op nutritional status to start off with is quite of an importance. And of course, stomach acid plays a role, hormonal changes, their medications. So there are certain medications that will decrease the iron availability, for example, in some cases, or might increase iron absorption in other cases. So we really need to look into the medications here and in between the lines. And of course, their comorbidities. So if he's an obese individual, he has a high inflammation and of course a low iron serum. So these are usually the micronutrients that I like to look at. And these are the papers that have definitely recommended certain doses depending on the kind of micronutrient, vitamin to be taken. So for example, here, just to give a heads up, for example, if you have iron and copper deficiency, okay, so this is basically a microcytic anemia, and you have to pick it up, usually in blood work after the surgery. A B12 folate deficiency would be a pernicious anemia. And a vitamin E deficiency here is a hemolytic anemia. So you need to look into the blood work and know exactly what are they taking, how much they're taking, and if there are any medications that are, hindering the absorption. So for example, let me give you an example of iron. For example, cholesterol-lowering bile sequestrants or PPIs will reduce the bioavailability of iron. Okay, certain females, let's say it's a PCOS individual, she's on oral contraceptives. So she will have higher iron levels in the blood already. So giving a high iron supplement is just going to give her more toxic levels of iron. So we really need to be careful on how to control them. And I always, educate my patients on what to ask the clinician or the surgeon. So let's say your surgeon tells you to discontinue vitamin D because it's already in the 50s range. So till when, doctor? We need to ask, till when should I discontinue it? So this is the questions that we educate the patients to ask because, doctors don't have time. And I think this is like the dietitian's job to light up to patients so that they be more aware of their micronutrient deficiencies. Now, my clinical experience for prevention of deficiency is usually the following. So I usually, if a patient would take a daily adult multivitamin, preferable in bariatric.
To finish, Ms. Naga.
Yeah, we're almost done. Yeah. Okay, so a B complex with thiamine would be about 100 mg. B12 should be either injections or intranasal. So there's different ways of giving the B12. We need to also shed the light on that. Elemental iron with vitamin C to enhance the absorption, of course, and calcium, depending on the kind of surgery, is usually given a range of 1,200 to 1,500 if it's a gastric bypass, or 1,800 to 2,400 if it's a biliopancreatic duodenal switch. And of course, the vitamin D up to 3,000 international units will aid in any, definitely here will be preventing any deficiencies. So practice, monitor labs, counsel patients individually based on the trend of, and severity of the deficiency, encourage frequent follow-ups and lab monitoring. And remember, research shows we will lose up to 75% of our patients to follow up starting from 6 to 12 months down the line. So how do I get them motivated? We need to monitor, reassess them, reach out for support groups, as I said, make small changes, but make these changes. Set the goals, keep a diary of all the foods and things that we are usually eating, and send them to your dietitian, get the lab work done. And most importantly, when they go see that follow-up to the surgeon, on that same day, they should be going to their dietitian as well. Now, just, I need 2 more minutes. So weight recidivism is one of the things that I really wanted to shed light on because it's quite recent. When we talk about, weight relapsing after 2 years down the line. So BMI increasing, so what defines weight recidivism? So basically a BMI increase of more than 35 after experiencing a BMI of less than 35, a BMI increase of more than 5 kg per meter squared over nadir. Nadir is basically the lowest BMI within 2 years post-op. Any 10 kilogram increase from nadir weight regain of more than 25% from the excess weight loss over nadir, and an excess weight loss of less than 50% after experiencing more than or equal to 50% excess weight loss. Okay, so there are many reasons why we regain the weight, and I wanted to finish off with this beautiful wheel of success. This is how I get my patients to, continue their wheel of success with the weight loss, with gaining muscle mass, with having a better quality of life. So just to mention some of them quickly: physical activity is a must for weight maintenance. Plan and shop smart. Eat and drink slowly. Try to avoid skipping meals, and definitely here, eat your carbs, your fat, and your protein. Thank you so much.
Thank you, Ms. Naram, for this detailed presentation. I don't know if there are any questions from the audience. I just have a first question, Ms. Naram, before anyone asks. What's the commonest deficiency you see in your practice?
It's usually iron and thiamine. Vitamin D comes next, but usually it's more, people are more aware. People are more aware of the vitamin D nowadays, especially after COVID. But it's usually the thiamine and the, as I said, and the iron, definitely.
Especially after malabsorptive procedures. Any other questions, guys?
Thank you, Dr. Amr. Thank you, Ms. Nagam, for a nice lecture. We will go for the next session. It's my pleasure to introduce Dr. Khalid bin Thani. He's a consultant physician in cardiovascular medicine, chairman of internal medicine department, Salmania Medical Complex, government hospitals. He's assistant professor in medicine. Dr. Khalid, he will talk today about interesting topic. We would like also to thank Abbott for their support for this lecture. Thank you. Dr. Khalid, the floor is for you.
Yes, thank you, Dr. Asad. Let me share the slide. Can you see the slides?
Yes, it's clear.
Okay, thanks everybody to allow me to share with you this great conference. I thank also Abbott for this gracious support for the conference also. Basically today my task is to talk about the dyslipidemia and the cardiovascular risk. It's one of the subjects nowadays that has a lot of highlight in the field. This is my disclosure. To start with, I would really like to talk about the cardiovascular disease as a leading cause of global cause of death. Wherever you talk, wherever your subspecialty, even you start to maximize your the dangers of your subspecialty. Cardiovascular diseases will come at the top. If you look carefully at from the WHO, the leading cause of premature death globally, cardiovascular diseases comes at the top of the list, and then comes cancer, and then the other non-NCD, plus the diabetes and respiratory diseases. Annually per year, there is 17.3 million deaths per year related to cardiovascular diseases. When you look at in 2015, the ischemic heart disease was the leading cause of 4 years of lost of life, accounting for 9.5 globally. So it is a big burden. The research is still going on in finding out specific reasons and also specific treatment for specific cardiovascular diseases. So when you look, let me minimize this. Okay, so when you look at the mortality, even in our region, we are not far away from the other global regions all over the globe. We still have that the ischemic heart disease at the top of the list. So the North Africa and the Middle East, if you look at the ischemic heart disease and the ischemic stroke, it comes at the top of the list. So cardiovascular disease is number one. As we said, it's account for 17.9 million people die each year from cardiovascular disease, and 31% of death due to cardiovascular worldwide, and 85% of death due to heart attack and stroke. So when you look at the Gulf cardiovascular diseases is the most common cause of death. As I mentioned in the previous slides, accounting for around 45% of all mortalities. Patients that present with heart attack in the Middle East are 10 to 12 years younger than those in the Western countries. This calculation is not far away here in Bahrain even. The mean age of, what do you call it, myocardial infarction, it is 60 years, which is less than the average. We are younger than the Western countries, with their mean age are 70 years. So the increasing prevalence of obesity is directly associated with the increase in lipid disorder and type 2 diabetes. I think in this conference we have shared a lot about regarding obesity, and it is the direct association with lipid disorders and type 2 diabetes. For my task today is the dyslipidemia. It is an abnormally high concentration of lipids, and is one of the main risk factors for the development and progression of cardiovascular diseases. So look at this. We are trying to shed light on specific subjects, but still, if you look at the smoking, obesity, and sedentary lifestyle in our region, it's reaching very high rates, by the way. If you look at Bahrain, the percentage of death due to cardiovascular disease is around 26%. If you look at the smoking, then you have 1/4 of the population, they are smokers. We are not far away from other GCC countries, by the way. And if you look at the overall obesity, yes, 1/3 of the population is obese, by the way. The GCC regarding the control of comorbidities. Now we are having difficulty in controlling the comorbidities in our population, and it's one of the most important. It's most importantly, it's based on the clinical evidence that it's available. You can see that trying to control hypertension, dyslipidemia, and also trying to control hypertension, obesity, and trying to control hypertension and diabetes. So according to the modern guideline, the healthcare provider don't control blood sugar only. We're trying to control other comorbidities at the same time in the same patient, by the way. So dyslipidemia, if you look at the dyslipidemia of type 2 diabetes and metabolic syndrome, we are dealing with a very special type of patients. Namely, we are dealing with patients who has high triglyceride, and they are having very low HDL and non-sensible small dense lipoprotein particles. All this affect and cause the atherogenic lipid profile for these patients. And by the way, it's the most common lipid profile in patients with coronary artery disease, around like 60%. I hope you can see my slides. Okay. So in terms of the macrovascular residual risk in patients with type 2 diabetes mellitus, still, despite all the studies that have been done, regardless if it was a primary prevention or a secondary prevention, you look at the subtypes of these patients, diabetic population, still the event rate is on the higher side. Actually, in this meta-analysis, the event to try to prevent these events or the events not avoided have reached a very high percentage, 77%. So still, despite being on statin therapy, despite being on trying to control other comorbidities, the events not avoided are still on the higher side with all the meta-analysis that shown here. So while the LDL cholesterol lowering with the statin reduced the cardiovascular risk, a substantial residual risk remains. So still we have a way to go to try to reduce the risk. Again, in meta-analysis, the cardiovascular risk reduction following statin therapy, still we have 78% residual risk that we are unable to achieve despite the fact all the available risk factor modification available in the market. So what about aggressive LDL cholesterol lowering with maximal doses of a statin? Does not eliminate residual cardiovascular risk. So even if you try to maximize your statin therapy, still there is a gap between or trying to control the risk factor and control also the residual risk. If you compare between the 80 milligram atorvastatin and 10 milligram atorvastatin, with it's only like 2.2 absolute risk reduction, and still the residual risk is still present in these patients. So despite the benefit of the LDL lowering, 60 to 80% residual risk remains. Still in the guidelines, we are stick to the importance of statin therapy, and it's one of the mainstay controlling these patients. Plus, the LDL is our target to reduce, and the lower is better, as all of us we know. But still, the residual risk remain despite treatment with lipid lowering agent, both in the primary and secondary prevention in these patients. So the incidence of major cardiovascular events and the level of LDL in patients receiving moderate to high intensity statin, if you look carefully here regarding patients experiencing major cardiovascular event, even in the improvement TIMI-22 and the IDEAL and the TNT trial, still there is no major difference between the moderate intensity and the high intensity statin therapy, but still a patient who developed cardiovascular ACS or MIs, we prefer to start them on high intensity statin therapy, but still there is the risk that we are not able to attain. So what are the factors that influence the ability to achieve desired LDL level? A failure to achieve optimal LDL levels. We are having multiple factors. We have the limited access to optimal therapy, difficulty with adherence, inability to tolerate optimal therapy, and genetic variability in response to these patients, and insufficient control with maximum doses of lipid-lowering therapy. So these and other causes alone or in combination can lead to a failure to achieve the desirable level of LDL. Not to say our type of patient that's available in the region. So what is this residual risk that we are talking about? We are talking about the non-HDL cholesterol. So if you look at patient reaching the LDL target, but not the non-HDL target, have a 32% significant higher cardiovascular risk. So if you look carefully among these patients, once you achieve that the target of the LDL less than 100, if you don't achieve the non-HDL cholesterol, still you are having a higher hazard ratio. So the strength of this association was greater for non-HDL than for the LDL and the ApoB. So basically, in this collection of data of 62,000 patients, has clearly identified that patients who did not achieve non-HDL target, even if you achieve the non-HDL target, you are still having risk of cardiovascular event despite trying to achieve an LDL target. So the LDL and the non-HDL goal declined at higher triglyceride level. So if you look at the non-HDL goal, attained was suboptimal in people with diabetes and coexisting cardiovascular disease. This was most marked at higher triglyceride level, possibly due to higher level of triglyceride-rich lipoprotein. So we are dealing with an atherogenic, basically, molecule, which is the triglyceride-rich lipoprotein, that continuously and inversely associated with the triglyceride concentration, and then also associated with a higher cardiovascular residual risk. So when we talk about the non-HDL cholesterol, the advantage as a target for the treatment, the non-HDL is basically the total cholesterol minus the HDL. So the non-HDL includes an assessment of all ApoB containing lipoprotein, namely VLDL, ILDL, and even the lipoprotein little a. So the non-HDL is indirect estimate of the LDL particle number. So what about the non-HDL? It makes no assumption about the relationship between the VLDL and triglyceride. And if you look at patient in diabetic patient, this relationship can be altered, leading to a falsely low LDL values as calculated by the free world formula that we know, all of us we know. So practical advantage does not require fasting. It's easily calculated, can be used in patients with triglyceride more than 400 milligram per deciliter. So the disadvantage of using LDL is the methodologic limitation of its calculation, because the LDL it's calculated as the total cholesterol minus the HDL minus the triglyceride divided by 5, which is the free world equation. So the method is valid only for values obtained during fasting state and becomes increasingly inaccurate once the triglyceride is more than 200, and invalid when the triglyceride more than 400. So what are the guidelines says, by the way? So this is the summary of all the guidelines. I guess most of you know that the lower is better nowadays. We are trying to risk stratify these patients to extreme and very high and high risk groups. Our target, I would say, is LDL less than 70 and non-HDL less than 100, especially for the very high. Now, for the extreme, we are aiming at 55 and 80. So remember these numbers, because these cardiovascular patients or high-risk patients, when they come to the clinic, you are trying to, as much as possible, to attain. I usually ask my residents to remember the numbers, which is 55, 70, and 100. So this is the cutoff, and try to, reduce it as much as possible for the LDL. And for the HDL, the cutoff is 80, 100, and 130. So the EAC guideline 2019, the treatment goal for the LDL, as I mentioned, that the cutoff is 55 for very high risk patient, and 70 for the high risk patient, and 100 for the moderate. And for the low one, you can reach until 116. So what about the non-HDL cholesterol and the statement that comes out from the ESC, European Society of Cardiology guidelines, that the non-HDL has been shown to have strong predictive power. The non-HDL is simple to calculate. Both Fried-Wald formula and direct LDL estimate have limitations subject with hypertriglycemia and in subject with very low LDL. So the non-HDL should be used as a secondary target when the LDL goal is reached. So once you achieve your target LDL, aim for it. Aim for the non-HDL cholesterol. This is the guidelines. I will zoom into it in a while. Basically, this is the statement that comes of the recommendation for the lipid analysis for cardiovascular risk estimation. I will zoom into it. So basically, the recommendation, it comes as class 1, that total cholesterol is to be used for estimation of cardiovascular risk by means of score system. And all of us, we know the score system for these patients. You can calculate it, and there's a calculator for that. The HDL analysis is recommended to further define risk estimation using the online score system. And the LDL analysis is recommended as the primary lipid analysis for screening, diagnosis, and management. And lastly, I would say that triglyceride analysis is recommended as part of the routine lipid analysis. So you have to get the triglyceride. What's next? The non-HDL cholesterol, it is there in the guidelines. So evaluation is recommended for risk assessment, particularly in people with high triglyceride, diabetes, and obesity, or very low LDL. The same thing that accounts also for the ApoB analysis recommended for risk assessment, particularly in people with high triglyceride, diabetes, obesity, and metabolic syndrome, or very low LDL. So it is in the guidelines. So when you receive a patient diabetic with metabolic syndrome, do it. I mean, it's now a part of our lipid panel assay that we usually do to make sure about the how controlled is the patient. Dyslipidemia, how we define it is represent a cluster of lipid and lipoprotein abnormality, including elevation in both fasting and not postprandial triglyceride, ApoB, and small dense lipoprotein LDL, and also low HDL and ApoA1. So the last thing is regarding the atherogenic dyslipidemia. Is one of the major risk factors of cardiovascular disease. I think we discussed it now in thorough, in people with type 2 diabetes and in people with abdominal obesity and insulin resistance or impaired glucose tolerance. So as per the guidelines, the LDL is the main focus. As per the guidelines, the LDL is not always sufficient to prevent atherosclerotic cardiovascular disease in at-risk individual. The goals for non-HDL and ApoB and triglyceride. The non-HDL reflect the total atherogenic burden for these patients, so test it and calculate it. What about the American Academy for the Endocrinologist? I think it's not far away from the European Society of Cardiology. The statement is clear regarding the non-HDL, and these patients should be calculated to assess risk stratification in individual with moderately elevated triglyceride, 200 to 500 milligram per deciliter, diabetes, and or established atherosclerotic cardiovascular disease. What about in our region? I mean, there is a consensus recommendation for the management of plasma lipid disorder in the Middle East that came in 2016, and namely, they recommend reducing elevated plasma triglyceride level as a secondary treatment goal. And they recommend that the triglyceride level more than 200 warrant treatment. So patient has more than 200 milligram per deciliter of triglyceride warrant the treatments, and there is an underlying atherogenic dyslipidemia. So what about the triglyceride as an independent risk factor for cardiovascular disease? So as we discussed, the non-HDL should be calculated to assess risk stratification in individuals with moderate elevated triglyceride, diabetes, and established atherosclerotic cardiovascular disease. Namely, for the triglyceride, the triglyceride level should be part of routine lipid screening. Moderate elevation, more than 150 milligram per deciliter, may identify individual at risk for insulin resistance syndrome, and level more than 200 may identify individual substantial increase of atherosclerotic cardiovascular disease, as we mentioned earlier. And even in our region, we are getting the target of 200 as substantial risk that these patients has an increased risk of atherosclerotic cardiovascular disease. This is the classification for our elevated triglyceride level. Borderline elevated is 152 to 199. And once you hit 200, it is high. And once you go to 500, it is very high. What about the triglyceride-rich lipoprotein cholesterol, small dense LDL cholesterol, and incidence of cardiovascular diseases? I think the triglyceride-rich lipid cholesterol strongly associated with the future MI and peripheral vascular disease event, whereas the LDL is strongly associated with MI alone. So if you have a patient and the patient has lipid-rich triglyceride cholesterol, the patient is not only prone to MI, they are prone also to other atherosclerotic diseases, especially the peripheral artery disease. So the triglyceride is an independent and significant associated with coronary artery disease. It is associated mainly with increased premature familial coronary artery disease, even with elevated triglyceride. So begin at a mild and relatively common triglyceride elevation of just 200 gives you a hint that the patient has a risk for premature familial coronary artery disease. So how would we manage such patients? We have the fenofibrate treatment, and all of us, we know that the fenofibrate optimizing the cardiovascular outcome in type 2 diabetes, the relative risk reduction was in the field and the Accord study around like 30%. If you look at the statin with fenofibrate, reduced risk of major cardiovascular event in a lipidemic patient with type 2 diabetes, with relative risk of 30%, around 30%, as we mentioned. If you look at the combination of fenofibrate with atorvastatin, to improve the lipid parameters, and also the 10-year probability of myocardial infarction reduced from 21 to 44.2%. So the combination works. The combination also safe. If you think about rhabdomyolysis in these patients, fenofibrate resulted in 15 times lower rhabdomyolysis reported rate than did ginfobrazil, as reported in FDA safety report. So the combination of statin with ginfobrazil enhanced the risk of myopathy, and is associated with statin must be avoided. There is no or very little increased risk of myopathy when combining statin with other fibrate, such as the fenofibrate, and this comes from the ESC guidelines 2019. So it should be safe, and your patient should be in safe hands. What about the fenofibrate in hypertriglyceridemia? Is it in the guidelines? Yes, it is in the guidelines, class 2B, level of evidence of B. In primary prevention at LDL goal with triglyceride more than 2.3 millimole, or like 200 milligram per deciliter. Fenofibrate or bezafibrate may be considered in combination with statin. What about the usage of the omega-3, EPA, and the DHA? Favorable effect of the combination on the lipid profile. The combination has greater effect on reduced triglyceride and the non-HDL. As you can see that the change in lipid and lipoprotein lipid after 8 weeks of the treatment is really pronounced. It has an effect in controlling the triglyceride level. Patients with diabetes benefited from the combination in terms of triglyceride and non-HDL reduction, especially in patients with diabetes. And the combination of atorvastatin and also the omega-3 has a pronounced effect on the triglyceride and the non-HDL cholesterol, namely for the triglyceride 31% reduction, and for the non-HDL 11% reduction. So regarding the combination with rovastatin combination, I think it has the same kind of effect with the atorvastatin, with 26% reduction and 10%. 26% for the triglyceride and also for the non-HDL of 10%. Relatively comparable if you look at the atorvastatin combination. And the most important treatment patient with dyslipidemia is a statin. So still it's our mainstay for treatment, which mainly lowers the LDL. And then you have to target the non-HDL atherogenic patients. Despite the fact that the statin does not control the triglyceride level effectively, you have to add something to control it. And having the combination has been proven to be safe in these patients. What about the non-HDL? is a major inclusive measure of, as we said, about the atherogenic ApoB containing lipoprotein. It is a strong predictor, by the way. It serves as a strong predictor for cardiovascular disease. And the combination have been shown that patients with diabetic and patients with no diabetes, that the reduction is still attained, despite the fact that the patients have been not diabetic. Basically, the percentage of reduction is not that much pronounced as the patients with diabetes. So what about the AHA advisory regarding the usage of omega-3 fatty acids? So all prescription agents appear comparatively effective, but head-to-head comparison are lacking. This in regard to the prescription of the omega-3 fatty acid, APA, DHA, or APA only. In patients with very high triglyceride, the statement is clearly that treated with prescription EPA and DHA product increased by 15 to 36%. However, there was no increase in ApoB, suggesting that the increase in LDL may reflect an increase in the average size of the LDL particles. So there was some sort of concern regarding the LDL, but I think this is related to the particle itself, not related to the level itself. In summary, so patient triglyceride 200, the summary statement is to go for 4 grams per day. The same thing for triglyceride more than 500. And the use for other lipid-lowering therapy is safe and apparently additive to the triglyceride reduction with the statin therapy. So, and safe with the fibrate even, if you want to add fibrates. Lastly, the last thing for my talk is regarding the ESC recommendation for the hypertriglyceridemia. And I would just read it out loud that the omega fatty acid can be used at pharmacological doses to lower the triglyceride. The omega-3 fatty acids affect the serum lipid and lipoprotein, in particular VLDL concentration. The underlying mechanism is poorly understood, although it may be related to least in part to their ability to interact with the other PPRA and to decrease secretion of ApoB. I guess the Europeans colleagues are still talking about the mechanism of action, despite the fact the effect that is seen in the studies regarding the use of omega-3 regarding the triglyceride. This is for my talk.
Thank you, Dr. Khalid, for your nice presentation. There is a couple of questions from the audience. First question from Dr. Muhammad. Can we take statin as a prophylaxis and at what age?
Okay, well, I mean, you have to calculate your atherosclerotic cardiovascular risk before saying that you want to add like statin, because still, I mean, taking the statin has the risk of having the side effect. There is some data out there using the statin as a prophylactic usage. Then like in the, what do you call it, in the prevention of cardiovascular diseases, using very small doses of statin. But I would highly recommend that you should calculate your risk before like going and like, you know, and even for your patient, you have to calculate the atherosclerotic cardiovascular risk, and then you may recommend the patient to start on statin therapy.
Almost similar question, but in dyslipidemia treatment for primary prevention, when should statin used? And which risk score you recommend? Thank you, sir. It's already answered, I think.
I think you should go to the. We are more with European guidelines. I think the score system plays a major role, and also the atherosclerotic cardiovascular, which is the counterpart when you cross the Atlantic. You can calculate the risk, and then once the risk more than 11% for atherosclerotic cardiovascular disease, then you may consider for these patients to start statin therapy. Yeah.
Another question: should all diabetics be on statin irrespective of LDL level?
Irrespective of LDL, this is a very good question, Dr. Asad. It's especially addressed for the diabetic. Look at their also if they are atherogenic. Look at their non-HDL. If it is high, you may consider actually. I mean, you are covered by the law now that just say, well, I mean, this patient atherogenic patient, and the profile is showing some sort of risk factor, so you can justify starting with the statin in these patients.
From Sima Mukhtar Baqar, a person with no risk factors for cardiovascular disease, at what LDL level you will start treatment?
With no risk factors.
Yeah.
Okay, now you have to look at if this patient is heterozygous or homozygous. I mean, what level we are talking about? If the patient has a very high level with other clinical features of what do you call it, atherosclerosis, with very high lipidemic blood, I would say, then you may start the treatment for these patients. You wouldn't leave them. These are, I'm talking about the homozygous familial hypercholesterolemia patient. Now, if you look at patients with heterozygous and a very high lipid panel, then you may consider these individually, and you look at the level. I mean, what specific level you are talking about, depends on that, we can start the treatment.
From Najla Shamsi, for how long should we continue use both statins and fenofibrate after reaching the triglyceride target?
Okay, very good question. There are some authorities, they recommend, it's like a consensus regarding once you achieve the LDL level below 1, you may consider, like, step down some of the statin therapy that you have started for the patient, okay? But we don't usually recommend this for atherosclerotic cardiovascular disease patient, by the way. So be cautious in, like, stopping the therapy. Communicate with other colleagues, because you have wide variety of patients you see in the clinic. So I would just say an example, if a patient MI, even if you after the control of your cholesterol, you may be reluctant in, like, stopping the statin therapy in such patient, unless the patient has some sort of side effect related to the drug or to the therapy. Then you may consider stopping, grace period, and then re-challenge again with the statin therapy.
Thank you, Dr. Khalid. By this, we will finish with this session. Thank you very much for your interesting lecture. And now we will hand over for next session. It will be chaired by Professor Barbara McCown. And Professor Barbara, you are here.
Yes, hello. Thank you, Dr. Assad.
I will join you because Dr. Naji will be busy with another commitment, so I will be with you.
Okay, lovely to have you. Thank you very much. So good afternoon, everybody, and welcome to this next session. Our first speaker is Professor Mahir Jallow, and he is a clinical professor of medicine and senior consultant in internal medicine, diabetes and endocrinology at the Gulf Medical University in UAE. He's very distinguished. He's an examiner for the Royal College of the Physicians for MRCP. He is an editor-in-chief for Diabetes Digest from Iraq, and also on the editorial board, a member and reviewer for many international journals. So he's also been awarded as special awards, special honors, and recognition. He's a clinical professor of medicine and senior consultant in my very pleasure to welcome him to give this lecture on the long-term effects of gestational diabetes. Professor Mahir. Professor Mahir, I think you're on silence.
Thank you very much for the nice introduction, and thank you, Dr. Asad and the organizing committee for giving me the chance to participate in this beautiful conference. So my talk today about the long-term effect of gestational diabetes. This is the campus of our university and our teaching hospital. This is my disclosure. I have no disclosure for this presentation. So the objective of my talk is to summarize the recent update about the long-term adverse effect of gestational diabetes on mothers and children. I will not cover any complication related to the pregnancy or the postpartum follow-up because it is covered by other colleagues. I will concentrate only on the long-term adverse effect of GDM on mothers and children. We know that Gestational diabetes is well known to be associated with an increased future maternal risk of type 2 diabetes. And a meta-analysis of more than 675,000 women with up to 28 years of follow-up showed that women with GDM have a more than 7-fold increased risk of developing type 2 diabetes. In recent years, more studies have shown that there are other long-term medical complications associated with GDM. The cardiovascular disease. Cardiovascular disease, including coronary artery disease and stroke, is the leading cause of death in women. In 2006, in a cross-sectional study of 994 women with a family history of type 2 diabetes, 332 with gestational diabetes and double this number without, Carr et al. First demonstrated the relationship between gestational diabetes and the future maternal cardiovascular risk. Those with the prior gestational diabetes were even more likely to not only have cardiovascular disease risk factor, including the metabolic syndrome, type 2 diabetes, but also to have experienced cardiovascular event which occur at a younger age. In 2008, Shah et al. From Canada conducted a population-based retrospective cohort with more than 8,000 women with gestational diabetes and the same number of women without gestational diabetes, with follow-up of 11.5 years. And they found the young women with gestational diabetes have a substantially increased risk for cardiovascular disease. Then after 1 year, in 2009, the same group further stratified the population into 3 cohorts: a cohort with gestational diabetes, or another cohort with women with an abnormal 50-gram glucose challenge test, but a normal OGTT, and women with a normal 50-gram glucose challenge test. And they found that both women with gestational diabetes and women with an abnormal 50-gram challenge test had a higher risk of cardiovascular disease on follow-up. This is the Kaplan-Meier survival curve for cardiovascular disease and coronary artery disease event and hazard ratio derived from this study. Those patients, the event-free gestational diabetes, and this is no gestational diabetes, and there is statistically significant difference. On the other hand, they follow the other patient who saw that the patient with cardiovascular disease in women with gestational diabetes, the black line, women received an antepartum oral glucose tolerance test, but did not have gestational diabetes, the brown one, and women did not receive an antepartum oral glucose, the green one. Also substantially difference between the patient with or without gestational diabetes or positive 50-gram glucose challenge. And this is replicated in many studies. 2013, a group from Israel did a population-based study of nearly 5,000 women. And they found at follow-up period of more than 10 years, women with gestational diabetes have higher rate of cardiovascular morbidity. 2004, from Sweden, conducted a population-based matched case control study, and they found the adjusted odds ratio for association of cardiovascular disease with gestational diabetes 1.51. 2017, another group from the US had a population-based study, 8,000 women. It showed women with a previous history of gestational diabetes have a significantly higher risk of developing cardiovascular disease and lower serum level of HDL cholesterol. Another group from the US, Tobis et al., by a large prospective cohort of more than 90,000 US women older than 26 years, women with a history of gestational had 43% greater risk of cardiovascular disease. And in 2018, a group from the UK, by studying a retrospective cohort with more than 9,000 women diagnosed with gestational diabetes and 37,000 control women found women diagnosed with gestational diabetes were at very high risk of developing type 2 diabetes and had significantly increased incidence of hypertension and ischemic heart disease. McKenzie from Canada, with a retrospective cohort study, 67,000 women with gestational and more than 1 million women without gestational of maximum 25 years follow-up. It shows that women with gestational diabetes had a higher cumulative incidence of hospitalization for cardiovascular disease 25 years after delivery compared with no gestational diabetes, and the admission numbers is significantly different. So to summarize the cardiovascular study, 2 important systematic reviews in the past year. In 2018, Jing et al. Retrieved 7 cohort study with more than 3 million pregnant women, including 14,000 incidence cardiovascular event. Women with prior GDM were 1.74-fold risk of cardiovascular disease of those without. And the gestational diabetes was associated with significantly higher risk of both coronary artery disease and stroke. So it remained to explore whether the increased cardiovascular risk was due to elevated level of other cardiovascular risk factor. And the other meta-analysis in 2019, Caroline et al. Did a pooled analysis of 9 studies, more than 5 million women and 101,000 cardiovascular events. It showed that pregnant women with gestational have a 2-fold higher risk of cardiovascular event postpartum compared with their peers. And this is coming to the American Heart Association and includes the history of gestational diabetes in their classification of cardiovascular risk factors in women. So they put gestational diabetes with 60% higher risk of myocardial infarction and 4-fold higher risk of diabetes mellitus. What about the chronic kidney disease? CKD is a common condition with an estimated global prevalence around 13.4%. Early evidence show women with gestational diabetes have a higher prevalence of microalbuminuria than women without any history of diabetes. Emerging evidence reported an association between gestational diabetes history and the subsequent renal morbidity. Beher et al. Conducted a population-based study and found women with GDM had higher rates of total renal morbidity. In 2018, Rawal et al. Did a long-term follow-up of women with GDM within the Danish National Birth Cohort and the Nurse Health Study too. They found women who developed gestational diabetes in a pregnancy were more likely to show an increase in the eGFR level 9 to 16 years postpartum, which could indicate early stage of glomerular hyperfiltration and renal damage. What about cancer? There are some controversy about the relationship between GDM and the breast cancer. A systematic review in 2014 include 9 articles documented 5 cohort and 4 case control study containing more than 10,000 cancer case and 14,000 women with a history of GDM. The pooled odds ratio between gestational diabetes and the breast cancer was just 1.01. Another systematic review in 2017 include 5 case control study and 6 cohort study, and it did not find significant association between GDM and the breast cancer. But in 2019, a cohort study in Taiwan showed women with gestational diabetes had an increased risk of cancer including cancer of nasopharynx, kidney, lung, bronchus, breast, and thyroid cancer. What about the long-term fetal adverse effects? Obesity, overweight, and insulin resistance is the main consequences on the fetal as long-term complication of gestational diabetes. So it is known that intrauterine exposure to the maternal pre-existing diabetes or GDM is associated with a higher risk for offspring abnormal glucose metabolism and adiposity. Early evidence demonstrated the association of maternal glucose level during a pregnancy with abnormal glucose metabolism and adiposity in childhood. Whether gestational diabetes independent of maternal body mass index is associated with future metabolic disease and obesity in the offspring was controversial, as much of the earlier result did not control for the maternal BMI. Two systematic reviews have shown the association between maternal diabetes and childhood obesity. In both reviews, the maternal hyperglycemia was shown to be a risk factor for obesity or overweight in offspring, but the association was attenuated or no longer apparent after adjusting for the maternal BMI. Another systematic review come from 2019-18 included 20 observational studies involving a total of 26,000 children. The results show offspring of GDM mother had higher body mass index in childhood. After adjustment for the maternal pre-pregnancy BMI, this association disappeared. So these are some limitations in those studies. Many studies focus on women with a high prevalence of diabetes, making it unclear whether mild hyperglycemia in a pregnancy could have long-term effect on offspring. Maternal treatment during a pregnancy has confounded studies on offspring risk of hyperglycemia. So there is still a clear answer for this question. But the HAPO follow-up study offers a unique opportunity to examine the association of maternal hyperglycemia during a pregnancy, less than over diabetes, and not confounded by the maternal treatment with childhood glucose metabolism. A total of nearly 4,800 children completed all or part of the HAPO follow-up visit. 4 study results came from HAPO recently. Regarding offspring, overweight, and obesity, Louis et al. In 2018 initially found among children of mother with GDM versus those without it, the difference in childhood overweight or obesity was not statistically significant. However, in a 2019 article, they are able to find the positive association between maternal glucose level during a pregnancy and measure of child adiposity in the HAPO follow-up children aged 10 to 14 years, and it is independent of the maternal BMI. What about insulin resistant? In terms of offspring, insulin resistant, Louis et al. Demonstrated that offspring of mother with untreated GDM are at high risk for impaired glucose tolerance 10 to 14 years postpartum. And the Scholten et al. Further demonstrated that the relationship between maternal glucose level during a pregnancy and child glucose level and related outcomes was generally linear across the spectrum of glucose level, including level below those diagnostic of GDM. What about the neurocognitive development of the child? The development of GDM coincide with the period of the rapid fetal brain development. And recent studies have shown that GDM has long-term adverse effect to offspring in neurocognitive development. Numra et al. Revealed the maternal GDM is associated with an increased risk for the attention deficit hyperactivity disorder at age 6 years. And Tina et al. Showed the offspring of women with GDM had a lower global cognitive score. Another study in 2018 found the GDM and maternal blood glucose level are associated with offspring in neuronal activity during an attentional task at both 6 and 18 months. Such electrophysiological difference are likely functionally important, having been previously linked to the attention problem later in life. And a systematic review and meta-analysis included 12 studies involving more than 6,000 infants up to 14 years. This meta-analysis found the association between GDM and deleterious effect on the maternal psychomotor development and overall intellectual function in the offspring. This study must be taken with caution. A direct causal influence of intrauterine hyperglycemia is still uncertain. A recent meta-analysis in 2019 included a total of 9 studies with more than 7 million participants. The results show combining of the cohort study demonstrating that offspring of diabetic mother were at higher risk of attention deficit hyperactivity disorders. What about mild GDM treatment and if have an impact on the long-term maternal and fetal outcome? After decades of uncertainty, the result from randomized treatment trial confirmed that the treatment of mild GDM is associated with immediate short-term maternal and fetal benefit. There is insufficient evidence regarding whether treatment confirms long-term maternal and fetal metabolic benefit. In terms of maternal long-term effect, a recent article in 2019 includes 457 women with mild GDM, 50 treated and 15 untreated, and evaluated at a median 7 years after their index pregnancy. The result showed there was no statistical significance in the frequency of diabetes, metabolic syndrome, and insulin resistant. In terms of fetal long-term outcome, one study showed although treatment of GDM substantially reduced the macrosomia at birth, it did not result in a change in body mass index at the age 4-5 years old. And in the follow-up of HAPO of offspring of women participating in a randomized controlled trial for the treatment of mild GDM, there is no difference in the overall frequency of obesity or metabolic dysfunction at age 5 to 10 years, according to whether the treatment was undertaken or not. So to summarize, treating mild GDM with dietary intervention and insulin when necessary is effective in reducing the short-term maternal and fetal risk. Whether treatment of mild GDM is associated with the future metabolic disease and obesity in the mother and her offspring remain unknown, with the data at the present suggesting no such association, at least in the first decade since delivery. So my conclusion, dear colleague, that gestational diabetes is associated with long-term maternal and fetal adverse outcome. Recent evidence suggests gestational diabetes increases the long-term maternal cardiovascular disease, CKD, and cancer risk. Maternal hyperglycemia is associated with offspring obesity, overweight, insulin resistant, and neurocognitive development. It remains unclear whether treating mild GDM would reduce the long-term maternal and fetal adverse effect. So keep your patient with gestational diabetes as high-risk group, not only for the postpartum follow-up, but through her life, searching for other risk factors for cardiovascular disease, and always calculate her cardiac risk, because for sure they are more vulnerable to future cardiovascular disease. Thank you very much.
Thank you very much, Professor Mahir. That was a very beautiful lecture and a very nice summary of the evidence so far. So it sounds like even with the mild gestational diabetes, we need to look out for future cardiovascular, I guess, risk factors or events. What do you do in your experience? Do you keep these patients under your care, or do you discharge them back to primary care?
Mostly those patients, we have the collaboration with our OB-GYN that those patients after delivery, usually they schedule for follow-up for the search for the metabolic sequelae, future diabetes, but also we will look for other risk of cardiovascular. But probably, unfortunately, most of those probably they are lost after 6 months, after 1 year, and probably we need some proactive system to keep those in touch for future searching of the risk of cardiovascular disease and other long-term complication of gestational diabetes.
Thank you. No, I think that's really important, and perhaps a global database of all these patients and their outcomes in time to come. That's very, very interesting. And can I just ask whether, how do you treat mild gestational diabetes in your patients?
I mean, the majority of patients, probably the dietary advice, and we can say sizable percentage of those patients, metformin will be part of the therapy, unless if we are not achieving the target of fasting and postprandial, insulin therapy will be started for them. Keeping in mind that the glycemic control is very important to keep throughout the pregnancy.
Thank you. Thank you very much. Dr. Assad, any other questions in the chat? I don't see any. I don't think there's any.
I cannot see here.
Okay.
That's interesting lecture, Dr. Maher. Thank you for your lecture. I think we will start the next lecture for.
Thank you. Thank you.
Thank you very
Professor,
much.
let me introduce you, Professor Barbara McCann, a consultant endocrinologist at Gay's and St. Thomas Hospital, a professor in diabetes and endocrinology at King's College London, leads the obesity bariatric service at GSTT for the management of patients with severe and complex obesity. Areas of research interest are in gut hormones and appetite control, pharmacotherapy for obesity and remission of type 2 diabetes, post-bariatric surgeries, and investigator for severe obesity clinical trials, and was awarded many prizes in recognition of outstanding research with the NHS, chaired many obesity and ABCD task force. Yours for you, Professor Barbara.
Thank you very much, Dr. Assad. So hopefully there's going to be a recording soon. Thank you. Hi, everyone, and thank you for inviting me to give this lecture entitled Management of Weight Regain. These are my conflicts of interest. So the learning objectives are, first of all, to understand the physiological changes that happen after weight loss. I will then talk about predictors of weight gain after weight loss to try and understand if they can help us to working out which patients are more likely to gain weight. And finally, we will talk about strategies to manage weight regain. So we're all aware that obesity is a complex and multifactorial disease, and it's a balance between energy intake and energy expenditure. Now, of course, there are many, many different factors that feed into that equation. And we have several hormones from the periphery that sort of talk to the brain, communicate with the brain, hormones coming from adipose tissue, such as leptin, hormones from the pancreas, including amylin, pancreatic polypeptide, and insulin. Of course, there's a very large number of gut hormones, including the hunger hormone ghrelin and the satiety hormones, including GLP-1. Now, interacting with all of this is genetics, and genetics, can predispose up to 70% of somebody's weight, or determine 70% of somebody's weight. So it's a really, really important factor in managing weight. And of course, medications. We prescribe a lot of medications that can really lead to significant weight gain in our patients. Now, these factors are interacting with the environment. And we have lots of patients with an inactive lifestyle who may stop smoking and increase weight. And of course, psychosocial factors involved and influencing their weight. And then on the other side, we have the hedonic input, the texture of foods, the palatability of food, the pleasure of food, of course, and all of that also feeds into the equation to determine the balance between energy intake and energy expenditure. Now, all of us have a fat mass set point, which I've depicted here with the black line. But there are many, many factors that are trying to push that set point further up. And here they are. So we have unhealthy diets. A lot of us have unhealthy diets, abnormal dietary constituents, cheap, ready-made food, which is not good for us, which can push that body mass set point up. Lack of exercise. A lot of us are not as active as we used to be several years ago, but that's also playing a part. And I don't think there's any of us in this room who's not sleep deprived or stressed. And again, that can have an impact. There are also people with disrupted circadian rhythms, for example, night workers or shift workers. And again, that will have an impact and a role. And of course, I've mentioned the impact of weight gain inducing medications. Now, of course, if we have years of exposure of poor diet, lack of physical activity, sleep deprivation, stress, and so on and so forth, this is going to push that set point even further up. And so, after several years, this is where we are, and it's really, really difficult to shift. So what can we do to shift it? Well, of course, we can think about lifestyle modifications, and we can think about addressing our diets and eating healthier food, less processed food. We can think about more regular physical activity, which can certainly improve and try and push that sort of set point down. We can try and sleep more and better if we can, and try and reduce our stress levels. We can also try and have stable eating patterns and less erratic eating, trying to avoid eating late at night, for example, and having a more regular pattern in our lifestyle. And then when we think about medication, trying to avoid those really kind of, medications that are going to lead to weight gain, and really try to avoid those if possible at all. Now, if lifestyle fails to get us to where we want to be, of course, we can then reach out to anti-obesity medications to help us regain our set point. And then, of course, finally, a bigger push with bariatric surgery if both lifestyle and pharmacotherapy has failed to get us to where we need to be in terms of improving health. Now, we all know that maintenance of weight loss is challenging. So here are several publications with different lifestyle interventions, and with pretty much all of them successful to some extent with different amounts of weight loss. But what we do know is that for all of these lifestyle interventions, after 4 to 7 years, that weight is regained, and sometimes beyond the original weight. Now, what are the causes of weight regain? Well, of course, we continue to have the environment that plays a role. So whatever the intervention, there's ongoing exposure to an obesogenic environment which doesn't go away. And even if you've had surgery, we're still exposed to that environment. So again, the obesogenic, not temptations, but really sort of, the poor food, poor quality of food is still there. And so we really have to make a sort of conscious choice to try and really navigate our way through this environment. Lifestyle factors. So unhealthy dietary content, we might be still eating poor calorie content of food. We may be continuing in an active lifestyle, and of course, ongoing stress and emotional factors in our life. And again, there's the impact of weight-promoting medications, which may still be having a role in terms of leading to weight regain. And last, but of course, importantly, the biological response. And I'm going to talk about this in a second, about why it's so important to understand that there is a lot of biology that is that's driving that weight regain. So who does well when it comes to maintaining weight loss? Well, if we look at the National Weight Control Registry, it's suggesting that those patients who lost weight and maintain weight tend to limit their intake to certain types of foods. They consume an average of about 1,400 kilocalories per day. And the breakdown is an average of about 25% from fat, about 20% from protein, and 56% from carbohydrates. They tend to eat 5 times a day. And they also tend to burn an average of 2,800 kilocalories per week through exercise, or 400 kilocalories per day, or 60 minutes of walking at about 15 minutes per mile. Okay, so these are the people who are going to do well. So those who control their dietary calorific intake and also exercise regularly. What about other predictors of weight gain after weight loss? And there was an interesting review in Nature published in 2019, looking at different studies and different types of predictors. And I've just sort of picked some of these for you here. So those patients with an increased initial weight loss are associated with greater weight maintenance. If you lose a lot more at the beginning, you're more likely to do well in terms of maintaining weight. If, on the other hand, your perceived exertion during suboptimal exercise is higher, I guess, that's associated with weight regain. The use of antidepressants is associated with a return to baseline weight, which is probably expected. Now, increased satisfaction with weight loss is associated with weight maintenance. If you're happy with your weight loss, then you're more likely to do well. Of course, genetics plays a huge role, and research shows that the FDO phenotype, for example, predicts weight regain. And then epigenetics, so that's a level of methylation, and the level of methylation in the MPY and POMC promoter neurons. So remember, MPY and POMC are very important neurons in the hypothalamus, which play a role in satiety and appetite. So anyway, the levels of methylation in the MPY and POMC promoter is associated with weight maintenance. And what about the biology and the biological response? So we know that science has really discovered that there are physiological responses to weight loss that trigger weight regain. So we know that there is usually a decrease in satiety hormones when we go on a diet and lose weight, and there is an increase in hunger hormones, which leads to an increased desire to eat and increased hunger. And even 1 year after the weight loss, our brain remembers these changes in hormones, these changes in hormones have still not gone back to baseline, and there is an increased hunger and desire to eat. And that's why it's so difficult to maintain weight loss after a diet usually. So this is what happens. So after weight reduction, the brain is stimulated to increase caloric intake because of changes in these hormones. So leptin goes down because there is less adipose tissue after a dietary intervention, usually with weight loss. Our hunger hormone ghrelin increases and our satiety hormones, including GLP-1, decrease. And this leads to an increase in appetite and an increased preference for energy-dense foods, high in fat and high in sugar. Not only that, but our resting energy expenditure is reduced in response to weight loss. So for every kilogram of weight that we lose, we need about 15 calories of resting energy expenditure less. So if we lose 10 kilograms in weight, we need about 150 calories less really to stand still, because our resting energy expenditure requirements have decreased. Okay, so what can we do to manage weight regain? Well, it's absolutely fundamental that it is managed in a multidisciplinary fashion because it is a complex problem. Obesity is a complex problem and weight regain is a complex problem. So of course we can look to do this in a sort of stepwise fashion. So with lifestyle first, pharmacotherapy, and then surgery. Now, before we talk about the individual interventions, I just wanted to remind you about the fact that lifestyle should sort of accompany all of the other interventions, of course. And combination therapies can yield an improved weight loss. So, for example, these are data from the liraglutide 3 mg scale maintenance study, where all patients were offered a lifestyle intervention, and only those that lost at least 5% were then randomized to other ongoing lifestyle or liraglutide 3 mg. So you can see that those that lost the 5% actually reached a 6% weight loss, and then they were randomized to lifestyle, where the weight was pretty much maintained, sort of up to 1 year following the initial randomization. But if they were randomized to the liraglutide 3 mg or Saxenda arm, they lost a further 6%. So lifestyle first, and then additional pharmacotherapy can be really quite powerful. And then, of course, if you stop the medication, if we stop prescribing, weight tends to go up because, of course, we are managing a chronic disease. If we take away those satiety signals, then weight tends to go back to the original set point. And again, this is also shown here. These are data from the sibutramine trials. Sibutramine, of course, is not available anymore because of increased cardiovascular risk. But the point here was that all patients were given sibutramine, and then sibutramine was stopped and weight went up. Whereas if you continue the medication, weight tends to be maintained. So when patients who are taking medication come and see us and they present with weight gain, of course, we've got to ensure that they are being compliant with the medication to exclude that as a possible cause of the weight gain. Now, moving on to bariatric surgery, and of course, bariatric surgery is probably the only intervention that's been proven to achieve weight maintenance in time. So these are data from the Swedish obesity study, the SOS study, where patients were followed up for over 20 years now. And you can see that those on a lifestyle intervention achieved a stable weight in time, whereas those with a band achieved about a 15% weight loss. And those with a gastric bypass achieved about a 25% weight loss. And what is it about bariatric surgery that allows us to maintain that weight loss in time? Well, certainly with the sleeve and the Roux-en-Y gastric bypass, we know that there is a favorable gut hormone profile with the ghrelin, the hunger hormone, actually decreasing and the satiety hormones increasing, which is the opposite of what we see after a lifestyle intervention. So this favorable gut hormone profile leads to reduced hunger and appetite, reduced preference for sweet and high fat, reduced reward value of food and correction of brain responses to food cues, also improved gut microbiome and restoration of insulin and leptin sensitivity. How do we define weight regain after bariatric surgery? It's defined as over 15% weight gain, so gain of initial weight loss post-bariatric surgery. And we see it in about a third of patients who undergo surgery about 2 to 5 years after the initial surgery. So, we do see it. It is reasonably common as well, again, because patients are still exposed to this obesogenic environment. So what are the predictors of weight regain after bariatric surgery? Well, if we look preoperatively, then those patients who are older, those with type 2 diabetes, and those patients with multiple psychiatric disorders, including personality disorders, tend to do worse and weight and regain weight. If we look at post-operative predictors, then nutritional non-compliance, hormonal or metabolic imbalances, physical inactivity, and psychiatric comorbidities tend to predict those who will regain weight. So how do we manage these patients? Well, it needs to be a multidisciplinary assessment. So first of all, we need to be supportive. Obesity is a chronic progressive disease, and the weight gain is not the patient's fault. So we mustn't stigmatize against patients. It's, of course, really important to assess their nutrition and diet, their eating behavior, the physical activity, sleep, and psychological status. Remember, all of those things that sort of push that set point upwards. And this is why it's really important to do this in a multidisciplinary fashion. If treated with pharmacotherapy, check compliance, as I mentioned earlier. Assess appetite, their hunger, their satiety, their cravings. This can also help to choose medication if you do have a choice of medication at hand, emotional eating, binge eating, because these psychological factors, if not corrected before the intervention, these factors are still going to be present after the intervention and need to be addressed. So, number one, we need to optimize their lifestyle again and go back to square one. And we need to get the dietitians, the psychologists, the exercise therapists involved. We need to check for recurrence or the new onset of obesity-related complications. Patients might have gone into remission of diabetes, for example, but now may have diabetes, which needs to be managed. Of course, we need to discontinue or change weight-gaining promoting medications. And there's so much that we can do as physicians to really help patients ensure that they are not on medications that are likely to make them gain weight, or at least try and switch them to more weight-friendly medications. If treated with pharmacotherapy, consider another treatment option if that particular medication is not working. What about the surgical patients who are regaining weight? Well, we may obviously discuss with the surgeons and think about imaging or endoscopy to check the integrity of the surgical procedure. So, for example, anybody with a gastric band, we tend to do a barium swallow to see what's, if there's any evidence of slippage for the band, for example. But yes, absolutely, investigations. Consider adjuvant anti-obesity therapy. So can we add medication post-surgery to help with the weight regain? And I think we probably all have access to liraglutide 3 milligrams, which we do use. And in the UK now, we also have semaglutide that has been approved, although not yet available
for those without diabetes, of course, at the 2.4 milligram dose. Naltrexone and bupropion is also licensed, and again, its use will depend to what the licensing is in your own part of the world. For those in the States, phentermine and topiramate, but of course, this is not licensed in Europe. But look at what's available locally in terms of medication, approved medication. So these are just data on the liraglutide 3 milligrams post-bariatric procedures. So this is a study by Wharton et al. Using liraglutide 3 milligrams for patients with weight regain after surgery, and for Roux-en-Y gastric bypass, patients with gastric banding, and also the gastric sleeve. And what you can see here that administering liraglutide 3 milligrams over a period of roughly 7 months actually led to a mean weight loss of about 5.5% weight loss. So, these agents can be used and they can help with weight regain. And certainly we are using them more and more post-surgery to do exactly this. What about revisional conversion? Absolutely, some patients will be considered for revisional surgery, and this is a discussion, of course, with the surgeon. So sometimes they might lengthen the limb, they might decrease the pouch size, although there's little supported data for this. Some controversy about whether decreasing the GJ anastomotic diameter is helpful or not, but sometimes we go from a sleeve converter sleeve to a Roux-en-Y gastric bypass. But these conversations need to be had with the surgeons. And again, change therapy conversion, whether conversion to a different procedure is a reasonable option. Whatever we decide to do needs to be a polymodal approach. We need to sort of start with lifestyle first, and then lifestyle plus pharmacotherapy, lifestyle plus bariatric surgery, or the combination of all three. And of course, it's about giving the right treatment for the right patient at the right time. So I think in summary, obesity is a chronic and multifactorial disease. And of course, the regulation of body weight is complex with a strong genetic predisposition. But there are clear physiological changes that drive weight regain after weight loss. And I've talked to you about some of the predictors that can help us to identify those most at risk of weight regain, both with lifestyle interventions, but also after surgery. It's really important to have a multidisciplinary approach for the management of patients, and a stepped polymodal approach should always be adopted when managing obesity and weight regain. And with that, I'd like to stop and thank you. I'm very happy to take any questions. Thank you.
Thank you, Professor Barbara, for your interesting lecture. If you are happy to keep the questions at the end, and we can proceed with the Dr. Naji lecture. Is it okay for you?
Absolutely.
Yes.
Absolutely.
Dr. Iman, in between, if there is any urgent question. Here, Dr. Naji, if you can introduce him.
Lovely. Warm welcome to Dr. Naji Alamuddin, who is a consultant endocrinologist at the King Hamad University Hospital. He's also senior lecturer at the Royal College of Surgeons in MUB. And he has a research interest which focuses on the treatment of obesity, involving behavioral, pharmacological, and surgical approaches. And he was awarded an NIH K-12 Mentored Clinical Scientist Development Program Award. And today he's going to talk to us about updates on lipid management. Professor Naji, very warm welcome.
Good afternoon. The title of my Good afternoon, everyone. I'm honored to be presenting to you today. Thank you for the organizing committee for inviting me. The title of my talk is Guidelines for Lipid Management. Here are my disclosures. The objectives of today's talk are to review the 2018 American College of Cardiology and American Heart Association guidelines on the management of blood cholesterol. I'd like to explain the role of role enhancers in determining risk stratification and treatment decisions. I will then move to discuss the clinical recommendations for the use of coronary calcium scoring, and I'll end by discussing the evidence base for the use of non-statins, specifically ezetimibe and PCSK9 inhibitors in the primary and secondary prevention of atherosclerotic cardiovascular disease, which I will refer to as ASCVD moving forward. The guidelines, as I mentioned, were published around 4 years ago. They are written in an easy way to review. They've emphasized 10 take-home messages. So the 2018 guidelines, like all guidelines, emphasize lifestyle over the lifespan. They encourage the use of motivational interviewing techniques, and they emphasize the use of maximally tolerated statin therapy, and that the lower the LDL, the greater the risk reduction. Now the question is, where does this recommendation come from? This is data from a meta-analysis of statin trials. As you can see, the on-treatment LDL is on the left, is a very strong predictor of risk. So lower is better if you're using statin. Now, there's no a particular lower threshold that we can tell. We have some semi-arbitrary goals that give us a sense of how low we want to go, but there's nothing magical when you achieve these goals. The guidelines address the use of non-statin medications in addition for patients who are at very high risk for ASCVD. So this is a way of further risk stratifying patients with known ASCVD into very high risk or not. Very high risk is defined as patients with a history of multiple major ASCVD events or one major ASCVD event and multiple high-risk conditions. Now, look at this list and think back about patients you see in clinic and how many of them meet this criteria for very high risk. So if they are very high risk and their LDL is greater than 70, then the recommendation is to add a second agent. We use ezetimibe as a first line and PCSK9 inhibitors if needed. The guidelines also emphasize the treatment of those individuals who have severe hyperlipidemia at any age, and that is defined as an LDL of greater than 190 milligrams per deciliter. So even if you have a 15-year-old patient with an LDL of more than 190 on multiple occasions, the recommendations are that you should treat them with a statin and to consider adding PCSK9 inhibitors if the target is not reached. In terms of lipid measurement, the guidelines recommend that lipid measurement should be performed above age 40. What's changed is that they recommend that it doesn't matter if it's a fasting or non-fasting lipid profile. Both are effective. Now, this makes it much more practical for patients, and you're much more likely to get lab results. So if a patient comes to see you in the afternoon, they leave the clinic, they get their labs immediately. They don't have to plan their day according to if they're fasting or not. The only time you need a fasting lipid profile is if the non-fasting triglycerides are more than 400 milligrams per deciliter. Then the recommendations are to repeat them under fasting conditions. Now, some of the changes compared to the 2013 guidelines is that adults age 40 to 75 who have diabetes and an LDL of more than 70 should just start a statin. The 2013 guidelines had you calculate the risk. The 2018 guidelines say just give them a moderate intensity statin, and we use a high intensity statin if there are high risk features. So speaking of statin intensity, this is just to review the different intensities. You have low intensity, moderate intensity, and high intensity. And this is defined by the degree of LDL lowering, with high intensity statins lowering the LDL by more than 50%. You have two high intensity statins, specifically atorvastatin 40 to 80 milligrams and rosuvastatin 20 to 40 milligrams. You have many more moderate options for moderate intensity statins, which brings the LDL down from 30 to 40, down to 30 to 49%. Low intensity statins lower LDL by less than 30%. So how about those adults aged 40 to 75 without diabetes and an LDL of greater than 70? What do we do? For these, we need to calculate their atherosclerotic cardiovascular disease risk and have a discussion with the patient about the treatment if the risk is more than 7.5%. The guidelines really stratify patients for primary prevention into 4 levels of risk, risk categories, which I will go to into more detail later on. So the guidelines recommend the use of this risk calculator. The risk calculator uses the traditional risk factors for vascular disease, including sex, age, race, total cholesterol, HDL, current systolic blood pressure, and if they're treated for hypertension or diabetes, and if they smoke. So we plug these in and we get an answer. So what's really expanded in the new guidelines are risk-enhancing factors. The emphasis is not to neglect other risk factors. These are risk factors that are not in the risk calculators and should be used in addition to the score given by the risk calculator. So this applies more specifically for patients who are adults without diabetes and have a risk of 7.5 to around 19.9. That's why they're considered intermediate risks, and that's why we should look at risk-enhancing factors. So the risk-enhancing factors that are not included in the risk calculators are the family history, meaning first-degree family relatives, and that the age that they had the event. For males, it's less than 55. For females, it's less than 65. Other risk-enhancing factors are the presence of metabolic syndrome, CKD. For women, we know that a history of preeclampsia or premature menopause, defined as less than 40, these patients have a higher risk of CVD. We know that many chronic inflammatory disorders, such as rheumatoid arthritis and psoriasis, increase the risk of CVD. We are asked to consider ethnicity. Elevated triglycerides, defined as a fasting of more than 175, confers increased risk. Now, if you measure a high sensitivity CRP and it's over 2, then that should be considered. The guidelines are not telling you to measure it, but if you do, you know what cutoff to use. Other risk-enhancing factors are lipoprotein(a), ApoB, and a reduced ankle brachial index of less than 0.9. A big change in these guidelines is the emphasis on coronary artery calcium scoring. So these guidelines recommend doing CAC in certain patients, especially if the patient and the provider are on the fence for therapy. The CAC can help in decision-making, and it's categorized into 3 scores. CAC of 0, statins are not needed. A CAC score of 1 to 99 favors statin use. A CAC of more than 100 or greater than the 75th percentile indicates statin use. So here is some categorization. You can all see that once you start getting above 0 in terms of a CAC score, then the risk starts to go up. So the decision has to be made on where you're going to make the cutoff to define who's at risk and who's not. So now we move on to what is the significance of a CAC score of greater than 100. So this is from a study called the multi-ethnic study of atherosclerosis, also known as the MESA study. They specifically addressed this question. In this study, they took more than 5,500 multi-ethnic participants who were on no lipid-lowering drugs, and they were classified based on their CAC score and their baseline lipids. And they followed these patients for more than 7.5 years. So what they were examining was the interplay between CAC and lipids. So just to go over this, the red line is a CAC of more than 100, green is a CAC between 1 to 99, and yellow is a CAC of 0. Here, they've categorized it based on the level of lipid abnormalities. So these are patients without lipid abnormalities. This is with 1 lipid abnormalities, 2 and 3 lipid abnormalities. And what they were, so what they showed in that study was that many individuals with dyslipidemia have no CAC. So these are patients with 3 lipid abnormalities, and take this group, they have no CAC abnormalities. And now compare that to the left. There are many individuals without dyslipidemia who have a high coronary artery score. So this is why this is the importance of this. So let's say you get a lipid profile on a patient. That by itself is not enough to risk stratify patients for you, because you can have patients with no lipid abnormalities who have a high CAC score and are at high risk of developing atherosclerotic cardiovascular disease. So in this study, what we see here is that the CAC score really stratifies cardiovascular disease regardless of lipid status. And in the study, those with any coronary calcium accounted for 79% of the events. 50% of the events occurred in the 21% of subjects with a CAC score of more than 100. Now, when the CAC is 0, absolute events range were very low, even regardless of what the lipid abnormalities were. So let's summarize this. The advantages of the CAC scoring. It helps diagnose atherosclerosis. The score is proportional to risk. And most importantly, a CAC score of 0 is the strongest negative risk factor for the development of ASCVD. Radiation exposure is very low. It's similar to a mammogram, especially when used with shielding and appropriate techniques. And it helps identify unusually high risk and unexpectedly low risk patients, like the patient I was talking about earlier, a younger patient, for example, with no lipid abnormalities who has very high CAC score. Now, and it also permits treatment based upon more accurate assessment of risk. What are some barriers to the use of CAC scoring? It's unfortunately not widely available as a point of care. It is becoming more available, but still not everywhere. I said it's low radiation exposure, but nevertheless, it is still radiation exposure. The cost is, it's typically not reimbursed by insurance. The cost of these have come down. It's somewhere between $75 to $125 to do this test out of pocket in the United States. And the other thing is that results are not integrated with treatment. In other words, once you get a positive calcium score, it's not going to get better. Also, there's no data saying that if you treat a person with a high CAC, that it's going to afford you benefit. There are no randomized control trials demonstrating the clinical benefit of this assessment. Now, I had mentioned some points about primary prevention earlier. So here are the recommendations for the primary prevention. Any age individual who has a familial hypercholesterolemia or persistent severe hypercholesterolemia defined as an LDL more than 190, they should start statin. For young adults, age 20 to 39, with a family history and an LDL of greater than 160, you should consider start statin. Now, once they hit 40, statin is indicated. As I mentioned earlier, age 40 to 75, with diabetes, we start statin. Age 40 to 75, without diabetes, we calculate the 10-year ASCVD risk using the risk calculator, and depending on the score, we decide what to do. More than 20%, we start statin. 7.5 to 20%, we assess risk enhancers, and we consider statin. 5 to 7.5 is a borderline risk. If there are risk enhancers, we discuss statins again. And if it's less than 5%, lifestyle changes are indicated. Let's move on to secondary prevention. So for secondary prevention, for individuals aged less than 75 with clinical ASCVD, a high-intensity statin is indicated. So a patient who had an MI, they should be on a high-intensity statin. Now, if they have known ASCVD and the LDL is more than 70, despite maximally tolerated statin, the recommendation is to add ezetimibe as first line, and we consider adding PCSK9 inhibitors if the LDL remains elevated, or for those who remain at very high risk. Now, the hesitation for the recommendation for PCSK9 inhibitors is due to cost-benefit analysis and also waiting on long-term safety outcomes. Now, things have changed since the publication of this in 2018, and the cost of these drugs has come down, as I'll show later. Now, for those who are older than 75 with ASCVD, we consider initiating or continuing moderate or high-intensity statins. Now, I'd like to take a bit of time to talk specifically about these, about other drugs, the non-statins, ezetimibe and PCSK9 inhibitors. So let's start with ezetimibe. IMPROVE-IT was a large long-term trial that looked at ezetimibe added to statin. Specifically, it was a study of patients post-ACS of statin versus statin and ezetimibe. Patients were followed for at least for several years, and at least 2.5 years. The primary endpoint, as you can see here, is cardiovascular death, MI, hospital admission after unstable angina, coronary revascularization greater than 30 days after randomization, or stroke. And the results were positive. The addition of ezetimibe to statin added benefit. Now, it wasn't super exciting. We only saw 6 to 7% benefit. But again, those high-risk individuals got greater benefit in adding ezetimibe as compared to placebo. Now, one very interesting thing in the IMPROVE-IT trial was that there appeared to be greater benefit between those with and without diabetes. Quite a striking difference, which was statistically significant. In fact, this applied to all risk factors. So if you look here at risk factors, the more the risk factors you have, the greater the risk reduction with ezetimibe. So in the very patients that you are going to consider for PCSK9 inhibitors, in fact, ezetimibe is a very good drug. It's also not very expensive, and insurance will often require you to use ezetimibe prior to starting PCSK9 inhibitors. Let's move on to talk about PCSK9 inhibitors and how they work. So the monoclonal antibody is targeting this molecule PCSK9, which is important in the degradation of the LDL receptor. The PCSK9 is a product of the liver. It attaches to the LDL receptor when it accepts an LDL particle. Then there's endocytosis. These molecules are taken in the liver, and then the PCSK9 triggers the destruction of the LDL receptor as well as the LDL cholesterol. So there's no recirculation of the LDL receptor. Now let's see how the drug itself works. So if you target a monoclonal antibody or you interfere with the production of this PCSK9, then the LDL receptor and the LDL cholesterol are reabsorbed, as you can see here. And the LDL receptor is not destroyed. So recycle and increase the LDL receptor on the liver, and that's why we have a greater reduction in the LDL. Now, how effective are these drugs in lowering LDL? When you look at long-term trials with alirocumab, which was one of the approved PCSK9 inhibitors, as you can see here, there's massive reductions in LDL in patients who are also on high doses of statins. And you see similar effects with evolocumab, which is the other PCSK9 inhibitor. Now here, look at dramatic reduction in LDL. I have patients with LDLs of 15, 20 on PCSK9 inhibitors. Initially, that was worrisome. I got scared how low it is. But the data is reassuring, and the data shows that, as I had mentioned in the beginning, that the lower the LDL, the greater the benefit. Now let's look specifically at the more important aspect, the cardiovascular outcomes. So there have been several studies that have looked at cardiovascular outcomes of PCSK9 inhibitors. There's been the Fourier study, Odyssey Outcomes, SPIRE-1, SPIRE-2. The first cardiovascular outcome trial is called the Fourier study, which is illustrated here. In this study, they took 27,000 patients, so a large sample size. And these patients were very high risk with established cardiovascular disease defined as a prior MI, prior stroke, or symptomatic peripheral arterial disease. Almost 70% of these high-risk patients were on high-intensity statins, as they should. 30% were on moderate intensity statin, and only 0.2% were on no statin. What this means is that they were treated medically very well. The inclusion criteria was an LDL of more than 70, and they were randomized to either evolocumab or placebo, and they were followed for several years. And what you could see here is that evolocumab was quite efficacious. The average LDL was 92 when they started. At the end of the study, it was around 130. It was around 30, excuse me. But look at here in terms of the hazard ratio. There was around a 15% reduction in events in patients who were on evolocumab compared to placebo. And when we look at alirocumab, which is the other PCSK9 inhibitor, it's almost identical to the evolocumab. There's a 15% relative risk reduction in patients who were on this PCSK9 inhibitor compared to placebo. So to summarize, this cardiovascular outcome trials of PCSK9 inhibitors, you have persistent LDL lowering, you have a relative risk reduction of cardiovascular events of around 15%. There is a limb-sparing effect in peripheral arterial disease, specifically with evolocumab, and we have greater benefits in patients with diabetes, similar to what we saw with ezetimibe. So where do these drugs fit in? Patients with familial hypercholesterolemia will often need these drugs because their LDLs aren't that goal. Homozygous FH is extremely rare, around 1 to 4 per million, so we don't need to worry about that as much. Now, other very high-risk patients are those with previous ASCVD who still have an LDL of greater than 70 on maximally tolerated statins. That's the #1 use by a long shot. And then finally, you have statin intolerant patients. These are patients who can't tolerate the drugs, but they need LDL lowering. So what insurance companies will often do in these patients is they will ask you to try different statins, and that often works. Sometimes I try alternative statins for this, but very often these patients will need PCSK9 inhibitors because they just don't tolerate the statins. Now, what about dosing and the pricing, the practicality of using these drugs? So there are 2 available drugs, alirocumab, also known as Praluent, and evolocumab, also known as Repatha. So they are given subcutaneously every 2 weeks or every 4 weeks. And the price is very expensive, but the prices have come down. So they started around $1,100 in the US per month. They're now at around $450. So in the US, the price of PCSK9 inhibitors is similar to GLP-1 agonists at this stage. In terms of safety, they are extremely safe drugs. So there are no specific serious clinical or lab adverse events have emerged. The subcutaneous injections are well tolerated. They are similar. The pens are similar to GLP-1 agonists or to insulins. You can have a bit of an injection site reactions, such as a rash or pain, which is mild and typically resolves. An upper respiratory tract infection and nasopharyngitis are the most common side effects. Mild GI side effects are seen. And what's important is that there's no evidence that there's an increased risk in developing diabetes or any neurocognitive effects. So in summary, statins are first-line therapy. Use of an ASCVD risk calculator is useful to help guide decision-making. Use risk-enhancing factors to further stratify risk. And what I really encourage you to use is the coronary artery calcium scoring. It offers objective risk stratification with a gradient risk based on the burden of CAC, 0, 0 to 100, and greater than 100. And that the addition of ezetimibe is recommended in certain high-risk groups. And finally, the addition of PCSK9 inhibitors is recommended in extremely high-risk groups due to the cost-benefit concerns. Thank you, and I'm happy to take any questions.
Thank you,
Doctor.
Professor Naji. Thank you, Professor Barbara, for your interesting lectures. Now, questions are open for both speakers, Professor Barbara and Professor Naji. Maybe there is questions over here for Professor Naji. Which cases should we advise getting CAC score and is better than TMT?
So that's a very, very good question. So I typically do, if there's someone who is at intermediate risk and I am concerned that they might have subclinical ASCVD, then I typically screen with coronary artery calcium. It's an easy test to do. You don't need to send them to a cardiologist to do this test, and it's not too expensive. Regarding the comparison between two stress tests, I don't know of any studies specifically, but I know there's controversy about using stress tests in screening asymptomatic individuals. There's concern about the predictive value of exercise ECG testing. So my recommendation is to start with a coronary artery calcium score, a CT, and take it from there.
The second question: why all diabetics be on statin? And what role of aspirin in diabetes and primary prevention?
Another excellent question. So the value of putting patients with type 2 diabetes, age 40 and above, on statins is because they're at very, very high risk of developing cardiovascular disease. So, and we know from the trials regarding the benefit of putting these statins on, and that comes as a follow-up to the question on aspirin. So in the past, we used to use aspirin very regularly on these patients, but with the availability of drugs like statin, where we see such improvement, and also with newer drugs like GLP-1 agonists, SGLT2 inhibitors, then you have to weigh the risks and benefits with aspirin. So aspirin is obviously, it puts you at higher risk of bleeding. So from a population perspective, we cannot recommend every patient with diabetes to be on aspirin. It is a risk-benefit discussion to have with a patient. Patients who are very high risk, they should be considered. But just to say, is patients who have atherosclerotic cardiovascular disease definitely need aspirin. So it's secondary prevention perspective.
Thank you very much. I have a question for Professor Barbara. For patients referred for a physician from surgeon, as we discussed yesterday with Dr. Ali Hamadani, he said they come to step 4 and they refer back to place. It is really very good idea to refer to missing points. But what happened, I receive a lot of cases here from Bahrain, asking to lose 10 to 15 kilograms before surgery. And it is really a good beginning to negotiate with the patients of other choices than surgery. So what you suggest, and to which level of BMI you can give this chance for giving them whether diet control and medications rather than surgery?
Thanks, Dr. Assad. I think, well, I think for all BMIs, we still have to, like I said, we always have to ensure that the lifestyle intervention has been addressed, because even if they get referred for bariatric surgery, you know, their results, the outcomes are going to be that much better if lifestyle has been addressed. I mean, pharmacotherapy, you know, if lifestyle fail, then pharmacotherapy should be the next step. And you know, the majority of pharmacotherapy is licensed for a BMI of 30 or BMI of 27 plus complications. Now, of course, if you have patients with significant complications with BMIs over 35, you know, technically you could think about bariatric surgery already at that stage, but some patients don't want bariatric surgery. And like I said, now we do have really effective medications for weight loss and medication that can achieve, you know, 15, even 20% of weight loss. So we are approaching levels that we see with bariatric surgery. So to some extent, we need to individualize therapy. We have to assess the complications and assess patient's choice and take all of those factors into account. But I think certainly within the NHS, medication will only really be available for BMIs over 35 plus complications anyway. So that's a sort of target group that we'll be looking to use pharmacotherapy for. And on the whole, bariatric surgery will be sort of BMI over 40, although of course, you know, they're still eligible for bariatric surgery, BMIs of 35 plus one complication.
Let me look for the questions until we have more questions. I have another question for the patient who go for interventional treatment of obesity. Is there any difference if they did a medical fitness like regime? So if you have patient do an exercise 30 minutes or 1 hour before involvement in any program, whether using a medication or diet control or even the surgery, is there any study you are aware that this can make a difference?
So I mentioned some of the national registry data, some American data, which shows that actually those that keep weight off after a lifestyle intervention are those that tend to do regular physical activity. You know, we talked about 60 minutes a day. So there is some evidence to suggest that weight maintenance is better. But actually, when it comes to, and with all the pharmacotherapy trials, most patients were advised to do 150 minutes of physical activity. So that wasn't controlled for in the, you know, in those particular trials. But I'm not aware of any evidence, say, for bariatric surgery, for example, that where physical activity beforehand makes a difference. On the whole, though, as part of just general weight maintenance, you know, I think physical activity is important, and it is that those patients who do less physical activity tend to regain weight, whatever the intervention on the whole.
Let me see for the box. Any other question over here from the faculty? Any question? By this, I think we have to finish with this session and looking forward for the remaining sessions. Thank you, Professor Barbara and Professor Naji, for your interaction, and
Thank
Professor
you.
Maher as well for his interesting lecture.
Thank you.
Thank you for
Thank you.
So there will be a break for 15 minutes. Good afternoon, ladies and gentlemen. Next session will start soon. And this will be chaired by Dr. Richard Quinton and Dr. Rawan Saab. So let me introduce the chairman of the next session, Dr. Rawan Saab, Assistant Professor of Endocrinology, University of Balmain, affiliated with the Mount Lebanon Hospital, University Medical Center, Specialist Diploma from Sorbonne, University Campus, Père Curie, Paris, authored numerous papers and medical works, as well as contributed in international conferences in the field. Holds a degree in therapeutic education of patients management of obesity in both clinical and surgical contexts, and is actively involved in several national and international scientific societies. And Professor Richard is the consultant and senior lecturer in endocrinology, Royal Victoria Infirmary, University of Newcastle, regional specialty advisor for UK Northern Deanery, awarded the Ralph Nobel Prize from University of Cambridge for his MD thesis on gonadotrophic hypogonadism, which remains his principal area of research interest. Floors for you. I think the
Dr. Asad, the presentation is for Dr. Rabab.
Dr. Rabab, yes, but
she's there. If you can also introduce her, please.
I will introduce Dr. Rabab, our colleagues. Dr. Rabab, welcome on board. She's assistant professor, head of Quality Assurance and Accreditation Committee, College of Health Sciences and Sports, University of Bahrain, PhD in Molecular Medicine, Arabian Gulf University. She will give a lecture about the lecture name?
Alteration of amino acid profile in diabetes.
Yes, alteration of amino acid. It is a part of her thesis in the master, and again, multiple research. Please, Dr. Rabab, floors for
Thank you. Thank you, Dr. Asad. Thank you for the introduction. I'll just share the screen. Okay. I need to minimize this. Yes. Okay. Good afternoon, everyone. Thank you, Dr. Asad, for the introduction. My presentation will be about the alteration of amino acid pool in type 2 diabetes. This was part of my PhD study at Arabian Gulf University. This research was published in June 2020 in Trends and Research. Talking about diabetes, we have to talk about the normal glucose homeostasis, where glucose level should be controlled by the insulin and should be taken into cells by different processes that activated by insulin secretion. Any disturbances in glucose metabolism, this will lead to type 2 diabetes, which is a metabolic disorder characterized by complex disturbances in glucose and lipid metabolism as well. And this will result from a combination of resistance in the insulin action and also the inadequate insulin secretion responses. With the technology advances in science for metabolic profiling, circulating amino acid have been suggested to be used or to serve as a novel biomarker for predicting the risk of diabetes. As we know, insulin resistance is contributed to diabetes, and there are several environmental genetic factors that are contributed to insulin resistance. It can be ethnicity, obesity, family history, defects on both receptor and post-receptor levels. Talking about the prevalence of diabetes, I'm sure that all of you are aware of this. According to International Diabetes Federation, global prevalence in 2021 was 10.5 as an expected to increase in 2045 to 12.2. And also the MENA region prevalence was 16.2 into 2021, expected to increase to 19.3 in 2045. This figure shows us the number of people with diabetes in adults by age group, and the one in the columns is related to the age group in 2021, and the black line shows the prevalence of diabetes, estimated prevalence in 2045. And as we can see that as the age group increases, the prevalence of diabetes also increases, and also by different years or increasing the years. Looking at the MENA region, the prevalence of the diabetes by age and sex, again, is the same, similar to global. And we can see that looking at the sex, differences between men and women, we can see that the woman at certain age group, let us say from 35 to 70 years, the prevalence of diabetes is slightly more in women than in men. GCC countries are countries with highest prevalence of diabetes in the MENA region, at least, and Bahrain is no exception. This number was reported from 2017. The prevalence of diabetes in Bahrain is about 25%. So type 2 diabetes is considered to be a monogenic and polygenic, has both monogenic and polygenic etiologies, and this polygenic nature of the disease will prompt or will help in studying using omics methods to assess the protein and the amino acid changes in type 2 diabetes. So using the proteomics and amino acid analysis profiling techniques will help in identifying biomarkers that will lead to a better diagnosis and more effective treatment of type 2 diabetes, and also it can help us to understand the pathophysiological process of the disease. Amino acid profiling has been used extensively as a biomarker in a number of diseases, including diabetes, and there are a number of researches, as you can see over here, that are referenced, shows the amino acid biomarkers in type 2 diabetes. And we can see that some researchers shows or reported that elevation of branched-chain amino acid and aromatic amino acid levels were associated with diabetes. Other researchers or other studies showed that elevation of branched-chain amino acids alone was associated with diabetes. And other studies shows the decrease of branched-chain. So sometimes increase and sometimes decrease, and depends, I think, in different ethnicity, shows different association with diabetes. And also elevation of phenylalanine and the decreased level of glycine showed to be associated with diabetes in some researchers. So the study objectives, because we know that the amino acid offer novel biomarkers to predict risk of type 2 diabetes, and which will help in disease management and also facilitate earlier treatment. So we wanted to explore the amino acid pool in type 2 diabetes using HPLC for better understanding of the metabolic changes. And also we wanted to use those generated data from this research in order to relate it to diabetes metabolism. Our study samples were patients with type 2 diabetes and diagnosed according to the WHO criteria. The patients were recruited from health centers and Salmania Medical Complex. The healthy controls were recruited by advertisement, and all the participants, they signed the consent form. The inclusion criteria was diabetes, Bahrainis, male or female. Exclusion was non-Bahraini and patients with chronic diseases. And this study was approved by the Ethical Committee in Arabian Gulf University and the Research Committee at Salmania Medical Complex. The number of these samples used in the amino acid analysis was 35 between males and females, 35 diabetic and 35 non-diabetic subjects. We have collected fasting blood samples from the study subjects, and we use a serum for the lipid analysis, and the plasma used for fasting blood glucose analysis, and also the aliquot was stored at -80 degrees for amino acid analysis. And all the biochemical variables were measured using automated biochemical analyzers in Salmania Medical Complex. The amino acid analysis was done at Al Jawhara Center. We have used reverse phase high performance liquid chromatography. And this is the system, how it works. We have used plasma for the amino acid analysis by reverse Phair's HPLC, and the HPLC is working by fluorescence detection. And we have used the method, or we have followed the method that's published in 1994, but we have done a slightly modification in the method where we changed the mobile phase to sodium hydrogen diphosphate instead of the potassium, and the analysis time was increased from 17 to 35, and the excitation, because we are using fluorescence, so we need excitation and emission wavelengths to be adjusted. There have been changed from the excitation was changed from 230 to 330, and the emission from 389 to 450 nanometer. We have used 13 amino acids in this study, or were tested in this study, and we have prepared, of course, working standard solutions, 7 concentrations, and also we had an internal standard, which was in Nervaline, and we have prepared 3 concentration of the Nervaline in order to compare it with the amino acid concentration, which we'll have later after the HPLC analysis. And these are the amino acids which were tested in this study. This graph or this table shows the gradient condition. We have 8 steps in the HPLC, and the time, as we said, it was 35 minutes. The flow was the same, consistent in all the steps, but what was changed is the mobile phase A and the mobile phase, the percentages between the two, between the steps. This is very simple representation of the HPLC method, how it was done. We have taken the plasma and we deproteinized the plasma with aceto-neutral because we needed to make sure that no protein is existing in that plasma. And then it was vortex centrifuged, and then the supernatant was derivatized using the UPA. The purpose for the derivation, because we are using fluorescent, so we need to change the chemical component of the molecule and make it fluorophore so it can be detected by fluorescence. And then the sample was injected triplicate into the HPLC system, and the result was the HPLC chromatogram, as we can see over here. This is just one of the chromatogram shows for tyrosine, where we, any amino acid, it was done for the 13 amino acid. It is example of one only. The amino acid standard solution for the tyrosine was spiked with the internal standard, derivatized and analyzed by the HPLC. This was done in order to find the retention time, where we can find, or when the amino acid that we are testing can be shown in the chromatogram, and compared to the internal standard, which is the Nervaline. The method was validated by the original author, but we have done limited validation to make sure that the method performance, is to ensure about the method's performance and applicability. The validation parameters was done for the evaluation was done for linearity, precision, accuracy, specificity, limit of detection, and limit of quantification. After we got the chromatogram, of course, we have calculated the amino acid concentration using this equation, and it was reported as mean and plus and minus standard deviation. The equation concentration, amino acid concentration equation consists of the concentration of the internal standard, the area, the average peak area of the amino acid, and then the response factor, which is the measure of the relative mass spectral response of the analyte compared to the internal standard, which is the RF, and finally the average peak area of the internal standard. We substituted in this formula, and we got the concentration in mean and standard deviation. This figure shows the typical HPLC chromatogram. The first one, the A, is this pooled standard amino acid, all the amino acid standard that we have used in our study, 50 micromolar. And B and C, B is for the non-diabetic subject, and C is for the diabetic. And we can see now here the difference between the diabetic and the non-diabetic chromatogram on the HPLC or the amino acid analysis. We can see differences in the chromatogram or the peak that's shown for each amino acid. The characteristics of the study subjects, gender and age and glucose and lipid profile were tested, shown in this table. We can see that there are differences, or the p-value is significant in most of them. And some of them we use the t-test, where we have linear data, where for the nonlinear data we use the Mann-Whitney. The response factor and the correlation coefficient and the retention time of the 15 amino acid and the internal standard are listed in this table. The results, what we have seen after running all these samples and all the 13 amino acid, we find that out of the 13, only 5 amino acid showed that there is showed association with type 2 diabetes, or they were significantly lower in type 2 diabetes. As we can see, those are highlighted: the glycine, the glutamine, the aspartic acid, tyrosine, and phenylalanine. So these were some of the phenylalanine is an aromatic amino acid and it's essential amino acid, where the others, the glycine, the glutamine, aspartic, and tyrosine are non-essential. Tyrosine is as an aromatic amino acid as well. But according to the literature, what they said that the branch chain amino acid were correlated with type 2 diabetes, or it was found in type 2 diabetes elevated or decreased. We didn't find this relation, as the valine, isoleucine, and lysine, the one in green, doesn't show any differences between the type 1 and diabetic and non-diabetic subjects. We have done the correlation of the fasting plasma level of all the amino acid, tested amino acid, or the five which was found in our study, with the glycemic and lipid profile. And we found only that the tyrosine was correlated with the HbA1c and the triglyceride. And the other one was the glutamine, also was correlated with the same parameters, which is the HbA1c and the triglyceride. But the other 3 amino acids, they didn't show any correlation with the fasting plasma glucose or the lipid profile, glycemic profile or the lipid profile. The correlation of the fasting plasma level of the amino acids with each other in type 2 diabetes and non-diabetic subjects also was done. We have found no correlation between the phenylalanine and the glycemic profile and the lipid profile. Also, the only correlation we found was the glutamine, the last one, has positive correlation with the glycemic profile, but not with the lipid profile. And then when comparing it with amino acid in non-diabetic and diabetic, we found that phenylalanine was positively correlated with some of the amino acid in non-diabetic, but in the diabetic one, it was only negatively correlated with the glutamine. And for the glycine, we can see that the negative correlation was with a few amino acids, thymine, alanine, valine, and lysine, negatively correlated with non-diabetic, but only the valine was negatively correlated with the diabetic subjects, with amino acid in diabetic subjects. Glutamine also had some few negative correlation with amino acids in non-diabetic, and with the lysine for the diabetic one. So here we can say that the phenylalanine showed in other studies to be elevated in metabolic syndrome and type 2 diabetes, and positively correlated with the plasma glucose. In this study, the level of the phenylalanine was more than 10 times lower in type 2 diabetes. And this difference, we could explain that by ethnic differences, since no studies were done in Arab population, or maybe because of the selection of the criteria of type 2 diabetes, as we have used studied amino acid profile in established cases of type 2 diabetes, not pre-diabetic subjects, and there may be an influence for the drug treatment on the amino acid analysis or profile. Tyrosine is another aromatic amino acid that shows that it's decreased in type 2 diabetes, and in this study, and I know that phenylalanine is a precursor of tyrosine. Tyrosine among the amino acid found to be a predictor for type 2 diabetes in other studies. So low level of phenylalanine tyrosine could be due to decreased de novo synthesis of tyrosine because of low level of phenylalanine, as we can see in this figure, or because of the overproduction or conversion of tyrosine derivatives, DUPA and thyroxine and etc. But however, the tyrosine derivatives might be low because the level of tyrosine is low, which we found in our study. So low level of tyrosine could explain the thyroid and autonomic disorders in type 2 diabetes. For the other amino acid, we find decreased level of glycine in type 2 diabetes was in line with previous studies. And we know that glycine is a part of a glutathione molecule, which is involved in detoxification reaction. Glutamine levels was decreased in type 2 diabetes in this study. In other study, it shows that it was raised in type 2 diabetes and insulin resistance in some studies and decreased in others. And glutamine plays a major role in amino acid metabolism and urea synthesis. Aspartic acid levels were decreased in type 2 diabetes in this study, and high level of aspartic acid were found in children with diabetic ketoacidosis, but low level were found and was associated with breast cancer. So the type 2 diabetes subjects had significantly low level of 5 out of 13 amino acids compared to non-diabetic. And the deficiency of those 5 amino acids can be explained as in part by increased gluconeogenesis in type 2 diabetes. And the decreased level of glycine in type 2 diabetes is in line with the previous study. Level of glutamine in type 2 diabetes were discordant, where it was raised in type 2 diabetes, while in other studies it found to be decreased, as in this study. The aspartic acid profile was the least to be reported in association with type 2 diabetes in the literature among the 5 selected amino acids. So in this study, we expected to find branched-chain amino acids, which is valine, lysine, and isoleucine, to be different in type 2 diabetes, but it was comparable between type 2 diabetes and non-diabetic subjects. But in other studies, it was found that to be either increase or decrease in type 2 diabetes. Increased amino acid, aromatic amino acid, shown to be associated with type 2 diabetes in previous study. In this study, both of them, they were decreased. Level of amino acids, essential amino acids, were associated to be with that type 2 diabetes in previous study. In this study, 4 out of the 5 amino acids were associated with type 2 diabetes were non-essential amino acids. And certainly because this may be because of genetic, food types, habits, or exercise might be reflected in amino acid profile. None of the 5 amino acids were correlated with lipid profile. Only glutamine and tyrosine were positively correlated with glycemic profile. The gender and the age as a covariate were not correlated with any test parameters. So in conclusion, we can say that the analysis of metabolites, particularly amino acid analysis in body fluids, has been a crucial part of the diagnosis, prognosis, and assessment of therapeutic intervention in clinical applications. Insulin resistance may account for or mediate the association between amino acid and type 2 diabetes, and that is amino acid increase or decrease the risk of diabetes through its effect on insulin resistance. Overall, amino acids may be used as novel useful biomarker in the identification of people at risk of type 2 diabetes, and it can be a potential target for eliminating the previously unknown pathways in type 2 diabetes pathophysiology. And the findings presented in this study suggest that dysregulated amino acid in type 2 diabetes should be explored more as therapeutic targets or corrected through supplementation to improve type 2 diabetes management and prevent future complications. And thank you for listening.
Thank you, Dr. Rabab, Professor Rabab, for your nice presentation. I invite Dr. Richard and Dr. Rawan to join this session.
That was a very nice talk. Some good science there. Thank you very much. We enjoyed that.
Thank you.
So, if there is any question over here?
Moment, Dr. Assad.
Yes.
No questions at the moment.
No questions. Okay, we can leave the questions till the end of the session. So the next will be, Dr. Richard. He will present now the
Okay.
Just 1 minute, sorry. Yes. So here we have the Society for Endocrinology guidance on the management of male hypogonadism. It will be presented by Dr. Richard. It will be it's our pleasure to introduce Dr. Richard. He's the consultant and senior lecturer on endocrinology, Royal Victoria Infirmary, University of Newcastle, and he is the regional specialty advisor for UK Northern Denary. Those for you, sir.
So a huge thanks, Dr. Al-Assad. Many thanks for the invitation. I'm just going to do my share screen. share. Okay, and just to check, can everyone see it?
Clear, yes, we can see.
Okay, just to say that I'm just one of the authors for this guidance. My main collaborator was Dr. Chana Jayasena from Imperial College London. And although this started off as guidance from the Society for Endocrinology, it's also been adopted by our colleagues across the Irish Sea, which is very nice. So where does this all start? Sorry, one moment. So this is just to run through to you how hypogonadism can present across the male lifespan, from youth to old age. And we aim to cover, to some extent, all of these. So neonatally, with 46 XY disorder sex differentiation, you can present with ambiguous genitalia, or bilateral cryptorchidism and micropenis. All of these strongly suggest there's something wrong with the male reproductive axis, even at birth. Or you can present in later childhood with delayed, absent, or arrested puberty. Gynecomastia can occur at any age. In adult life, sexual dysfunction or infertility, vasomotor sweating and flushing. If you had socioeconomic characteristics, we begin to lose them. And older age, premature osteoporosis, anemia, and myopathy. So the background of these guidelines were actually another set of guidelines from the British Society of Sexual Medicine, published in 2017, which they submitted for adoption to the UK Royal College of Physicians. The college then sought advice from the Society for Endocrinology Clinical Committee, who circulated. And really, we didn't feel these guidelines were consistent with the principles of practice of UK endocrinology. And we therefore it was not felt that these were suitable for adoption by the College of Physicians. But on the other hand, here were some UK guidelines, which we were saying were not suitable, but there were no others. And our society did not have guidelines of its own. So they, in 2018, the chair of the clinical committee tasked myself to assemble a guidelines team and get cracking. And my first recruit was Dr. Jayasena. So the group with the 12 of us, we decided to go multidisciplinary. So the 3 endocrinologists, but also 2 urologists, andrologists, 2 biochemists, 1 reproductive gynecologist, 1 academic GP, an endocrine nurse specialist, and an expert patient with Kalman syndrome who has a big web presence and is very connected. This is the science bit, the male reproductive axis, and we wanted to cover all aspects of this, including fertility, induction, spermatogenesis, where that was feasible. And we also wanted to make sure that our guidelines clearly distinguished between true hypogonadism, where there's an organic defect of either at the testicular level or at the hypothalamic pituitary level, as opposed to men who are unwell for other reasons, and with a secondary suppression of the central axis physiologically, due, for instance, to inflammatory cytokines. And really, this just illustrates the background, the fact that in men with chronic illness, doesn't matter what your illness is, your gonadal axis tends to shut down. And biochemically, it's indistinguishable from central hypogonadism, but it invariably results when the particular underlying disease is cured or remits. And just to say that a lot of the published papers that you will see, which refer to men having secondary hypogonadism, these men are probably not hypogonadal. These are men almost certainly with non-gonadal illness, which is akin to how the picture of central hypothyroidism looks very similar to sick euthyroid or non-thyroidal illness syndrome. And importantly, the biochemistry invariably resolves when the particular underlying disease is cured or remits. And particularly in relation to obesity, whether you lose weight or whether you undergo bariatric surgery that then restores normal physiological parameters, including the gonadal axis. There are some interesting data to suggest that the relationship between testosterone and diabetes metabolic syndrome is sexually dimorphic. So actually in men, a lower level of testosterone is associated with higher prevalence of type 2 diabetes metabolic syndrome, whereas higher levels in women are associated with a higher prevalence of type 2 diabetes metabolic syndrome. And actually, around about a third of men with type 2 diabetes syndrome have a low testosterone level, most with low normal LH. And again, many authors have labeled this secondary hypogonadism. We feel this is better termed as non-gonadal illness. And longitudinal studies show that lower testosterone levels in men and higher levels in women are associated with greater risk of developing type 2 diabetes metabolic syndrome in the future, although actually the direction of causation is hard to ascertain. And also, once you adjust for abdominal girth, these relationships become much weaker. Crucial bit of evidence that came out over the last few years is the fact that just how important it is to do your samples at 9 AM and fasted, just because there's a big drop in LH similar to testosterone secretion with acute energy intake or protein intake. I think this is how we classify male hypogonadism. And broadly speaking, we divide between intrinsic dysfunction of the testes, where the light bulb's broken, and lack of LH nephrotic stimulation, where the light switch is turned off. And important to recognize that in the first situation, the biochemistry gives you the diagnosis. So the only reason why the biochemistry might not give you the diagnosis is if the sample's taken from the wrong patient. But essentially, if you have low testosterone, high LH, usually the FSH is even higher, the diagnosis is unequivocal. This patient has primary gonadal failure, primary testicular failure. Light switch off, lack of FSH stimulation. This can be harder to distinguish between a number of things. For instance, non-gonadal illness effect, or an afternoon or non-fasted venipuncture effect, or just after a really bad night's sleep. And so in this situation, the clinical context is vital to make an accurate diagnosis of true central hypogonadism. We chose to go with central rather than secondary hypogonadism as a more precise term for low LH or low FSH. The European Male Aging Study was hugely informative to us. We know that the age-related decline in serum testosterone, everyone knows it's there, but it predominantly reflects the physiological effects of obesity, inflammation, and accumulated non-gonadal illness to suppress the hypothalamic pituitary gonadal axis, giving you low testosterone and low normal LH. However, about 1.5% of older men have low testosterone and high LH, so they have unequivocal primary gonadal failure. And the proportion increases a little year by year. So the older you are, the likelihood your testes are going to fail. And this is a nice quadrant picture. There's a very similar one in EMAS. This is actually taken with the Chinese equivalent SPECT China. And so this group here, these are men who've got normal LH, normal testosterone, they're normal. This group here, SPECT China calls them secondary hypogonadism because they've got low LH and low testosterone. But actually, a lot of these could be men with non-gonadal illness. Up here, top left, these are men with unequivocal primary hypogonadism. So 1.5%, almost exactly the same as European Male Aging Study, this Han Chinese group. And then we have the group about 10%, similar to EMAS, which is described as having compensated hypogonadism. So these are men with a high LH and normal testosterone. However, this is a purely biochemical term. It's not a clinical term. So if you have a man with, say, low normal testosterone and high LH, biochemically, you can call that compensated hypogonadism. However, that man is anemic, osteoporotic, azoospermic, or has Viagra-resistant sex dysfunction, you wonder just how compensated that is clinically. So amongst these men are probably men with actually true primary hypogonadism, just in the early stages. And also, neither SPECT China nor EMAS checked FSH levels, which tend to be more stable. And there's always a possibility you just happen to pick up an LH pulse peak. And just remind you again, men with primary hypogonadism treble the risk of having type 2 diabetes, as it's treble the risk in men with Klinefelter syndrome and treble the risk in men with dystrophy myotonic. There's something about having primary gonadal failure which trebles your risk of having type 2 diabetes, whether it's a congenital problem, genetic problem, or an acquired problem. Almost no one has done any work in this area. So having been on record for many years saying, the andropause doesn't exist, it's an invention by big pharma. Well, actually, it does exist, just it's exceptionally rare, 1 to 2% of older men. Regarding the drop in testosterone with age that largely occurs due to non-gonadal illness, interestingly, although that occurs in linear fashion in EMAS, in SPECT China, that holds until late middle age. But actually, if you look at older Chinese men, so I call them the immortals because, they survived the Communist Party, Chairman Mao, mass famine, collectivization. They're stick thin, they eat healthily, they haven't adopted Western diets, they're tough as old boots, they're survivors, and actually their testosterone levels are no different from that of younger Chinese men. So this is how we chose to define male hypogonadism, and we've done it slightly differently, slightly more strictly than other groups. So we certainly do not approve of the term testosterone deficiency, because this is a descriptive term rather than a diagnostic category. Like other guidance, we say it's a clinical syndrome comprising clinical features and laboratory evidence, but also we emphasize the relevance of reduced fertility. Again, there are certain exceptions, the rare Pasqualini syndrome, activating mutations of the FSH receptor, but in general, if you have preserved fertility, that is very unlikely to be compatible with a diagnosis of hypogonadism. And even though we're quite fussy about precisely how you're going to diagnose central hypogonadism, just to make sure you're not getting mixed up with like artifact or obesity or venipuncture effect or non-fasting, when it comes to primary hypogonadism, we don't fuss around. Low testosterone, high LH, you're hypogonadal, the end. If you haven't got sexual symptoms, you know what? So what? If you don't have any symptoms, so what? You have primary gonadal failure, whether you realize it or not. And we also emphasize that although most definitions of hypogonadism conventionally require sexual symptoms, actually men may not volunteer them, it may not be important, and certainly we don't see that the absence of sexual symptoms or the absence of the patient willingness to talk about sexual symptoms to be an obstacle to actually making the diagnosis. So we believe that through contextual clinical and laboratory statement, any diagnosis should be framed in relation to one of the recognized causes, and whether diagnosis is testicular, primary, or secondary central. And thinking about the clinical features of male hypogonadism, these can be reproductive, infertility, sexual dysfunction, gynecomastia, or non-reproductive. And the non-reproductive ones can be physical, which is fatigue, reduced strength endurance, anemia, osteoporosis, fracture, or vasomotor symptoms, and much less specifically psychological. Loss of motivation, concentration, irritability, lower labile mood, and particularly in the congenitals, intense body shame. Our American colleagues got a bit obsessed about tandem mass spectrometry for testosterone levels, but actually they're only superior in the female range to standard immunoassays. In the male range, say about sort of 5 to 35 nanomole per liter, some immunoassays outperform tandem mass spectrometry. So if you've got tandem mass spec, great, but it's not the holy grail for males. And actually, the between laboratory agreement for some immunoassays can be as good as 4% coefficient variation, whereas a tandem mass spec goes up to about 10%. So actually tandem mastectomy may actually be worse than a good immunoassay. Always measure total testosterone fasted before 11 a.m. after a good night's sleep and not during periods of intercurrent illness. And the diagnosed hypogonadism is supported by other lab features, such as not just testosterone isolation, but you may have a raised LH, you may have a low bone density, anemia, or that testosterone is below reference range on at least 2 separate occasions. Although, of course, if your LH is high, doesn't matter, one sample will do. If you're suspecting male central hypogonadism, further investigation should include pituitary function, particularly prolactin level. Rule out iron overload because the pituitary gonadotropes have an iron transporter in their cell membrane, and so they're that much more vulnerable to iron overload than are other pituitary cells. And usually it's necessary to perform MRI scanning. The exception being if there's compelling evidence for non-gonadal illness. And that might be, a guy with morbid obesity and sleep apnea. You're thinking, I think this guy's got a very good reason to have a low testosterone level with normal LH. I'm probably not going to go down the path of doing the full investigation here. So what to do with the total testosterone borderline or not really consistent with clinical context? We think it's worth measuring NSHBG level to our calculation of free testosterone. When SHBG is mid-range, it adds no value to the diagnosis. When SHBG lies at either extreme of the reference range, higher side or lower side, it correlates better with androgenicity than does total testosterone. Problems with the free testosterone calculation is the formula hasn't quite been perfected yet. And also, there is a lot of variability in routine clinical labs in measuring SHBG. And the coefficient of variation is far higher for SHBG than it is for testosterone. So you can imagine in the UK, 7 assays for testosterone, 6 for SHBG, and vast amounts of different permutations for calculated free testosterone and reference range. So free testosterone is not automatically better, but it can get you out of a false positive diagnosis when your SHBG is on the low, or very low, and it can get you out of a false negative diagnosis when your SHBG is very high. And really, we need to work harder on this. So the endocrinology and biochemistry community need to begin to work harder to establish better interlaboratory standardization of testosterone and SHBG assays. So late onset hypogonadism, this has been banded around a lot and it means different things to different people. So this is from the EMAS study, and they felt that really it required the presence of 3 sexual symptoms and either total testosterone less than 11 and free testosterone less than 220 picomole per liter. And originally classified as a clinical biochemical symptom associated with age-related comorbidities, particularly obesity, symptoms of low testosterone, and consistently low serum testosterone, and after excluding what they term as classical causes for hypogonadism. But really, only 2% of men aged 40 plus fulfill the criteria for late onset hypogonadism. And again, it's possible that all of these may actually have had non-gonadal illness instead. And interestingly, there was only very limited impact of aging per se once you removed the effects of comorbidities. But I think what I would say, I think we need to reset what LOH means. I think we should now say that LOH means those men who have primary hypogonadism and raised LH due to old age, as opposed to Klinefelters or as opposed to testicular torsion or whatever. So I think we need to redefine LOH in relation to primary gonadal failure. Interestingly, although the incidence is low in men, 0.2% a year, it increases equally with both chronological age and illness. So fertility in central hypogonadism. Many of these men don't quite get the message. It's not explained to them that well. They need to understand that at present, they are probably infertile. However, this is about the only direct hormonally treatable cause of male infertility. If we put the gonadotropins back, we can either restore or start de novo spermatogenesis. But the treatment should vary according to the context. So if you've previously been through an entirely normal puberty, developed normal sized testes, and then you lost pituitary function, say due to a tumor, actually, HCG alone, twice or 3 times weekly, may be just fine enough to restore spermatogenesis. If it doesn't work, you could always then add FSH later. However, if you have a congenital central hypogonadism where you never properly developed normal testes similar to spermatogenesis, HCG alone monotherapy is futile, completely futile. And you should start with both HCG and FSH. We also recommend, rather, in the same way that you target your HCG dose according to levels. So you want normal testosterone, you don't want the estradiol level to rise too high because it predisposed to gynecomastia. You want to keep the hematocrit normal as well. And similarly, we don't suggest giving FSH blind. We suggest doing some endocrinology and targeting a physiological serum FSH level of 4 to 8 units per liter. If you got the severe end of congenital central hypogonadism, so your testes may be less than 4 mil, or there's history of clitoritism or micropenis, there are some data to suggest that if you pre-treat them with FSH first, before adding HCG, that may be beneficial in terms of stimulating German Sertoli cell proliferation before you determine their differentiation with Leydig cell secreted testosterone. And check the blood tests and analysis every 3 months. Testosterone cardiovascular safety is a little bit frustrating because I kind of know the answer to this, but I can't tell you because the work hasn't yet been published. So why might it be a problem? Well, one is the effect on hematocrit. Testosterone stimulates red cell production in bone marrow, and we know from the Copenhagen study that men with a higher hematocrit had 50% greater risk of MI than those in the middle 50 centiles. There are also data from the Tromsø study suggesting a greater risk of venous thromboembolism, particularly unprovoked venous thromboembolism in men with the highest hematocrit. If you look at the cross-sectional studies of testosterone treatment, some show reduced cardiovascular risk, some show increased cardiovascular risk, and some show no change at all. However, one RCT was stopped early in 22 cardiovascular events versus 5 in the placebo arm. Big problem. You may have heard the term major adverse cardiovascular or coronary event, which is bandied out quite a lot in cardiology circles. We discovered recently there is no internationally agreed definition of what constitutes a MACE, which would be helpful, wouldn't it? So we know that whereas the European Medicines Agency has not put any labels on testosterone for cardiovascular risk, the American FDA has insisted on a stroke risk on its label. So the risks, well, actually, I said the risks are very clear to me, or risks or no risks, but unfortunately, I'm not allowed to share that with you yet. Discuss risks versus benefits with patients with high cardiovascular risk. Further information is coming soon. First from the testes, individual patient data meta-analysis, data and submission to Lancet, and then the Traverse study managed by the FDA should begin publishing results next year. And then we'll know for sure. So the priorities of monitoring therapy, probably 1 and 2, I would say, are equal: sexual function, general well-being, and 2, hemoglobin and hematocrit. Serum total testosterone, other things being equal, if you're intramuscular, you aim for lower end of the normal range at trough. If you're on gel, you're in for mid-range 2 to 6 hours post-application. However, if your hemoglobin and hematocrit are rise too high, you will have to accept lower levels of testosterone than that. Conversely, you're a young man with, for whatever reason, absolutely rubbish bone density, with high testosterone as you possibly can, short of raising the hemoglobin and hematocrit. And so we suggest this idea of low end of normal at trough for intramuscular and mid-range for gel. To some extent, it's other things being equal and motherhood and apple pie. So issues of bone density or hemoglobin hematocrit may need to override that for the individual patient. Important to do periodic assessment of bone density by DEXA. Now, prostate safety. We had 2 andrologists in this, and we're very clear that there are no data to suggest that testosterone treatment in men with hypogonadism increases the risk of de novo prostate cancer. We therefore suggest that you follow general advice for the male population. In the USA, there is a national screening program, follow that. In the UK, there isn't. However, if you are going to screen, you should target older men, those with a strong family history, or with Black ethnicity as being at much higher risk. So really, we think there are insufficient data to support the efficacy or safety of a physician-led prostate screening program in men with hypogonadism. So this is possibly our most controversial position taken. We also say that there is, although there is no universal andropause, around 2% of older men have proper testicular failure, and they should generally receive testosterone treatment. Testosterone should be the first-line treatment of osteoporosis in men with hypogonadism, not alendronic acid. However, if you have a patient whose risk of fracture, when you calculate it, is very high at that point, then you could also prescribe a bone-specific agent as well. We already discussed the prostate issues. So take-home messages. Primary hypogonadism with high LH is simple to diagnose in almost all situations. But the diagnosis of central hypogonadism is only secure when it's framed in the context of a recurrent syndrome, such as due to opiate analgesia or due to pituitary surgery. Men with high normal hemoglobin hematocrit or normal sperm counts are very unlikely to be hypogonadal. And finally, this could come as a surprise to some of our colleagues in general practice or in geriatrics, that testosterone treatment of men with a well-founded diagnosis of male hypogonadism is effective, safe, and cheap, and should not be withheld for reasons of age or disability or mental health. The principles of treatment of dealing with individuals with learning difficulty is that, for instance, is that their treatment they should not be deprived of treatment that you would otherwise treat other men or women with. However, this experience and the risk benefits of testosterone treatment can't be extrapolated to men with low testosterone levels, which are due to primary age-related frailty or non-gonadal illness. There are very few situations in which we say that testosterone treatment is contraindicated in men with a verified diagnosis. One of these would be if they're seeking actual parenthood. Also, active prostate cancer, active breast cancer, erythrocytosis, probably also uncontrolled sleep apnea and uncontrolled congestive cardiac failure. And for with obesity and borderline testosterone and low normal LH, we really emphasize the primacy of lifestyle change over testosterone treatment, unless there are compelling reasons, such as osteoporosis, anemia, reduced testis volume, or refractory sexual dysfunction. We note the findings of the recent T4DM study, which showed protection against type 2 diabetes in obese men with or without low testosterone. but this was at the cost of real problems with erythrocytosis, also blood pressure and lipids. So many thanks for this and for listening in. And right, yep, I have unshared now.
Thank you, Professor, for your interesting topic. We can postpone the questions till the end, because if there is any urgent question, we can answer it now. Okay, so the next speaker, can you introduce, Richard, can you introduce next speaker, please?
Let me just,
in front of you.
Oh, yes. It's good to see you, Dr. Rabab Saab. So Assistant Professor of Endocrinology, University of Balamand, affiliated with the Mount Lebanon University Medical Center, diplomat from the Sorbonne University in Paris, authored numerous papers and medical works, also holds a degree in therapeutic education of patients, a big interest in the management of obesity in both clinical and scientific contexts, and he's also actively involved in several national and international scientific societies. Dr. Rawan Swab, soyez la bienvenue aujourd'hui.
Merci, monsieur. Bonjour, monsieur Richard. Hello, everybody. Thank you very much for your invitation, and congratulations for the organizers. It has been quite a load of information, which is very, very precious in these times. So thank you for letting me present the topic that I hold very dear to my heart. Let me try to see if I can share my screen.
Thank you, Dr. Rawan. We'll switch off our camera so you can show your
Thank you.
post. Yes.
Let me try to see. I'm having a bit of a trouble to put myself on slideshow mode. All right, is everybody, I hope that the slides are easily seen. So I'm going to be presenting polycystic syndrome, polycystic ovary syndrome as a risk factor for metabolic diseases. These are my objectives. First, we're going to define what PCOS is to try to find the link between PCOS and metabolic syndrome, the effect of androgens, the cardiovascular risk scores, and a careful take-home message to try to find a nice way to treat our patients. So polycystic ovary syndrome, as you know, is the most common endocrine disorder in women during the reproductive ages, and it is associated with a plethora of cardiometabolic consequences. We know that 15% of the women in the general population fit the description of PCOS according to the Rotterdam criteria. Women with PCOS often seek the care of medical personnel for menstrual disturbances, clinical manifestation of hyperandrogenism, and infertility. The presentation of the disease varies widely. So we know that 30% of ladies with PCOS would have normal menses, while 85 to 90% of them would present some sort of oligomenorrhea. And even up to 40% would have complete amenorrhea. PCOS is associated with a higher prevalence of metabolic syndrome compared to ladies not having PCOS, and this is 2.2 times higher. So although women with PCOS frequently seek medical attention due to different symptoms that we have already described, much attention has recently been focused on metabolic derangement. The prevalence rate of the metabolic syndrome in PCOS women varies largely between different countries and ethnicities. For example, 43 to 46% of ladies with PCOS would have metabolic syndrome in the United States, compared to 8.2% in southern Italy. And this is, it could be the result of very different factors like age, race, and different approaches to define metabolic syndrome in different countries. There is a link between PCOS and metabolic complications. As you can see in this little diagram, we see that the presence of cysts in the ovaries would lead to an androgen excess. This is going to increase the fat cells in the abdominal visceral adiposity, by that increasing a lot of markers such as TNF-alpha, interleukin-6, and leptin. This would provoke an insulin resistance at the level of the glucose transporter, leading to hyperinsulinism. And hyperinsulinism itself is associated with multiple cysts in the ovaries. So we're stuck in a vicious cycle. And this cycle is going to lead to increased blood pressure, insulin resistance, as said, fatty liver disease, dyslipidemia, as well as endothelial dysfunction, among a lot of other signs and symptoms. Insulin resistance is very important to discuss when we're talking about women with PCOS, because it plays a very important pathophysiological role, and it would help in the evolution of metabolic syndrome. And we know that a lot of symptoms and signs associated with metabolic syndrome overlap with those of PCOS. As you can see here, insulin resistance is central for the diagnosis of PCOS, but it's also very important in obesity, as has been discussed so many times today, macrovascular and microvascular disease, glucose intolerance, hypertension, dyslipidemia, and endothelial dysfunction. We know that the BMI increases mostly between the ages of 20 to 30 in ladies with PCOS. So this age is a very sensitive time period for the development of the symptom. And it's very important to screen the ladies as early as possible to be able to manage the complications of the syndrome. 50 to 80% of women with PCOS would have some sort of insulin resistance, and this is going to increase the risk of diabetes by 2% every year. Insulin resistance is associated with obesity, but even lean women may have insulin resistance, and this is the sine qua non of the PCOS situation. This is going to increase the risk of diabetes mellitus in these patients, reaching up to 10 times more than patients without PCOS. So let's say we have a patient with PCOS, 16% of those patients with normal glucose tolerance would convert within a few years into impaired glucose tolerance. And the yearly risk is 2% to be converted to overt type 2 diabetes. So we should start seeing PCOS truly as a precursor for diabetes, and this is very important to prevent this deleterious disease. The risk of metabolic syndrome is also elevated even in lean women. As you can see in these pictures, it is up to 3 times more important in lean women with PCOS versus women without any PCOS. Insulin resistance, I hope I've convinced you, played a very fundamental role in mediating and increasing the risk factors in PCOS. So insulin resistance is associated with hyperandrogenemia, which is going to lead ultimately to a rise in blood pressure. We're going to discuss it a little bit down the conference, as well as obesity. And all of this is going to lead to the appearance of cardiovascular diseases. Obesity presents an additive effect on insulin resistance as that of PCOS. So the visceral adiposity in PCOS is associated with a greater insulin resistance, and this will exacerbate the reproductive and metabolic abnormality of PCOS. These have already been discussed. We're going to go through them in a little while. So insulin resistance is directly linked to dyslipidemia, type 2 diabetes, low-grade inflammation, hypertension, and as you know, all of these are cardiovascular risk factors. The risk of metabolic syndrome in PCOS increases with BMI and age. And this has been published in 2016, where you can see that the prevalence of metabolic syndrome was 19.7%, and it would be increasing with age and BMI. And this is statistically significant across all of the variables, whether age, BMI, or the components of metabolic syndrome, such as a low HDL, a high waist circumference, an elevated triglyceride, and a fasting blood glucose, as well as an elevated blood pressure. And we know that we need 3 components out of 5 to be able to diagnose metabolic syndrome. The cardiovascular factors may often appear at an earlier age in ladies with PCOS. So ladies with PCOS present a large group of increased risk for developing a cardiovascular disease, and we have to screen them as early as possible. They are at a higher risk of having CVD, mainly CHD, an increased carotid intima media thickness, an increased calcium artery score, increased inflammatory markers such as CRP, fibrinogen, white blood cells, and so on. There's a 3.3 time increased risk of death from MI in postmenopausal women with a history of PCOS And comparing moderate to severe PCOS, we know that the higher the severity of PCOS, the higher the cardiovascular heart disease. CAC scores. The increase in CAC score observed in PCOS patients is independent of age and BMI. So we know that PCOS itself is an independent risk factor, and this is where we have to be very vigilant in treating. Young women with PCOS, they have a greater CIMT compared to age and BMI matched controls. And we know that CIMT has been advised to be measured in women with PCOS as early as age 30 and then 3 to 5 years after. And the CAC scores should be measured by computed results. Hypertension and PCOS. It has been shown in different studies, and the one that I have added the pictures from in 2017, that the mean systolic and diastolic blood pressures are significantly higher in ladies with PCOS. There's been a study of Dutch women aged 45 to 54 years old, and the prevalence of hypertension was seen to be 28.1% in the PCOS group compared to 11% in the control group. And it has been seen that the androgen level were significantly and positively correlated with both systolic and diastolic blood pressure in patients with PCOS, and this was independent of insulin resistance, obesity, and dyslipidemia. Talking about dyslipidemia, there's a lifelong apolipoprotein lipid metabolic dysfunction in women with PCOS, and this factor exaggerates the risk for CVD with aging. So PCOS would lead to weight gain mainly over a visceral and central adiposity linked with dyslipidemia, as well as a higher cardiovascular risk factor and insulin resistance. And the increased androgen secretion is also associated with a higher risk, as we have discussed, with hypertension. Dyslipidemia and PCOS, among all of the cardiovascular risk factors, dyslipidemia is certainly the most persistent and the highly prevalent. And we know that ladies having PCOS would have a higher LDL level that advances all over the ages up to the 4th decade. A triglyceride would also be elevated, especially in obese ladies. And we know as part of the metabolic syndrome, the HDL cholesterol would be lower, and this could be seen as early as the 20th decade, the 2nd decade, 20 years of age. In PCOS, insulin resistance will lead to an increased insulin. This would lead to inability to suppress lipolysis. And this would lead to the mobilization of free fatty acids from adipose tissue to the liver, hampering the inhibition of hepatic VLDL synthesis and blunting of the catabolism. This would get us to an abnormal lipid profile. An abnormal lipid profile is atherogenic, such as high triglyceride, high LDL, and a low HDL number. In addition, some studies have revealed the presence of highly atherogenic, small, dense LDL in these ladies with PCOS. The metabolism of these large particles would result in the formation of smaller, denser particles, and those are poorly cleared. Insulin resistance is also associated with a reduced clearance of VLDL particles and chylomicrons, and this would impair the apolipoprotein E-mediated clearance of very rich lipoproteins with triglycerides. There was a meta-analysis by Wild et al. That showed in ladies between 18 to 45 years of age that there was a higher LDL level, a lower HDL level, and a higher triglyceride level. True, it's not very high statistically speaking, but if we are adding up these cardiovascular risk factors across the age and across these patients' lives, this is going to increase the cardiovascular risk factor. Metabolic syndrome, hypertension, and dyslipidemia has also been seen to be increased in families of ladies with PCOS, which leads to a hereditary component to be examined among these patients. So we know that in 14 studies, the meta-analysis showed that the mothers of ladies with PCOS had a 1.78 times higher risk of metabolic syndrome, fathers 1.43, sisters 1.5. Same goes for hypertension and dyslipidemia. So even the male component, the male aspect in the family is also hit by ladies who have PCOS. So it is a genetic component that has been reviewed. Androgens, there's a positive correlation with insulin resistance and PCOS. So obesity is going to lead to insulin resistance, and this is going to increase the circulating androgens in the ovary, adrenal, and adipose tissue. This leads to indirect effects on the theca cells of the ovary. There's an effect on the central stimulation of LH release, and there's a decreased production of SHBG at the level of the liver. PCOS is the most common cause of androgen excess, as we know, in young women, 80% of the population having PCOS, with significant elevation of DHT, DHEA, DHEAS, and androstenedione. And we know from studies, especially this one that has been published in 2017, that ladies with a higher androgen ratio and a higher concentration of testosterone fare worse when it comes to the cardiometabolic profile compared with women with PCOS having a normal level of androgens. Let's talk a little bit about the treatment. Traditionally, the first-line treatment of PCOS were oral contraceptive pills. The question is now, knowing that we have the metabolic component, are we with or against the treatment of PCOS with OCPs? In 2017, this study has shown that combined OCP increased the risk of venous thromboembolism in the general population, and it is also influenced by age, smoking, and obesity. We know that estrogen can have negative cardiovascular effect, especially in ladies above 35 years old, so they are usually less recommended. Although the ideal progestins to use are those with the lowest androgenic profile, they may induce a higher number of VTEs and may be contraindicated in patients with severe obesity, especially ladies with PCOS with central obesity due to insulin resistance. Several clinical studies have suggested that the use of OCP may aggravate insulin resistance and would worsen hyperglycemia in obese women with PCOS. What about cardiovascular morbidity and mortality? We know that OCPs have a beneficial effect on HDL, but they also present a detrimental effect by increasing triglycerides. And some studies have also shown that OCPs can exacerbate hypertension in women, and this is associated with a 2 times increase in the risk of cardiovascular factors in the general female population. So since OCPs are a little bit frowned upon in metabolic syndrome with PCOS, what should endocrinologists provide for women with PCOS at diagnosis? Well, what is important is to have a careful metabolic and cardiovascular assessment, and this is advisable for all women with PCOS. Screening for risk factors should start as early as possible and even at diagnosis. It has been suggested that BMI, waist circumference, and blood pressure should be measured at each visit. The ADA recommends diabetes screening for high-risk patients, including women with PCOS, at least every 3 years, while some other organizations have recommended screening every 1 to 2 years, depending on the presence of different risk factors that are coexisting. Although there are no long-term data in the morbidity and mortality for cardiovascular risk factors in PCOS, it is advisable to perform a careful assessment in order to tailor the most suitable strategy and to prevent cardiovascular disease. It's always important never to forget the lifestyle modification is always the first step, as well as insulin sensitizers. The question remains, if this is going to take care of insulin resistance, what happens concerning dyslipidemia? Because as we have said, these ladies are at higher risk for dyslipidemia. In this case, statins may be advisable and offered to patients depending on their needs and depending on their profile. So in conclusion, it's always important to remember that not all cases of PCOS are the same. The treatment needs to be tailored according to the patient's profile and her complaints. Endocrinologists should always start screening PCOS patients according to their presenting risk factors for metabolic syndrome and future metabolic risks. And treatment, as always, should be adapted according to the needs. Thank you very much.
So many thanks for Félicitations for a wonderful presentation. And I think we are going to keep questions to the end. Is that right, Dr. Assad?
Yes, it is.
Excellent, excellent.
So basically, there is a question for you. Thank you, Rawan, for your nice presentation. For diabetes, would be the question for Richard. with
Yes.
the diabetes, can testosterone replacement help if borderline low? So diabetes with the ED, can testosterone replacement help?
Okay, so it all depends what the clinical context is. So if you have a man with proven hypogonadism, so yes, almost certain. So it depends what you mean by help. I'm sorry. So a man with a borderline low testosterone who's obese and who's got diabetes or pre-diabetes, even if they don't have what I would call actual hypogonadism, if you give them testosterone, you'll improve insulin resistance and you'll reduce their chance of going from pre-diabetes to diabetes. Or if they have early diabetes, you'll increase their chance that they'll be rolled back to pre-diabetes. However, this is at the risk of a very high risk of inducing high hematocrit, polycythemic erythrocytosis, which may in turn increase cardiovascular risk through a different mechanism. So this is the difficulty. However, for a man with who's got obvious hypogonadism, high LH, they've got Klinefelter maybe, they'll generally be anemic to start with, and so starting them on testosterone treatment does not present this kind of problem. But yes, if you start your classical obese vasculopath who's not really hypogonadal and whose low testosterone reflects body mass index rather than hypogonadism, classically they will have a high normal hematocrit, and therefore testosterone treatment would probably not be wise.
Thank you. And another question for Dr. Rawan. Do you think women who are overweight and change their lifestyle, diet and exercise, but could not lose significant weight, would see improvement in symptoms?
Yes, it's true, because we see it a lot in clinics. Lifestyle modification is very important, not just at the level of the weight. We're talking decreases in insulin resistance. As we have discussed, the number one factor in the development of maintenance of polycystic ovary syndrome is insulin resistance. So a good lifestyle modification should be able to decrease the resistance to insulin and thereby decreasing the symptoms. The weight is not the only factor that we look for. We look for central obesity. We measure the waist circumference. Let's not forget that for people who are exercising, there's a higher muscle bulk. So it's not necessary to see a decrease in the weight as much as a decrease in the body composition. So yes, if they are overweight and have started on a healthy lifestyle, even if they have not lost as much weight as they wanted to, there is an improvement in insulin resistance and there is an improvement in the signs and the symptoms. The first thing that you see usually is a better menstrual cycle. Ladies will always tell you the first 3 months of their treatment, when lifestyle modification is important, the first thing they notice is that their periods get back to being into a regular system. So weight is not the only factor to look for.
Any question for Dr. Rabab? Dr. Rabab with us, I think. Yes. And by this, I can feel that if we have no more questions.
Can I have just one comment
Yes.
for Dr. Rabab? Maybe slightly in defense of the contraceptive pill. I mean, for historic reasons, almost all contraceptive pills are based on ethinyl estradiol, which I'm not sure is, I hesitate to call it estrogen because it's not human estrogen. Although there are some newer ones now that are based on human estradiol. Now, we know from transgender women that actually ethinyl estradiol is completely banned in transgender women because compared with regular estradiol, it increases blood pressure, it increases cardiovascular risk, it increases risk of venous thromboembolism. And so it's always slightly surprised me that we think, oh, well, transgender women, they're so delicate. They must have natural estradiol. We can't possibly give them this nasty poison, ethinyl estradiol. But regular women, oh yeah, have ethinyl estradiol, it's fine. And there's a certain kind of like disconnect there, which I find difficult to comprehend. And I realize the data on estradiol-based contraceptives is much more limited. but from first principles, they would seem probably to be safer.
Yeah. Yeah, they're safer as whenever you're going to use oral contraception. But I mean, the way things are shifting recently is to try to see PCOS as a metabolic issue much more than it is a reproductive hormone issue. But yes, I completely agree with you. It would be very interesting to see if there's any improvement by putting patients on this kind of treatment rather than what we usually see.
A pleasure, wonderful talk.
There is
Thank you
no
so
more
much.
questions.
I really enjoyed it.
I'd like to thank Dr. Rabab, Dr. Rawan, and Dr. Richard for really informative lectures, and thank you for your discussion as well. And I will hand over for Dr. Batil, Dr. Molina to start their session. Dr. Batil is here. Yes, sir.
Lovely. Thank you.
I'll hand over for you.
Thank you, Dr. Saad. Thank you very much. This is the final front. Again, thank you for the organizers for inviting me to be a part of the esteemed faculty. I think you'll all agree it's been a wonderful 3 days of education interaction. So the final session of today and of the conference, 3 very good speakers. First up is Dr. Omar Abdul Jabbar, and Dr. Omar is a consultant neurologist at the Bahrain Defense Force Hospital. He's also a clinical lecturer in neurology at the Royal College of Surgeons in Ireland, here in Bahrain. He's also a lecturer of medicine at the Arab Gulf University, and the title of his talk is 10 Points for Dementia. Hopefully, she'll be able to remember most of the 10 points by the end of the talk, and certainly end of the day today. Is Dr. Omar with us today? Excellent.
Yes.
Welcome, Dr. Omar.
Assalamu alaikum. Thank you, Doctor, for your presentation. Thank you very much. بالبداية صوت واضح دكتور؟ Clear speaking?
Yes, Dr. Omar.
Yes, clear, Dr. Omar. We can
hear you very well. We can hear you very well. The floor is yours.
Just for sharing the 1 minute.
While Dr. Omar's getting his presentation up, I would just say it's been a really nice mix of endocrinology sessions, diabetes sessions, sessions about internal medicine, reproductive health over the last 3 days. I've certainly enjoyed, much of the last 3 days, but also the discussion after the talks. Are you okay, Dr. Omar?
One minute, just.
Sure. No, that's fine. We've got a bit of time. Don't worry, we're running slightly ahead of schedule, so we've got a bit of time. I guess it's a good time to start thanking our organizers behind the scenes who put an incredible amount of work in this conference. It's a shame we're not face-to-face, but I'm sure we'll be face-to-face interacting with each other in person very soon.
No,
Great.
okay.
We can see your slides, yes, of course.
Okay. Thank you very much. Thank you, Dr. Asad, and thank you for all the organizing meeting, for this all presentation, nice presentation. Our lecture today about dementia, which is very important topic in medicine and common to be seen in our neurology clinic and also in general medical clinic. So to start with dementia, our lecture, sorry. Yes. For the lecture summary, we start with the definition, then we discuss risk factor, and we start our main topic in the questions in dementia. Then for assessment and investigation, and also at the end we can discuss some few types of dementia. So first of all, for definition of dementia, before the definition was one of the most important sign is the memory loss plus one or more of cognitive difficulties such as disorientation or disturbing executive function, or language problem like aphasia, or motor function problem like apraxia or agnosia. This dementia should be significant that interfere with the social or occupational function. And it will be also one of the characteristic features. It should be changed from the baseline function. And this is the old definition. Now, in the recent few years, the definition for dementia is decline in one or more of the neurocognitive domains severe enough to interfere with daily living activity, which means not only memory impairment needed or memory impairment should be present to diagnose of dementia. We have about 6 domains. Anyone affected can give us one of the causes of dementia. For example, we have motor function decline or language problem, or executive function, or learning and memory impairment, or complex attention problem, or social cognition. So at now, there is no need to only memory, or one of the characteristic features is the memory. Anyone impaired significantly to interfere with the daily living activity, we consider this condition as dementia. So what cognitive changes do we see in person with dementia for these domains? For example, for learning and memory, we have the amnesia or memory problem. For the language, we have aphasia. For the perceptual motor, we have visual recognition like agnosia. We have performing motor activity like apraxia. Apraxia means forget to do previously learned motor activity. For executive function, we have abulic and apathic patient. And for complex attention, you have distractibility. Regarding the epidemiology of dementia, the time being, or the last 20 years, more and more cases of dementia will be diagnosed. So this increases the number. Also the facilities of getting more investigation for dementic patient, more and more. So every few years, the number of dementia cases per ward increasing, reaching 2050 about 130 million per cases per ward. So this is an increasing number, make more burden on the health system, and it will affect the other disease condition. So it should be this dementic patient should be managed and investigated, and if we can treat it, we can treat it as early as possible. Regarding the risk factor for dementia, the most important risk factor is the age. By this risk factor, this is considered enough to diagnose patient with the most common cause of dementia is Alzheimer's disease. So the age is the most important risk factor. Additional other vascular risk factor like blood pressure, sugar, and also cortisol level, stress, genetic factor also important, and sedentary lifestyle, and any previous inflammation affecting the brain system. So we go to the question in dementia, which is the most important to be discussed in this lecture. So first of all, once we see case of dementia, we should ask ourselves, this is dementia case or normal aging just? So to compare between these normal aging and dementia, usually for normal aging, the patient unable to remember conversation details or even that took place a year ago. While patient with dementia, the recent one or enabled recent event, or even within a few days, he cannot remember. For patient also normal aging, not able to remember or forget things and event occasionally. While for dementia patient, frequently forgetting things and events. Also, the patient with normal aging difficult in finding word, while the patient with dementia, there is frequent pauses when finding words. Again, what is the difference? For normal aging, slower to think, while dementia cannot think. Slower to do for normal aging, the patient with dementia cannot do like before. Hesitate more for normal aging, while patient with dementia cannot get started. Second question, is it dementia or pseudo-dementia? As we know, pseudo-dementia means most likely this depressive or depression case. So for dementia, usually the history time is not clear, while for pseudo-dementia, usually clear. For slower progression history in dementia, while rapid progression of symptoms in pseudo-dementia. Patient may have refused medical help in case of dementia because he not think he is a dementic patient, while patient with pseudo-dementia due to depression, patient wanting medical help. Also, there is past psychiatric history with patient with depression, while in patient with dementia, they are rare to have past psychiatric dysfunction. Other question, is it dementia or delirium? So delirium is the acute stage of impairment in attention and consciousness, while dementia is a progressive course, need months to years to get the symptoms. So for delirium is acute stage, hours to days, while for dementia, months to years. And the course also fluctuating for delirium, and while for dementia, it is progressive. For the duration, for delirium, hours to weeks, while for dementia, months to years, the history. And for the attention, as we said, impaired in patient with delirium, while for dementia, unless it is a severe one, there is no impairment in attention. Other question, is it dementia or Alzheimer's disease? For dementia, the wide term is the dementia, which means many disease causing dementia, while Alzheimer is one of the causes of dementia. So in the clinic, some patient, they ask you, please, doctor, this is my case, is it, or the relative asking you, is this dementia case or Alzheimer? So the difference is simple. Alzheimer is one of the causes of the dementia. Dementia is the wide term for many, many causes affecting the cognitive function. So again, dementia is not a disease, while Alzheimer is a disease. For the clinical assessment, for starting with the symptoms, for dementia, we have also many symptoms, but in the commonest one is the memory impairment, which affecting the daily life, and also the other symptoms like decrease or poor judgment, or also trouble in understanding visual images, or also a problem in speaking. Then at the end, also the patient started to have some psychiatric symptoms. For the examination, usually starting with general examination for patient with dementia, looking for metabolic condition, looking for underlying malignancy, looking for other related condition like visual or hearing impairment. So to assess for pallor, jaundice, lymphadenopathy, assess for goiter as a cause of hypothyroidism related cognitive impairment, organomegaly, peripheral pulsation to assess for vascularity of the patient, because one of the causes of dementia is the vascular related dementia. For a neurological examination, you should examine the patient full neurological examination, including the cognitive function, which is usually rare to be examined for the patient with non-dementic symptoms, like patient with straightforward stroke or multiple sclerosis. Usually we don't go in details for assessing cognitive function, while patient presented for us with cognitive impairment, so we should assess his cognitive function. In addition, we should assess for focal neurological deficit, or assess for asymmetry in reflexes or tone examination, and assess for primitive reflexes like grasp reflex, glabular reflex, palmomental reflex, which should be not present in patient above 2 years of old. If we see it later on in life, so this means there is a frontal connection pathology, which most likely related to dementia. So these primitive reflexes is important to assess. Also, we should assess for, as we said, for the neuropsychiatric assessment or cognitive function assessment. We have many terms related specifically to certain disease. For example, if we see hallucination more for the cognitive function assessment, this is means temporal lobe epilepsy or dementia with Lewy body. If we see naming problem, this means semantic dementia, one of the types of dementia. If we see problem in apraxia, could be this is MPH, normal pressure hydrocephalus, as a cause of dementia. If we see problem in speech, mainly and language, could be this anomia of Alzheimer's disease, or could be frontotemporal dementia. So accordingly, which we've sign or symptoms seen by the patient, seen from the patient, so we can assess accordingly which condition is more likely to have. Moreover, also we have the types of memory impairment. In general, the human memory have sensory memory. Okay, example for sensory memory, when the patient for example, see animal or smell something. So this is sensory memory less than 1 second. You have short-term memory, which is the working memory, less than 1 minute. We have the long-term memory, which is lifetime, which can be divided into explicit memory and implicit memory. So explicit memory, which is conscious memory, other name declarative memory, which is related to the facts and event in our life, while the implicit memory, which is the unconscious memory or procedural memory, which is related to our skills and tasks done before, which is routinely to be done. No need to get even a few seconds to do these skills or tasks. So we call this is procedural memory. And also for declarative memory, which is we divide it into episodic and semantic for whether it is related to the facts or the event. For cognitive assessment, which is the most important for patients with dementia, we have mainly 2 types of cognitive function assessment. We have mini-mental state examination, and we have Montreal related, or we call it Montreal Cognitive Assessment, MOCA test. So before that, if we want to roughly assess the cognitive function, we have a simple test we call recall test, registration and recall of 3 object names. For example, pen, car, and river. So we ask the patient, we will ask you about these 3 words. After 2-3 minutes, you should give us all these 3 words. So for the patient with memory impairment, he cannot remember one of them. If he can remember, if he can remember only one, or no word he can remember. So this means significant or clear cognitive function derangement or dysfunction. Sorry. For patient who remember 2 of 3, so the next question we ask him to drawing a wall watch. If he can draw and put the number, as for example 10 past 10, and he put put it in normal or true manner, so this means cognitive function normal or roughly normal. So if he remember 1 or no word at all, so we need to assess him more by mini-mental state examination, which is needed full assessment. You take 15 to 20 minutes for assessing the orientation, registration, attention and calculation, and recall and language also. A scoring of 30 points. So patient with normal cognitive assessment between 27 to 30, and patient with mild 25 to 26, and accordingly reaching to the severe less than for other method, Montreal Cognitive Assessment, MOCA, again, we have a score of 30, and we assess for visual, spatial, executive function, naming, memory, attention, language, abstraction, and delayed recall. Again, for this Montreal Cognitive Assessment, we need some picture also for naming, and also we need some numbering for calculation. So at the end, also we have a score of 18 to 26 means mild cognitive impairment, 10 to 17 moderate cognitive impairment. If it is less than 10, severe cognitive impairment. So after the assessment, we should know there is a course for the cognitive dysfunction. Starting, as we said, there is normal aging, maybe patient reaching 90 years, 95 years, and there is no cognitive impairment, just normal aging. And patient with dementia, it is not started straightforward dementia. There is a preclinical time and minimum or mild cognitive impairment. Then we're starting with dementia, which is also subdivided into mild, moderate to severe, and severe. For a preclinical stage or silent phase, the brain changes started, but without measurable symptoms. An individual may notice changes, but not detected by examination. Even for the cognitive function assessment, we see the cognitive function maybe 28 or 29. For starting mild cognitive impairment, there is here the patient started to complete. In addition, we can, by assessing the patient, we can see there is some impaired in one of the cognitive domains, but still this not interfere with the daily living activity. Once the symptoms of cognitive dysfunction affecting the daily living activity, we consider this case as a case of dementia. So in general, for mild cognitive impairment like dementia, we have amnestic type, which is memory related, and non-amnestic type, as we said, may be related to language, may be related to other things, like we called a patient with, for language and, for example, executive function, or there is attention deficit problem, not only related to memory. Question number 5, is it cortical or subcortical dementia? For cortical one, the typical example is Alzheimer's disease. For subcortical one, the typical example is the Parkinson, which is related to basal ganglia related structure. For the mixed one, which is seen in vascular dementia affecting the cortex and the basal ganglia related area. Question number 6, is it dementia alone or plus? When facing patient with dementia in the clinic, you should ask yourself, is it only the signs and symptoms of this patient is only related to dementia or something else with this patient? For example, when we access him, we see Parkinsonian feature. So we consider this case as a Parkinson dementia complex. And one of the typical example we've seen in such patient with cognitive dysfunction and gait impairment, and there is hypertonia in the examination, seen in patient with normal pressure hydrocephalus, which is characterized by 3 clinical features: urinary incontinence, gait apraxia, and cognitive dysfunction. For other things, for dementia alone or plus, if we see patient with motor neuron disease plus dementia, we call this is a frontotemporal dementia, ALS complex, amyotrophic lateral sclerosis complex. Question number 7, which is very important to us and to the patient. Is it a treatable dementia or not? So once we see patient with dementia, one of the most important to investigate for the treatable causes, because sometimes when we treat this treatable causes earlier, you can get full recovery and there is no more cognitive impairment. So one of the commonest causes is the drug-related condition affecting the cognitive function, depression, like for example, for depression, and for metabolic or endocrine causes like hypothyroidism, for any eye or ears decline affecting the cognitive function. As we said, normal pressure hydrocephalus, a tumor or other space occupying lesion, for example, meningioma, or patient with subdural hematoma, which is slowly within a few weeks affecting the cognitive function. Infection also like syphilis, HIV. Also, nutritional deficiency is very common after bariatric surgery. If patient not getting supplement or refusing to take any supplement, we get more cases of thiamine deficiency. For the, as we said, for treatable, or so we call it another name, reversible causes of dementia, like infection, as we said, meningitis, encephalitis, for metabolic B12 or B1, or thyroid disease or uremia, vascular subarachnoid bleed, hypoperfusion. If it is early treated early and no more complication, the patient will get improving. Traumatic, subdural, inflammatory SLE, neoplastic, space occupying lesion, and psychiatric condition which causes pseudodementia. One other important question seeing in the last few years, is it rapidly progressive dementia within days to weeks or 2 weeks to month? This is the history of rapidly progressive dementia. Maximum within months, the patient starting to have deteriorated in his cognitive function. So we have 2 types also divided into prion disease, which is non-treatable, and non-prion disease, which is mostly treatable. And the most important one is autoimmune encephalitis, which is seen in the last few years, many cases. So this is if it is treated early, this is affecting the cognitive function of the patient, and dramatic improvement gradually after starting steroid or IVIG for our patient who presented with rapidly progressive dementia. Some of the cases within a few weeks, deterioration in cognitive function. So the common treatable causes of rapidly progressive dementia, as we said, immune-mediated, which is the limbic encephalitis or autoimmune encephalitis, which could be paraneoplastic or could be idiopathic. Also, we have primary meningitis of the CNS and sarcoid, and malignancy. Also, we have lymphoma, infection, fungal infection, or toxic metabolic, also like Wernicke encephalopathy. For investigation in general for dementia, we have screening investigation for all the patient, like a blood test, including full blood count, renal function, liver function, thyroid function, ESR, B12. And we have also a ECG, brain imaging, CT and MRI, and EEG to rule out subclinical epileptic attack. For additional investigation for selected patient, for example, patient presented with a rapid course with headache, meningism, fever. So here we need to assess for, as we said, autoimmune encephalitis and for vasculitis. For autoimmune, we need to send for a neuronal antibody like NMDA and voltage-gated potassium antibodies, and also for assessing for syphilis serology and TB and other special cultures. Also, you need, as we said, MRI for the whole patient, at least to assess for space-occupying lesion on other structural causes of dementia. For young onset dementia, mainly non-cognitive related, like behavioral changes, we need to assess for also HIV serology, copper study for Wilson disease. And also, if there is family history of early dementia, we need to assess for metabolic and genetic screen like muscle axillary scan and marrow and liver biopsy. And for a sleep disorder, also, we sometimes patient with presented with a sleep disorder with the cognitive decline, we need to assess for a sleep study. Also, for a drug like medication, need to be investigated. Some toxic medication or toxic materials can affect the cognitive function, like chronic exposure to methanol or alcohol consumption, so affecting the cognitive function. For a clinical seizure or prominent fluctuating in cognitive function, need also to do prolonged EEG to rule out epileptic discharge, because sometimes there is no clear convulsion, but there is or we call it non-convulsive type of epilepsy, and also to assess for some cases for autoimmune, which also can be presented with clinical seizure or prominent fluctuation in cognitive function. For also nutritional cases, post-surgery mainly, we suspect poor nutrition, so we send for nutritional screen. Also for psychiatry, we need psychiatric evaluation. If we suspect also additional investigation, if we suspect there is an inflammatory process, we need also to investigate. So for the rapidly progressive dementia, for infectious causes, we need to do viral PCR and culture, bacterial, fungal, and TB. And for autoimmune, as we said, autoantibodies mainly, and paraneoplastic screen. For malignancy, we need sometimes to do pan-CT scan and or PET scan to rule out silent or small size underlying malignancy. For the vascular, also we need to do echocardiogram, carotid ultrasound, cerebral angiography, and also for neuroimaging in dementia. It is like these three examples for patient. For this one, first one, this one, there is dilated ventricles, which is seen in NPH, normal pressure hydrocephalus, causing gait apraxia and urinary incontinence and cognitive dysfunction. For this patient, settled trauma before a few weeks and started to have fluctuating in his cognitive function. So there is subdural hematoma, which is a chronic one. And for this patient presented with an insignificant headache for a few years, then at the end, he started to have, for example, focal epilepsy with cognitive decline, and there is left hemispheric large size frontotemporal meningioma. So this is the important thing. We should do a CT scan at least, or better MRI for any case with cognitive dysfunction or dementia patient. For the management in general, for treatment of dementia, our main focus for enhancing quality of the life for the patient and maximizing functional performance and improve cognition and mood and behavior. We have pharmacological and non-pharmacological treatment. The issue for dementia need also take care or support for the caregiver also, not the patient, because the patient sometimes, especially in moderate to severe cases, even he cannot recognize that there is a problem for him, while the relative complaining and the caregiver also is the complaining one of what to do with this patient. So a non-pharmacological approach, we have modify environment, optimize stimulation, use of consistent routines. We need not to change the room of the patient or any home-related issue, and keep it on his old keep his old memory, not changing, assess and adapt for any aggravating factors like poor sleep or nutritional deficiency, and also behavior management principles and education. Other things for non-pharmacological treatment, for example, as we said, environmental modification like clocks and calendars and to-do list for the patient, and picture of a toilet on the bathroom door, picture of food on the dining door, we should put to the patient to make the life easy for him. And environmental
Dr.
safety.
Omar, you have 5 minutes. That's okay.
Sorry. So in general, the treatment for pharmacological one, we use acetylcholinesterase inhibitors or an MDA receptor antagonist. So for this medication, which affecting the neurotransmitter in the brain, and which made some cases better, or at least to keep stable condition of the patient. Some patient after a few weeks or 2-3 months, there is no improvement at all. We're increasing the dose, we add another antidementic treatment, but at the end, some of the cases, there is no response. So no need to continue more on antidementic treatment. But sometimes the patient started to have symptoms like psychiatric symptoms. So here we start antidepressant or antipsychotic medication. For a classification of dementia, we have more, now we discuss sometimes dementia for a progressive one and non-progressive and reversible. Reversible, we discussed already about the metabolic condition or autoimmune or MPH. For non-progressive one, like a traumatic brain injury or anoxia or vascular. For a progressive one, which is the commonest one due to loss of a neuronal cell, the most common one, Alzheimer's disease, dementia with Lewy body, and vascular dementia and Parkinson dementia complex. So another question, question number 9, it is one or mixed type of dementia, because sometimes we have Alzheimer mixed with dementia with Lewy body or dementia with vascular dementia. So it is important also to recognize this condition as a mixed dementia or only Alzheimer dementia. For the progressive degenerative dementia, the most common type is Alzheimer's disease, representing 60%. The less common one is the vascular one, 20%. And dementia with Lewy body 15%, and frontotemporal dementia 5%. For pathophysiology of degenerative dementia, there is abnormal protein deposition in the brain, whether extracellular, like in prion disease or Alzheimer's disease, amyloid beta protein deposition, or we have intracellular deposition of abnormal protein like alpha-synuclein or tau protein. For the diagnostic tools and degenerative dementia, as we said, MRI, PET scan and SPECT scan, also FDG scan, which is fluorodeoxyglucose scan, and amyloid PET to see for amyloid PET atrophy, and tau PET positive atrophy also for tau protein and amyloid protein. CSF biomarker also tau and for amyloid beta 42 protein. If we have a few minutes for discussing the types of commonest type of degenerative dementia, Alzheimer one is the commonest one. And this is the German psychiatrist who discovered the first case of Alzheimer's disease. And it represents Alzheimer's disease about 60 to 85% of dementia in people aged more than 65. And also represent 45% of the subject aged more than 85 may have Alzheimer's disease. For the pathology or pathophysiology, there is neurofibrillary tangles and neuritic plaque deposition. This is affecting the transmission of impulse inside the brain. So the patient is starting to have decline in his cognitive function. So there is atrophy mainly in the cortex and also in the hippocampus. And at the end, there will be dilated ventricle because there is atrophic changes in the cortex. So the ventricle so it will dilate it more. So hippocampus, atrophy in the cortex, and dilated ventricle. This is the main 3 radiological findings. The symptoms, memory loss mainly, change in mood, social isolation, and misplacing things, and confusion at the end, and sometimes ending with severe dementia. The patient refused to eat, refused to take medication, and urinate on himself, and very difficult to deal with the patient, and develop aggressiveness. And at the end, ending with bedridden stage and maybe nasogastric feeding or gastrostomy feeding. And also for the psychiatric symptoms, the patient we have dementia with Alzheimer maybe have mild symptoms like depression and anxiety, and on the other side they have maybe severe form like aggression and hallucination. Here we can see the finding in Alzheimer and other condition. For the normal one, there is activity of the brain involving all the brain, while Alzheimer, there is decrease in activity, the red area less in the parietal lobe mainly. For frontotemporal dementia, the decrease in frontal and temporal lobe activity. There is mild and moderate severe form of Alzheimer's disease. Management, as we said, anticholinesterase inhibitors like donepezil, Aricept, rivastigmine, galantamine, and the new one, NMDA, we called memantine, acting on an NMDA receptor. For the vascular dementia, the second most common type of degenerative dementia, there is a risk factor, diabetic hypertension, high cholesterol, and also the presentation of the vascular dementia could be related to stroke, a strategic area causing dementia, like thalamus, for example, could be related to multiple lacunar infarction, causing stepwise decrease in cognitive function, could be also due to large size infarction, also causing cognitive dysfunction. Also, and sometimes you have mixed dementia, which is Alzheimer with vascular dementia.
Sorry, Dr. Omar, you're 1 minute over. Can we ask you to just wrap up so we could take some questions? Would that be all right?
Yeah, sure. For the vascular, as we say, this is multiple large vessel infarction. This is bilateral strategic thalamic infarction, and this is Weiswanger disease, which is white matter disease affecting the area related to memory mainly. So Weiswanger disease related to chronic hypertension and diabetes. So this white matter changes significantly to affect the cognitive function. For dementia with Lewy body, it is characterized by visual hallucination and cognitive dysfunction, plus motor dysfunction and Parkinsonian feature and autonomic dysfunction. So this is there is characteristic feature of day-to-day fluctuating, not like Alzheimer's disease progressively, and there is Parkinsonism 85%, and also we have REM sleep disorder and delusion and autonomic dysfunction. So for Lewy body dementia, mainly on the occipital lobe, there is degeneration. And we have Lewy body disease, a term which is characterized, or Lewy body disease family, which is Lewy body dementia and Parkinson disease. Also, there is Lewy body deposition and Parkinson disease dementia. So we have Lewy body, Parkinson disease, and Parkinson disease dementia. For frontotemporal dementia, this is also one of the degenerative one, either frontal lobe degeneration or temporal lobe degeneration, or both. For frontal one, there will be behavioral changes more. For temporal one, there is more memory impairment. And sometimes for the frontal one, it is severe enough during the social activity of the patient, and even his family, they are complaining so much of this abnormal behavior. So need to be assessed by psychiatrists and treated with aggressive psychotherapy, because it is affecting even his family, this behavioral changes. Precipitating factor for any case of dementia, infection, any UTI or chest infection, worsening of the dementic symptoms, electrolyte disturbance, a new vascular event, or medications sometimes related affecting the cognitive function. For example, patient with silent or stable dementia starting to have worsening in the last few days. So we should think there is something new. Not we continue the diagnosis as dementia. We think there is maybe infection, or there is a new vascular event like stroke or medication related. For a prognosis, it depends upon if it is reversible or a treatable one, or it is degenerative one. For a prevention of dementia, can we reduce the risk by be physically active, follow healthy diet, and enjoy social life, and control the vascular risk factor. As in summary, we said history and full examination is important. Dementia or normal aging, you should know from the start. Don't forget the treatable cause, and rapid management and referral if there is cases of rapidly progressive dementia should be sent for a neurologist. Training of the caregiver is needed to prevent complication, and the prevention is always better than the treatment. Question number 10, the last question. Any question if you want to ask? This is the question number 10.
Thank you, Dr. Omar. Thank you for the a comprehensive talk on dementia. I'm sure there'll be questions coming through. Dr. Banerjee, would you like to take the questions and answers, if that's okay?
Thank you very much, Dr. Omar. Very, very nice presentation overall. I think we've got a couple of questions which are on the question answer board. The first one is that any relationship between COVID vaccine and dementia, or even cognitive impairment? What's your opinion on that, Dr. Omar?
We face some cases now in the last few months. They said after taking the vaccine, I start to have memory impairment. But to be sure, when we assess the patient, his cognitive function fully normal. And when we do investigate more by brain MRI, there is nothing in the brain, no atrophic changes, no dilatation in the ventricle. Sometimes it may be related to psychological stress. If they think from the vaccine or from the corona infection, they get some, but directly there is no link till now proved. But we face cases sometimes related to vascular event happen after corona infection. This is reported cases. Sure, there is some more risk of getting stroke, whether ischemic one or bleeding. So this can affect the cognitive function. But otherwise, patient with normal MRI and normal cognitive assessment by mini mental state examination or Montreal assessment. So we don't think so. This is true cognitive dysfunction or pathological. This is maybe psychological related. Because some patients, there is a problem in attention, which is happen after any infection, any stress at family or at work. There is some problem in attention. This is not considered a cognitive dysfunction.
Okay. There's another question regarding how to treat mixed cognitive impairment.
Yeah, if we have mixed type of dementia, we can start, for example, the most common combination is Alzheimer plus vascular dementia. We can start for vascular dementia by decreasing the vascular risk factor, control hypertension, diabetes, hyperlipidemia. And at the same time, we can start antidementic treatment by acetylcholinesterase inhibitors or an NMDA receptor antagonist medication. And we see the response within a few weeks, up to 2 to 3 months. If there is no response, we can do combination therapy. If there is no response, this means this case is beyond the treatment with antidementic treatment.
Okay, that's wonderful. Yeah, Dr. Patel has his hand up, so a question from him.
Thank you, Dr. Omar. Very comprehensive talk. I enjoyed that. So clearly, cognitive impairment is going to become more common, as you were saying. It's a big problem going forward as people are living longer. Are there any tests that we can give our patients, our friends, our loved ones to have a self-assessment of cognitive function?
Thank you for this nice question. One simple question is the recall, registration and recall. As we said, I give three words in the lecture. If the listener to the lecture, if they can remember these 3 words, means it is good function, a good cognitive function. But the problem, you should tell the listener that I will ask you about these 3 words after 3 or 5 minutes. Not giving these 3 words and finish. No, you should tell him, I will ask you about these 3 words. Please, can you repeat it after me now? If he repeated the 3 words, this means the registration normal. And the recall after 3 to 5 minutes, you ask him, what is these 3 words? This is a rough assessment of cognitive function. If he can remember 3 words, this means he is good cognitive function.
What about, can I ask you just to press you a bit more on that? What about higher cognitive function apart from recall? Are there any simple tests that we can ask patients to conduct with their families or their loved ones?
Yes, one also important question about if the patient educated about subtraction, -7, for example, if it's not fully low level of education, -2 or -3 from 20, 20 -3, 17, 17 -3, 14, yes. Like this is subtraction also important.
Thank you, thank you.
Just doctor, I have a Kahoot MCQ 10 question. If they want the listener to start with Kahoot, I have 10 questions. If there is time,
I think we are shortage of time.
4 minutes it takes.
It sounds a wonderful idea, but I think we're just a bit short on time. Yes.
Yeah.
Yeah, Dr. Omar, it will be nice, but maybe we are short of time. Is it possible to postpone it next time?
Yeah, no problem. No problem.
Okay.
I think Dr. Omar can, if he is happy, he can share the slide with us, and that can be sent to the attendees by email.
Yes, sure. We can manage this.
I think that probably would be the most time sort of sensitive way of.
Okay. You can share it with us, Dr. Omar, and then we will share it with all delegates.
Yeah. Okay. But this is Kahoot need time to start for number and. This is MCQ, just I don't know how to. It cannot be shared like this. It should be by, yeah.
Because we are
Direct
out
answering.
of time. We can postpone it for next.
Okay.
I'm going to ask you one last question. One
Yes.
final question, a quick answer, if that's okay, Dr. Omar. How do you
Yeah.
treat mild cognitive impairment? What's your approach?
For mild cognitive impairment, as we said, first of all, we should rule out treatable causes, even if it is mild, whether B12 deficiency, whether thiamine deficiency, whether thyroid dysfunction, whether there is autoimmune process. Once we consider the treatable causes is out, so now we deal with patient with degenerative process, mainly Alzheimer-related condition. We call it mild cognitive impairment. At time being, they said if starting early for mild cognitive impairment with antidementic treatment, acetylcholinesterase inhibitors, some cases this will stop the progression of from mild cognitive impairment to become a case of dementia. So early treatment with antidementic treatment is some cases helpful to stop the progression of the disease.
Wonderful. Well, thank you again, Dr. Omar, for a comprehensive talk on dementia. It's a really important topic. Very important topic.
For all.
So let's move on. Thank you. Next, we've got delighted to introduce a friend and a colleague, Dr. Mulinath Banerjee, who's a consultant physician in diabetes endocrinology in Bolton. He's also works in general medicine and divisional research lead. He's an honorary clinical lecturer in endocrinology and diabetes at the University of Manchester, where he received his PhD. He's led a number of projects, including quality improvement, has published in a number of peer-reviewed articles in journals. He's also an associate editor of the British Journal of Diabetes, a journal very close to my heart, and a clinical champion of diabetes. So thank you very much for joining us. Dr. Mulinath is going to be telling us about COVID-19, diabetes, pregnancies, vaccines, everything you need to know. Okay, over to you, Dr. Banerjee. I'm really looking forward to this.
We are sharing Dr. Banerjee's recorded session, or you want live, Doctor?
I'm happy with the recording. That's fine, not a problem.
Thank you, Dr. Yaman.
Good evening, everybody. My topic of the talk today is COVID, diabetes, pregnancy. Good evening, everybody. My topic of the talk today is COVID, diabetes, pregnancy, and vaccination. Quite wide-ranging, but overall, let's see how much we can cover in the next 20-25 minutes. Good evening. These are my disclosures. So my topic broadly is between diabetes, pregnancy, and vaccination surrounding the COVID-19 infection situation. Let's go through a very short case. Let's go back by about a year. January last year, 29-year-old Caucasian lady who was known to have type 2 diabetes for the last 3 years. She was booked at the antenatal diabetes clinic at 6 weeks of gestation. At booking visit, her HbA1c was 8.6% or 71 millimoles per mole, and body mass index was 34 kgs per meter square. She did not attend the preconception service, and at the time of attending our clinic, she was on treatment with metformin 1 gram twice a day and allogliptin 25 milligrams once a day. She was up to date with her retinal and foot screening, but was not with the nephropathy screening. She did not check her blood glucose at home, which is quite expected for somebody who's taking oral hypoglycemics and who is not pregnant. So once she attended, her allogliptin was stopped. Self-monitoring of blood glucose and folic acid 5 milligrams once a day was initiated. Antenatal scans, clinic appointments, and telephone appointments were all booked in. Following her initial visit, her blood glucose profile suggested she needed
further optimization of a therapy, and hence metformin dose was increased to a maximum of 2.5 grams a day, and subsequently insulin was introduced in a basal-bolus regimen, and her glucose levels were optimized. In uneven full antenatal progress, blood glucose levels were very well controlled and all within the current target. But at 35 weeks of pregnancy, she developed symptoms of COVID-19. Since about 10 days since starting her symptoms, she noticed reduced fetal movement and attended the emergency obstetric triage unit, where she was assessed, and she underwent emergency lower segment cesarean section for fetal distress. The baby was born at 3.45 kilograms and needed special care baby unit support for 16 days and was discharged home after that. Both mom and baby are doing well since then. Now let's come to the situation of COVID-19. It's not novel anymore. It's almost 2 years that the WHO declared it as a public health emergency of international concern. That was on the 30th of January 2020, and it declared as a pandemic on the 11th of March 2020. The total number of patients infected by COVID-19 worldwide is 421,155,794, and that's correct till yesterday. And the total number of deaths worldwide was almost touching 6 million now. Looking at the risk factors which increases the risk for developing COVID and also the outcome can be broadly divided into behavioral, which is hand washing, social distancing and mask wearing, general health comorbidities as obesity, hypertension and diabetes, demographic, occupational exposure, which vast majority of us attending this conference are, access to healthcare, ethnic inequality and education, and some biological measures as well. Coming back to the topic of mine, let's focus on diabetes and COVID-19 infection here. The risk of contracting COVID-19 infection is the same as the general population. It does not increase the risk at all. And the vast majority of patients with diabetes will have a very mild illness and would not need a hospital management. But what we have seen is a few factors which increases the risk of hospitalization in patients with diabetes and COVID infection. High hemoglobin A1C, increasing age, non-Caucasian ethnicity, rising body mass index or adiposity, and any diabetes-related complications. These all increase the risk of hospitalization in patients with diabetes. Now, why does it happen? Now, what we've seen is that the COVID-19 can have a big impact on the beta cells. And we can divide those impacts into three different areas or three different modes. One is a direct infection of the beta cells by the COVID virus. There could be indirect impact on the beta cells, and there could be systemic reasons. When we talk about the direct impact, we're talking about beta cells being infected by the COVID virus, and it could be because of direct acute injury or a persistent infection. Now, this is because the beta cells express the ACE2 receptors and hence are susceptible. Now, if we talk about the indirect impact of the COVID virus, it could be because of the ductal cells being affected, the endothelial cells supplying the pancreas and the islets, they are being affected, and the pericytes being affected. These all have an indirect influence on the beta cells and reduces the viability of the beta cells within the pancreas. The systemic influences could be secondary to involvement of the liver, of the adipose tissue, and kidneys. They lead to endocrine effects and lead to pro-diabetogenic metabolites, which are systemic in origin. That diabetogenic milieu leads to some paracrine effects and affects the beta cell function. In overall, if we look at all these three different ways by which the beta cells can be affected, we can summarize as beta cell inflammation, beta cell autoimmunity, beta cell dysfunction, and ultimately death of the beta cells, all of them leading to reduction in insulin availability for patients with diabetes or at risk of diabetes. Now, during the COVID infection pandemic situation, what we have seen is that quite a few patients who have been admitted with diabetic ketoacidosis, that is driven by an systemic infection, but also because of the beta cell dysfunction that we have been seeing. Now, this was an article published from the UK, and I believe the chairperson is going to discuss about our experience, and he definitely is going to look into this article from Lancet Diabetes and Endocrine. But I'll just briefly touch on that, is that it showed that patients with type 1 diabetes were at a higher risk of mortality than type 2, but both of them were much higher at risk from patients who did not have any form of diabetes. Now, let's focus on very briefly on diabetes and pregnancy. The perinatal mortality in patients when women who have diabetes in pregnancy is about 4% when compared to non-diabetic pregnancies, which is about less than 1%. There's 2 to 4-fold risk of congenital malformation, and it rises as the A1C rises at the time of conception. The fetus can be affected as a small for gestational age or large for gestational age, and the risks of the mother is because of worsening of vascular complications, iatrogenic risk of intensive glucose control, and they also have a higher risk of hypertension during pregnancy. When we then come to COVID-19 infection and pregnancy, now what we can see with the CDC guidance is that the pregnancy or recent pregnancy increases the risk to get severely ill from COVID-19 when compared to people who are not pregnant. And the risk factors which actually predisposes to this is having certain underlying medical conditions, which include diabetes, being older than 25 years, living or working in a community with a high number of COVID-19 cases, living or working in a community with low level of COVID-19 vaccination, and thereby the overall incident risk of infection is higher, working in places where it is difficult or not possible to keep at least 6 feet apart from people who might be sick, and being part of some racial and ethnic minority groups. They can also have a higher risk of developing in the preterm and also risk of stillbirth, and might be more likely to have pregnancy complications than with patients without COVID-19 infection in pregnancy. The Royal College of Obstetricians and Gynecologists have also given a similar guidance, and they suggest that it is unlikely to cause problems with the baby's development. So the congenital malformation and the overall growth of the baby is not affected. There is also no evidence to suggest that infection leads to early pregnancy, increased risk of miscarriage, or loss of fetal life. The transmission of COVID-19 from a woman to her baby during pregnancy or childbirth, which is also defined as the vertical transmission, is very, very unlikely. And whether or not a newborn baby gets COVID-19 infection is not affected by the mode of birth, feeding choice, or whether the mom or baby stay together. It's also interesting that if the baby develops COVID-19 infection very soon after birth, they have really remained well and didn't have much of problems. Now, most of these guidances are based on these 3 articles that have come out. One, and the UK Obstetric Surveillance System report that is updated regularly. Now, when we come to the combination with diabetes, pregnancy, and COVID-19 infection, let's have a look regarding why this is more of a concern. Now, what we know is that the COVID infection, the cause, the risk factor, and the severity of the cause has led to the pandemic. Now, that has led to lockdown. But again, having diabetes, the risk factors, the lifestyles, the pro-inflammatory state, the tissue hypoxia because of microvascular complications, that can actually predispose to the COVID infection. Now, due to lockdown, the activities have gone down, and hence that predisposes to a much severe infection as well, because our overall body mass index, the activity levels are all lower. Now, both these two can combine together, and they can have some common roots, and they lead to hypoxia, pro-inflammatory state, high risk for developing preeclampsia, fetal and tissue hypoxia, and hence it can affect diabetes in pregnancy. Let's come to the topic of COVID-19 vaccination. There are broadly three different types of vaccines that's available. We're not talking about the routes, it's just about the type of vaccine that we have. One is the mRNA vaccine, the other is the viral vector, and the third is the protein subunit vaccines. Now let's come to the mRNA vaccine. Here we have the mRNA of the spike proteins, which is developed in the lab and is taken up as a vaccine and is injected to the individuals. The mRNA enters the cell, and that induces the human tissue to produce more of the spike protein of the COVID-19 virus. When these spike proteins are exposed to the body's immune system, it produces the antibodies, and hence the antibodies against the spike protein provides the immunity against the COVID infection when it happens subsequently. The viral vectors work in a slightly different way, where we have got the virus, and the genetic material of the virus for the spike protein is induced into a harmless or inactive virus. This then is the active virus, but it's harmless and is infected. The harmless virus enters the cell, enters the human cell, and it replicates the protein that is being produced because of the mRNA that's there. And again, there's an increase in the spike protein that are being produced and leads to the development of the antibodies and thereby the immunity. The protein subunit actually is an inactivated viral vaccine, and it causes either the spike protein or the viral body protein to be there. The proteins are then removed, and the material inserted into a bacteria or yeast cell, and these proteins are then purified, and the spike protein themselves, not the virus themselves, they are actually then injected, which causes the induction of the immunity, induction of the antibody formation, and the induction of the immunity thereby. Now, currently, there are 34 different types of vaccines that are available in the world. In the Kingdom of Bahrain, there are four vaccines which are available. One is from AstraZeneca, which is a vector vaccine. The Pfizer is the mRNA vaccine. The Sinopharm is a protein subunit vaccine. And Sputnik 5, which is a vector vaccine which uses human adenovirus. The efficacy roughly is between 76% to 95% across the whole spectrum of the vaccines that are available here. There's some concerns about some of the vaccines. The AstraZeneca has been reported to have very unusual blood clots and some capillary leak syndromes. Pfizer has been associated with mild self-resolving myocarditis in the teens and very young adults, and mainly men. Sinopharm and Sputnik, they have nothing declared as concerns regarding their usage. I won't be going into the details of the restrictions that are there when used locally. Let's visit some of the myths and realities about the COVID vaccines. The COVID vaccine can give you COVID-19 infection. That's untrue, because none of the vaccines that we use have any live virulent virus. The vaccines change your DNA. That's untrue as well, because either the mRNA vaccine increases the body's production of the spike protein, or the others present spike protein to our immune system. And none of them actually interfere with our DNA structure. The vaccines contain controversial components. They don't, because there are only permitted additives which are needed to stabilize the mRNA or the proteins that evoke the immune response that are added when preparing the vaccines. The side effects are dangerous. Not really. There are some serious side effects which we know, but vast majority of the individuals, when they receive any of the vaccines, they don't have any or very mild local or general reactions. Very, very rarely there can be side effects like myocarditis. It is estimated about 1 to 6 per million. Acute transverse myelitis, there have been 47 cases reported in the literature till now. And venous thromboembolism, there's no increased risk with the vaccines, and that was according to a meta-analysis published in Thrombosis Journal very recently. Though what we very well know is that the risk of thromboembolism from COVID-19 infection is very high. There's also concerns regarding reproductive health. In men, there is no evidence that the vaccines affect it. On the contrary, after a moderate to severe COVID infection, the sperm quality declines, and that can last up to 1 to 2 months. This is linked with the ACE2 receptors in the testicular cells, which peaks around 30 years of age. In women, there hasn't been any effect apart from the slightly delayed menstrual cycle or prolonged menstrual cycle. Now, if a lady has a single dose of a COVID vaccine during a single menstrual cycle, it roughly increases the cycle length by about a day. If they receive 2 vaccine doses in the same menstrual cycle, then that increases the cycle length by an average of around 2 days. But these changes, they are thought to be temporary and they don't cause any problems. Vaccine is not needed if you already had an infection. That's not true either. Because if you had COVID-19 before and you're not vaccinated, the risk of you getting reinfected is twice when compared to people who have been vaccinated. The other thing which comes up more and more is that it has been a very rushed process and the product cannot be trusted. Now, all the vaccines that we currently have in the world, they are all based on the trusted processes. Now, over the years, there's a lot of development of science and technology, and that has actually reduced the time between the bench and the use of these vaccines in the clinic. And hence, I think we should have a lot of respect for all the people who have developed the vaccines and run the clinical trials and made them available to us to be used in a clinical setting. And what are the challenges in that respect? Now, the concerns that have been expressed by the patients with diabetes about COVID vaccinations are as follows. Vaccines will cause blood glucose levels to go haywire. Now, that is slightly true. The vaccine is given and that induces a mild inflammatory response. There may be some effect on the blood glucose levels because of the overall inflammatory state, the stressful state that the patient is going through. And hence we always advise that if they have been unwell, they should follow the sick day rules. The next concern is vaccine efficacy wanes with time and hence it's no use taking them. It does wane, the effect, but with the booster doses, the efficacy is regained. The other thing is that taking it with other vaccines as influenza vaccine can be harmful. There's no evidence for it so far, and in some countries it's licensed to be co-administered. Actually in UK we have been giving it, and in fact I had it, one in each arm when I had my booster. Patients with diabetes may not have similar protection following vaccination, and that is probably true because in the study that was done with the Pfizer's vaccine, both patients with type 2 diabetes and individuals without diabetes, they had elicited a strong immune response. But the level of the antibodies seen in patients with type 2 diabetes were lower than patients without diabetes. But they still had a good response, and hopefully that actually protected them from further COVID infections as well. Let's now come to the quite controversial topic and quite contentious topic about pregnancy and COVID-19 vaccination. The second article published in NEJM last year showed that if the women received the vaccination within 3 weeks, there was no increased odds of the fetal loss, but if they received it in the previous 5 weeks, there was some protective effect of the vaccine and the odds were actually lower of fetal loss. Now, the third one was published in JAMA, where 105,000 unique pregnancies, there were 13,000 spontaneous fetal losses, early fetal losses, and the exposure to Pfizer, Moderna, or Janssen vaccine that was evaluated in this study, the preceding 28 days did not increase the risk of fetal loss at all, and the overall adjusted fetal loss ratio was 1.02. Hence, what we can say is that the risk of COVID vaccination leading to early pregnancy fetal loss is very, very low. Now, what about the pregnancy outcome if the pregnancy continues? There are 3 studies as well on that one. The first one about 4,400 women. 913 were vaccinated during the last 2 trimesters of pregnancy, and there was no difference in the outcome in the groups of pregnancy in considering with delivery, newborn complications, including gestational age at delivery, incidence small for gestational age, and newborn respiratory complications. In the second study, there were 712 women who received 2 doses of the Pfizer vaccine versus 1,063 unvaccinated women. There was no association with maternal composite adverse outcome, but a significant reduction in the risk of neonatal composite adverse outcomes. The third one was a retrospective study of around more than 40,000 pregnant women, and the pregnancy was not associated with any preterm birth or small for gestational age at birth overall when compared to unvaccinated pregnant women. Hence, what we can say is that there is no adverse effect of the vaccines on the pregnancy outcome, and there may be a possible benefit with the neonatal outcomes in this group of women. Now, the overall consensus regarding pregnancy and vaccination is there's no concern about vaccination in pregnancy and lactation, but there may be, and the benefits of vaccination actually outweighs the risk. So the WHO standing, the CDC comes up saying that COVID vaccination is recommended for people who are pregnant, breastfeeding, trying to get pregnant now, or might become pregnant in the future. And the Royal College of Obs and Gynae, they suggest that the COVID vaccination is strongly recommended at any stage of pregnancy. Receiving 2 doses of vaccine and the booster dose is the safest and most effective way of protecting the pregnant woman and her baby from COVID-19 infections. What do you think that we could have done differently in January 2022 for a lady if she got pregnant again and had type 2 diabetes and developed COVID infection? The vaccination. And that is being offered to all pregnant women currently in the UK. I hope the cloud of COVID is passing through and we are going to get the sunshine through very soon. Thank you very much for all your kind attention.
Thank you, Dr. Banerjee. That's a very clear and well-timed presentation. I think we're going to, as my talk covers the sort of COVID and diabetes arena also, we could probably take questions at the end if that's all right.
Yeah, that's fine with me. I think we can sort of cover. So shall I introduce Dr. Patel to the audience? So it's my absolute pleasure to introduce Dr. Dipesh Patel, who is a consultant physician and in diabetes and endocrine, and honorary associate professor at University College of London and Royal Free Hospitals in London. He's also the chair of Association of British Clinical Diabetologists and has multiple publications. So, Dr. Patel, are you doing it live or are you doing it via recording?
I shall be doing it live. Thank you, Dr. Banerjee. Thank you very much.
Over to you then.
Thank you. I assume you can hear me okay. I will put my slides on. Hopefully you should be able to see my slides.
Yes, doctor, we can see.
Thank you, Dr. Iman. Okay, so again, thank you again for the organizers. This is the last talk of the this IMDO 5. I'm privileged to give this talk about lessons learned. We have all been through, as Dr. Banerjee has told us, the cloud of virus of COVID-19 for the past almost 2 years now. And I just want to give you some thoughts about COVID-19 and the effect on diabetes individuals, but also services with diabetes, and share some of the lessons that we've learned in the UK. So we all have experienced changing roles as a physician, as a doctor. Certainly I, between March and May 2020, was a full-time COVID doctor doing rounds on COVID wards. I did no outpatient work whatsoever in the NHS organization. So clearly we've had a lot of deployment, we've had different skill sets, and we've all put on PPE and looked after our patients as best we could, but also looked after our teams, our junior doctors. And in many cases, clinical staff remained redeployed in acute areas That's partly because of COVID-19, but also in the UK, partly due to the rise in demand for acute care in other aspects, because routine care for chronic conditions had not been, or had been significantly disrupted by the viral pandemic. So that's still an ongoing challenge, certainly in acute medicine, not only a demand for healthcare, but illness in our staff, either viral illnesses or non-viral illnesses in our staff, requiring self-isolation, and obviously members of our families, including young children, being suffering from COVID-19, and therefore the need for self-isolation. So that's had a major effect on staffing and continues to do so. Certainly, I'm sure that's not just limited to the UK, that's probably all around the world. And we're also seeing that in other aspects of industry, not just in healthcare. But also at the bottom here, we told our patients to stay at home. We told them not to come to our clinics and our outpatient elective services. We told them to stay at home, and we thought we could adequately manage them at home in a different way. But I think we've learned a lot of lessons from that. We've also learned that physical space and social distancing, both socially, but also in the healthcare setting, is really important. And we've had to reorganize how we look at our hospitals, how we look at our clinics, how we look at each other. We can no longer, unfortunately, have meetings with one another. By testament, this is why we're having an online meeting this year. We've had to reorganize the way we do things, both in clinical medicine, in our meetings, in our MDTs, and our conferences. And this is obviously testament to where we are now. So it's had a huge effect, and it continues to have an effect on our patients with diabetes, but also the whole healthcare sector as a whole. And one of the real costs are loss of colleagues, a loss of friends, a loss of loved ones. Dr. Richard Quinton showed this slide, and I asked him to share it with me, to show it again, that remembering that actually colleagues, physician colleagues and other healthcare professionals have lost their lives in duty to look after patients. And Dr. Richard Quinton eloquently pointed out that one of the doctors who worked at my local hospital, Dr. Alpha Sadhu in Watford, came out of retirement to give service, and unfortunately it cost him his life. And he also pointed out that out of all these doctors, only 2 were Caucasian. Okay, so clearly there was a predominance of effect in ethnic minorities. He also pointed out that the minority of people losing their lives from the healthcare professional sector were women. So clearly males had a preponderance for severe disease and unfortunately death. And I don't think we still understand why that might be. So again, a really salutary, sober lesson that we've all learned the hard way. So I'm going to show you some data in individuals from the UK. You may have seen some of these data before, and I'm pleased that Dr. Mulinov touched upon this in his talk, so I won't have to spend too much time going through this. But it was generally looking at mortality in England in people with type 1 and type 2 diabetes. Just to put this in context, this observation was over a 72-day period where there were 23,000 deaths observed. So that's a lot. And out of these deaths from England, 33%, so 1/3 of all deaths had a history. It were in people with a history of diabetes. And that was no coincidence. I think we've got some background noise here. That was no coincidence. On further analysis, we looked at type 2 diabetes, and we showed, or the co-authors demonstrated, there was an odds ratio of 2.03. So people with type 2 diabetes were twice as likely to die of COVID-19 illness, and people with type 1 diabetes, although the death rates were lower, at 1.5% of the deaths, they were 3.5 times more likely to die. And as you can see from the graph here, clearly is age on the x-axis and rate of mortality per 100,000 over 72 days on the y-axis. And you can see black is the general population, which is quite low and starts escalating after the age of 70. blue are those with type 2 diabetes. Again, you've seen a rise after the age of 70, and red with type 1 diabetes, even a higher risk. So clearly age was the main determinant of death, but people with type 2 diabetes and type 1 diabetes were at higher risk of dying. And this was published in mid-2020. From these data sets, we also showed, was demonstrated that men had almost twice as likely to die of COVID-19 compared to women. And those from the most deprived backgrounds also had almost a twofold increase in death from COVID-19. There's lots of controversy of why that might be. Was it because these people from deprived backgrounds were in terms of public-facing roles, either they were on public transport or healthcare or otherwise, or was there something else about deprivation that increased their risk of dying? So as I said, age was the main determinant of death, and the top graph can show you this compared to an age of 60 to 69 years. If you're between 70 and 79, you had over 2.6-fold increase of dying, and if you're over the age of 80, you had a 9-fold risk of dying. So clearly, age was a major predisposition to death. We know those with cardiovascular disease had a higher rate of dying. It accounted for almost a third of people dying overall. And there were interestingly regional variations in death, where the majority of the deaths occurred in London, the West Midlands, and the Northwest. And that was probably due to the spread of the virus more than anything else. As I said, people from Black and minority ethnic backgrounds had a higher risk of dying. And this shows you the individual components. So we can see compared to white Caucasians, where the risk was a baseline at 1, those of Asian backgrounds had a 35% excess risk. Those of Black backgrounds, 71% excess risk. So clear data here, and these were otherwise standardized in terms of mortality. And deprivation, you can see the different quintiles of deprivation, clear line, a dose dependency. The more deprived the background, the higher risk of death, which is worrying for us and our patients. Particularly the second paper that came from NHS England, from this fantastic work where we linked up hospital deaths, community deaths, and NHS records. So this is arguably cannot be done in many countries. And we were lucky enough to be able to do it in England via the NHS England group. We saw, as Dr. Banerjee had mentioned, in terms of people with type 2 diabetes, the higher the HbA1c, the higher the risk of death compared to a reference HbA1c of between 49 and 53. That's up to 7% in old money. And you can see if your HbA1c was above 86 millimoles per mole, you had a 62% increase. And you can see there was a dose dependency, i.e. the higher HbA1c, the higher the risk of death. The one thing that really came out of COVID-19, not just this data sets, but multiple data sets from Italy, from New York, from UK and other areas, is increased risk of death from obesity. So this has really shone a light on trying to get to grips with this major epidemic in the world, obesity. And we could see clearly on our intensive care units, there are many more people who are obese. And there are a number of theories in terms of hyperinflammation, decreased cardiorespiratory reserve, of why people with obesity are at excess risk of dying. In people with type 2 diabetes, a fall in kidney function was also a risk factor. And again, there was a stratified risk. The lower your eGFR in mils per minute, the higher the risk of death. Intriguingly, smoking did not show an increased risk of death. Paradoxically, there was a slightly lower risk of death, and we don't really fully understand that from this data set. So questions arising from this data set really were initially lots of people, there was lots of speculation, worry, concern about whether some of the medicines we use in people routinely with type 2 diabetes, such as RAS inhibitors, ACE inhibitors, and A2RAs or statins, did they have an adverse effect? And we went through a lot of non-evidence-based practice. People were stopping medications, and we now know that is not true. They did not have an adverse effect on individuals. Do we think that certain diabetes medications affected outcomes? I think that's largely unknown. There are still publications coming out to debate this, and I think we still really don't know a definitive answer. But the real question really for me and others is that if we look after our patients better, if we ask them, if we help them achieve better glycemic and weight targets, would we risk any future risk of severe disease or death from the next viral pandemic? Because we're aware that this is not going to be the last viral pandemic, the way viruses work. There is going to be a future one at some stage. And the question is, can we protect our patients better? And I guess we don't know. The proof of concept is we think it may be beneficial, but we don't know. It's not been proven. In London, we had lots of presentations, as you probably did locally in your practice, of severe presentations, lots of ketoacidosis, hyperosmolality, and mixed pictures we saw, high rates of kidney injury, so lots of acuity, disproportionate level of ketosis in people without type 1 diabetes, and in some cases we're just with type 2 diabetes on just lifestyle management. And we know ketosis in some people occurred rapidly, which makes us think about how did the virus and the illness affect the beta cell transiently? And I'll come on to talk about that. We saw in our critical care areas, there was some extreme insulin resistance. We don't see this very commonly. We see this every few years, but we were seeing this routinely. People requiring intravenous insulin at rates of 10, 15 units per hour. So severe insulin resistance. We saw hyperglycemia was associated with more severe disease. And we saw very high rates of inflammatory markers. And again, we came together in terms of societies to come together to come up with some guidance for our colleagues, both locally and regionally, in terms of how to manage these patients well and keeping patients safe. The first thing I guess we found out quite early on in this sort of presentation was that we needed to measure capillary glucose and ketones in anyone who came in unwell with COVID-19, whether they had a background of diabetes or not. So based on some of the mortality data, a number of societies in the UK came together, the Association of British Clinical Diabetologists, a Primary Care Diabetes Society, Diabetes UK representing patients, which is really important, and a group called Get It Right First Time. We all came together and we came up with a sort of policy that was published both in the British Journal of Diabetes and Diabetic Medicine that showed that actually the people we needed to be seeing and managing were the people at the highest risk of death. And we can show you the stratification there. And that, no surprise, these were the people at highest risk of severe illness from COVID-19. We've included there recent cardiovascular admission, acute foot disease and pregnancy, because these patients needed to be seen face-to-face to avoid poor outcomes. Again, we published this in an article, which was really a mixture of people involved in diabetes. We had an expert patient, we had a GP, we had specialist colleagues, we had specialist nurses on this publication. It's a really testament to the multidisciplinary role of clinicians in managing our patients. We can't do it alone as physicians. And what did we find? What were our conclusions? Well, in the UK, we needed better integrated IT systems to triage patients. If we need to capture patients with the highest A1C, the lowest kidney function, the highest BMI, we need that information communicated electronically. We need to use this information to avoid duplication, where the GP surgery intervenes with healthcare and then the specialist does the same, and that's inefficient, and that's a way we should not be practicing. So there's this mantra in the UK that we use again and again: we need to see the right patient at the right time in the right place. And again, without proper integrated care, so GPs talking to specialists, GP surgeries talking to hospitals, and hospitals talking to one another, this is not achievable. And we needed a needs-based follow-up. It's based on your needs of becoming unwell and developing an adverse outcome from COVID-19, not routine follow-up. So again, that's the legacy here. We no longer have routine follow-up. It's all based on needs, and that's based on risk. And we also determined how many patients can be seen face-to-face versus virtual, and we're all still doing a lot of virtual consultations, which I think is proven to be very beneficial. However, there are in lots of cases, virtual follow-up or virtual consultations don't work well. I was really pleased where I work in North Central London that this was adopted in North Central London, this sort of triaging based on the NHS England data sets. North Central London across all GP surgeries across North Central London adopted this into high risk, medium risk and low risk. I'm not going to read out the individual components of that. That's not that important. But again, it's based on the NHS England data set and some of our recommendations from specialist bodies. So again, our healthcare providers and payers were listening and put this policy into place relatively quickly, which I was pleased to see. And then again, NHS London looked at trying to further risk stratify who needs to be seen urgently face-to-face, who needs to be seen virtually, and who you can safely defer appointments to. So what does a roadmap to recovery look like? Well, we told you data is so important. Data and risk stratification are the pillars of best care going forward. We need closer liaison. We've learned primary and specialist care. When we're all becoming COVID doctors, the GPs unfortunately did not feel well supported looking after patients. There were hundreds and maybe even thousands of patients being discharged on insulin rapidly from hospitals, going back to primary care. And these clinicians unfortunately had to pick up the management in these cases. They unfortunately did not have the right support in many instances to do that, but we've learned from that. We know that social distancing is very important to minimize risk for our patients. For many months afterwards, many of our patients felt uncomfortable coming to acute care settings for a blood test, for some imaging, to see the specialist. We can understand that. So the NHS England's, I guess, future plan now is to develop, and this is quite new, diagnostic hubs in the community. So diagnostic hubs in the community are being rolled out initially in a pilot phase, but I can quite easily see this in England happening on a widespread basis. So diagnostic hubs, not in the hospital, not in GP surgeries, but outside in the community. And remember, through all these metrics that I've shown you with diabetes, care needs to be holistic. There is lots of mental health burden that came on because of this isolation and virus and fear. We need to talk to our patients and reassure them, just as you heard Dr. Banerjee tell you some of the myths about vaccination, some of the myths about COVID-19. There's lots of misinformation out there, which is really harmful. We need our patients to trust us, and we need to trust our patients will make the right decisions for themselves. So a holistic approach, including mental health, I think is key for patient care. I was really pleased and proud to be working in the NHS in England during this time where bodies like NHS England, primary care, specialist care and patient care came together and came out with guidance that we were all using together, and that was agreed to be used in a number of sectors. I won't reiterate some of this, but IT is so important. Now practices are routinely picking up those people with high A1C, low EGFR, high risk of cardiovascular disease. And we're having these sort of virtual case discussions to discuss some of the most complex patients virtually and to put a management plan in for them. We're all doing non-face-to-face consultations by video, email, text. We're using technology in a very versatile fashion. I think hopefully this is here to stay. If you take nothing away from my presentation apart from this slide, I'd be very pleased. Please do go to the ABCD website at www.abcd.care. It's a free website for information. Over the pandemic, we had a massive rise in website traffic. We had thousands and thousands of hits, thousands of followers. And this is because hopefully we had some useful information to filter out to other people who were facing the same challenges we were facing in the UK. One of the three main, I think, areas that may be of interest to you are our ABCD webinars, which occur every month and are free to register on, and that tells you in a variety of topics within diabetes and multidisciplinary topics, not just for consultant physicians. Our COVID-19 guidance, hopefully you won't need that going forward. But also our technology network. This is a modular approach. You can have your own modules in terms of improving your expertise and experience in technology working. I won't go through this, but I just want to acknowledge Professor Jerry Raymond and his team, who put together a lot of this guidance with COVID-19, both at the front door, managing DKA in different ways, not just with intravenous insulin, and managing patients with dexamethasone and inpatient hyperglycemia. You will all know dexamethasone was a relief when we found out it made a difference in moderate and severe disease, and that clearly we needed a guideline to help manage hyperglycemia. And this group really were very agile and worked very quickly to come up with this guidance, which we're still using now. I won't go through local networks. I just wanted to mention Dr. Rustam Ray, who still continues to lead the ABCD COVID-19 National Diabetes Audit. So this work is ongoing. We haven't stopped working. These group of clinicians have been meeting weekly at 8 o'clock in the morning since June 2010. Now this work has exploded. Okay, our learning of diabetes and COVID-19, we now have partnerships with France, Spain, and the US in terms of new learning in people with diabetes. There have been at least a couple of papers published. There are 5 manuscripts in preparation. I'm really proud of this group and this work that we've achieved in trying to share some of the learning using our national data sets. Lastly, I just want to touch upon the future. There was a suggestion that clearly if COVID-19 causes ketoacidosis, there may be a temporary insult to the beta cell. And we know there has been evidence from previous pandemics, from SARS-CoV-1, causing transient diabetes. So there is a theory that that can happen. And we know that the beta cells also express the ACE2 receptor, which is a binding site for both SARS-CoV-1 and 2 viruses. But data in children from Northwest London also suggested that actually beta cells were being affected. In 5 big units in Northwest London, they had over a short period of time between end of March and June 2020, they had 13 new cases of type 1 diabetes. And over a year-on-year average, that was an 80% increase in type 1 diabetes in children and young people over that short period of time. Majority of them presented in DKA. So the real question is, was this an acceleration of type 1 diabetes from the virus, from the immune response from the virus? Are we going to see a legacy of type 1 diabetes on the back of this? And I guess we don't know this, only time will tell, but I guess we're mindful that this may have had an effect overall on the rates of type 1 diabetes. This is my last slide now before we take questions. So new ways of working. We've learned a lot in the last almost 2 years. We've been working 7 days with specialist services. We know now how to rapidly discharge patients on insulin. We have virtual wards, okay, wards we cannot physically see. We have virtual wards, people at home in other care sectors, and we look after them. We know we have much closer, and we should continue to strive for much closer communication between community and hospital diabetes services. That's really, really important. In the UK, we had an exemplar of collaboration with industry. We had an industry-led dedicated telephone line to help manage people with insulin. This was funded and collaborated with by NHS England, Diabetes UK, and Novo Nordisk and Insulet. So industries coming together with NHS organizations to work together. I think we should be proud of that. Recovery of services and recovery of care, it's going to take time. We cannot do this overnight. It's going to take many months and arguably years to coming forward. However, the one thing that I think we've learned in the UK, we can work together. Professional bodies such as the Royal College, primary care bodies, specialist care bodies, and NHS England have really worked together, which is something I'm very proud of. Just to summarize, you've heard from me and others telling you people with diabetes have a high risk of severe disease and death, particularly people with high HbA1c, high BMI, reduced kidney function. Some of the acute presentations were really quite alarming and severe, something we've never seen before, and we've had people come together to develop guidance of how best to manage these. Really important that patients and clinicians know sick day rules with their medications, not just when you should prescribe a medication, but when you should temporarily stop that medication. It's very, very important. And we all need to work together, okay, in what we call integrated care to help promote efficient services for our patients, not just what's best for the physician or that one patient. Community, we need to look after communities and populations. So for them to have the best experience, but also for them to have the best outcomes. And for that, I'd like to thank you for your attention. I'm very happy to take questions with Dr. Banerjee.
Thank you very much, Dr. Patel, for a very comprehensive coverage. Just before we start on any other questions, I think there's a question to show the slide of virtual consultations. You could go back and share the slide of that one. That would be great.
Virtual consultations. Let's see if I can find that particular slide. I think it might be this one. And let's see if I can share that. Okay, let's go with. Okay, just give me 1 second. Hopefully you'll see. Was that the right slide?
Dr. Kantipuri, could you just let us know by coming on the mic, please?
Again, I'm very happy to share this slide if that's of interest to delegates in terms of some of the details regarding what we thought in NHS London, who should be seen face-to-face, who should be virtually. I'm very happy to share them.
Yeah, that's the slide that Dr. Kantipuri was asking for.
Yep, very happy to share.
No other questions in the question box at the moment, but I would ask.
For you, Dr. Molinat, if you don't mind.
No, there's one question. Yes, because Dr. Patel was still there. Okay, fine. I'll take that question. Is regarding vaccines, that some vaccines had produced antibodies in hundreds and others in thousands. Does this make one superior over the other, or is it qualitative rather than quantitative? Now, I think the main emphasis of that is to compare Moderna versus the Pfizer vaccine, both of them being mRNA vaccines, and Moderna vaccine had a higher concentration of mRNA, and hence the dose, the inoculate, was much higher. It wasn't surprising, it produced a higher level of antibody response. Now, what we have seen is that the protection rate between Moderna and Pfizer is almost similar in the in the 90s. Now, whether that high, sort of 10 times higher amount of antibody presence affects the immunity or is better or not, we don't know. But we are actually at the top of the curve with both of the vaccines, and hence the protection is almost similar. Hence, it's still an open question because, as I say, is that it's only 2 years that we have had this disease, and the vaccines are about just 1 year plus that we have been using. But there hasn't been any difference in the protection rate that we've seen between the two vaccines at the moment. Okay, there's another question. Would you recommend second or third booster doses of COVID vaccine for diabetics or patients with chronic disease in the next winter? This is a policy decision. If you ask my personal opinion, what we have seen is that 100 years ago, we had the flu pandemic. And since then, we have been changing the flu viruses regularly, almost on an annual basis worldwide. And with that, we have been able to prevent flu-related death in thousands, if not in millions worldwide. Now, if you ask my opinion, and I'm not a policymaker, I would definitely say that this needs to be given regularly. Because what we know very much is that if people have not been vaccinated, the risk for them to have a severe disease is much higher. Now, when the vaccination, when we're talking about the third wave in the UK, and believe me, I practice in Greater Manchester, and that was one of the worst affected areas in the whole country. At one point of time, 95% of patients who were admitted to our intensive care were unvaccinated people. Yes, we have got vaccine deniers. We have got real skeptics about vaccines here. And this was something which was really, really scary. Vaccine does not give you absolute protection. There's no question about it. There are vaccine failures as well. But if you look at the population dynamics, if you're protecting the whole population overall, we have good evidence that people get less sick, means they actually are harboring less virus in themselves, and hence, and that's reflected onto the transmissibility into the population as well. within the family, within your own society, that transmissibility goes down. If that goes down, the overall inoculum for each and every other person is less, and that reduces the severity overall. And hence, I'm a very big protagonist of vaccination. You can very well know, or you can see. But that is something that needs to be thought through, is that it actually protects, and there's good evidence and good data about that as well.
And just to echo that, Mulinaf, is certainly with the recent wave with Omicron, certainly in my London hospital, 90% plus of people in intensive care actually were unvaccinated or certainly had less than 2 or 3 doses of the vaccination. So inadequately vaccinated, I would say, the vast majority. And that tells you something, doesn't it, in terms of the efficacy of the vaccination.
Absolutely.
Also, Dr. Molina, they're asking you as well, which vaccine would you suggest for type 1 diabetes, patients with type 1 diabetes?
Okay, again, a policy decision. It depends from country to country regarding what's being available. All the vaccines that we have seen till now, they are almost equally efficacious. As mentioned in my talk, that the efficacy varies between 76% to 95%. It's a wide range, but if you look at the WHO's vaccination policy, any vaccine which gives more than 50% coverage or 50% protection actually can be licensed to be used. Comparing that, what we are seeing here, all the vaccines that we have got, is at least 1.5 times to almost double that rate that WHO suggests. So all the vaccines are really, really good regarding the efficacy from the WHO benchmarking point of view. There isn't anything that we can select. It depends on the individual, their age, their gender, and also their risk factors. Because like the AstraZeneca vaccine in the UK is not advised for people under the age of 30, while above the age of 30, it can be either vaccine, Pfizer or Moderna or AstraZeneca. So it isn't anything that we can select, but again, from person to person, it can vary. Right, there's another question. Is it true that Omicron escapes natural and vaccine immunity? Not really. The main thing, I had actually excluded one of the slides regarding the origin of all the variants that we have seen, just to make sure that we were careful regarding the time. It doesn't, because what we have seen is that, yes, there has been increased incidence of Omicron as a second infection, despite somebody having a previous one. And I was one of them. I had last June, and I had again in this January. And the symptoms were very similar to what we were getting from Omicron. But what we have seen is that by this time, we had vaccinated a vast majority of the population as well. And hence the effect of the Omicron infection was much, much less. So it's unlikely that it escapes. It can have a second, it definitely can infect, but again, there is a protection, and we have seen that the hospital admission and ITU admissions were far less than what we had actually were worried about with the Omicron variant than what we had seen with the Delta variant before.
Thank you, Dr. Batil and Dr. Molina, for really interesting, and Dr. Omar, it's really impressive. And I think this topic, it needs a single conference, not only session. In reality, because we will ask you now, just because we are closing, before doing a closing ceremony, I would ask you, all of you, to open your camera so we can get one photo for the available faculty. Dr. Muhammad is there. Before doing a closing.
Is Dr. Asad, while people are getting on their cameras, what I can say is that when we're talking about the topics a few months ago, I didn't realize that it's going to explode in such a massive discussion overall worldwide regarding vaccination and COVID. But nice fun.
Dr. Omar, yes. Dr. Depesh. Okay, done. Thank you. So now we will give that mic to Dr. Iman and Dr. Muhammad to do closing ceremony.
First of all, I would like to
Thank you, Dr. Asad. And first of all, I would like to thank the Dr. Asad and Dr. Abdul Wahab for giving me this opportunity to organize the fifth IMDO conference with all the committee members, and sure all the team, Dr. Iman and Ahmed, Dr. Fatima, Dr. Madiha, who's spending these 3 days behind the screen to monitoring all the activities and to organize the sequence of the lectures. It's a hard work, but they are doing it in the right way and smooth way also. They not make any pressure on all the speakers, and they're following also the request of all the audience and companies who's behind their screen to monitor and to get the best quality of virtual conference. Today we are reaching the end, and I think as before, it is a successful event. All the lectures was very scientific and informative, and I think a lot of information was spread from the speaker to all audience. Thanks for all the speakers, and I will leave now the talk to Dr. Iman. Dr. Iman.
Yes. Hello everybody, and thank you for such a wonderful 3 days. They were really fully packed with a lot of information, and I think from the comments of our delegates and attendees, we can know that they're really happy with all the knowledge that they have received, all the up-to-date guidelines and practices that were mentioned in the lectures. Let me give you now some numbers. Ahmed will share with us what has been happening over the 3 days of the conference. Of course, I would repeat again, like Dr. Muhammad Salman mentioned, that was great that we had the patronage of His Excellency Sheikh Mohammed bin Abdullah Al Khalifa. He's always supporting us for the past 5 years, which was great. I will not forget also Dr. Abdul Wahab, Muhammad Abdul Wahab, who's the conference chairman. He's always has been supportive to both the scientific and organizing committee, and he's the backbone for us. Definitely Dr. Asad, Dr. Muhammad, scientific, the co-chairmans of the scientific committee, Dr. Asad and Dr. Muhammad, the chairman of the organizing committee. Big thanks to Dr. Mariam Al-Hajiri, the deputy in charge for the Bahrain Diabetic Society, along with Dr. Dalal Al-Rumehi for organizing the IDF MENA session. That was great. We enjoyed the 6 or 7 speakers from all over the world that they have joined us with their information. That was really a good addition to the IMDO conference. And some numbers for you, statistics. Over the 3 days, we had 55 plus speakers, 54 plus lectures. Actually, we had attendees attending around 850, but mostly like we had an average of 350 to 400 live attendees on and off. That was a really good number, and we really appreciate their commitment to the IMDO conference. And we had speakers from many nationalities. We are proud to have them over and over in our IMDO conference. Of course, we are not going to forget our sponsors, Novo Nordisk, AstraZeneca, Abbott, and Boehringer, who have sponsored some of the speakers of the 3 days session. And I would say a big thanks to the devoted attendees who over and over the years, they continue to attend the IMDO conference, and they are always really religiously, they follow the IMDO conference, and they benefit during this time.
Thank you for all of you. I would like also to give chance to Ahmed He's the one who also in the team, if he's available. Ahmed?
Yeah.
Yes, Ahmed,
It's my
thank
pleasure,
you.
Dr. Asad, always to be a part of the fifth generation of IMDO, and looking forward to be a part in next IMDO 6, inshallah, to be in physical, and to welcome all our guest speaker and the scientific and the organizing committee. Inshallah, next year, IMDO 6, February 2023, inshallah. Thank you.
If there is no more comments.
Ahmed, Dr. Molinat is asking 850. Is this new for IMDO or it's been around this number in the previous IMDO? Yes.
850 is the registered number.
The latest registered number. Yes. It is the latest registered number.
Some people, they use the link for YouTube also. So this will be good.
We cannot hear you. Yes.
There is some delegates use the link through YouTube also, which is not possible to count. We give link to Egypt for Dr. Inas Sheltout. We are very thankful for Professor Sheltout, and we give the link to some delegates to share it with their team, like Bahrain Diabetes Society, and they are behind that YouTube, which was continuous broadcasting for the conference.
Dr. Asad, would you like to ask some of the attendees to join and open their camera for a photo group?
Is it possible?
All delegates, whoever wants to join in our photo group for MP5, just raise your hand and Mr. Ahmed will take you to the section. Dr. Asad, you're already included.
Yes, it's okay.
We're asking for the delegates.
Okay, I understand. But just to encourage people to join, try to raise their hands. Yes, even for you.
Also, all speakers and committee members, don't forget our gathering and gala dinner today at Kufia restaurant, 7 o'clock. It is in the Water Garden. So all who's in Bahrain, sure, not outside Bahrain, they cannot join us. There is only 20 minutes remaining.
We should expand the screen. I cannot see the. Yes, okay.
We have 13 raised hands. Mr. Ahmed, can you see? Okay, you can.
I just promote them, the panelists, they should accept the invitation.
Okay. Okay, our dear guests who have raised their hands, you have now the opportunity to open your cameras with us. Dr. Emil Hanna, you can open your camera if you don't mind. Please, dear delegates, we're giving you the chance to open your camera, so please do that. Dr. Ghazi, you want to open your camera, please? Whoever is now in the panel list, please open your cameras. We are entering more people to join us and the group photo.
It's difficult to open the camera. But
I think Ms. Nagam, you can.
the host is
Dr. Asad, please just lower your hand if you don't mind.
Yes, sure.
Dr. Iman, you skip the camera.
Yalla, we'll try. Mr. Ahmad. We'll open it, Dr. Ghazi. Yalla. Yes, Dr. Ghazi, you're clear.
Thank you.
Dr. Debesh Batil, yeah.
Please, everybody get ready on the count of Mr. Ahmad. He will take the screenshot. Thank you all.
Okay, Ahmed, thank you for all of you.
Okay.
Thank you all, dear delegates and speakers and committee members. Inshallah, see you next February for IMDO 6.
Bye-bye.
Bye-bye.
All the best.
إن شاء الله بالتوفيق إن شاء الله السنة الجاية.
أهلا وسهلا.
مستر ممدوح والجماعة كلهم. Great job. Thank you very much.
هلا دكتور غازي.
الله يعافيك.